conceptualizing this program, and faculty from all over India who are eminent faculty. They put in a lot of hard work for preparing the live discussions, cases, and put in there, given your inputs. We have senior faculty like Dr. C.K. Dua, who was my teacher, my mentor in my postgraduate days. You will learn from her experience. We have included them as part of our mentors, part of our moderators or chairpersons of the program. Besides this, from south, from east, from west, everywhere we have faculty who will be contributing to great knowledge, and in very, very learned experience. We will learn from them significantly. This program, we have 7 days of learning, and each day, for all practical purposes, we divide to a particular day. There will be airway related lectures on some days, then there will be breathing related lectures on some days, then circulation, then your critical care. Like that, we have divided each day so that you can connect it better. Each day will give you a comprehensive learning. And even after the day finishes, you will have access to the videos, so that if you cannot join during your working hours, you will be able to see them and learn from them. This program was started in 2021 by our HOD at that time, Dr. Mohandeep Kaur. She's with us, still working with us in our department. So I would like Dr. Mohandeep Kaur to address you all before we proceed further. Dr. Mohandeep Kaur, please.
Very good morning to everybody, and thank you, Dr. Nirja, for giving me this opportunity to speak again on this platform of Appec 25. I welcome Dr. Dua ma'am, and she is such an asset. Whenever there is a call, she is always there. And as Dr. Nirja has said, this program was designed to, conceptualize reaching virtually the farther corners of India, where, our students do not get access to this teaching material. And, when, we are in the States, we always see Delhi as the iconic thing, and we feel that teaching in Delhi is the standard. However, just to reach out to all those farthest places, we have conceptualized this virtual program, and it was found to be a great success. Since 21, we are holding it every year, and people are waiting for it to happen. And they are before the dates are announced, we have a lot of queries, as Dr. Nija must have got, that when are we starting Appec? So, this is keeping the interest of the students who have to learn from not only from Delhi, but from all the states. We are here with the rich materials for you, and the cross-section of the examination will be totally covered in this program. That is what it was meant to be. Like, we have case discussions, long cases, short cases, then your Viva kind of table, Vivas, wherein you have to have, deal with the drugs, then X-rays, CPR, everything, is tried to be covered. The sky is the limit as far as the curriculum is concerned, but I'm sure if some participant has gone through these 7 days extensively, you will go a lot into faring well in your exam. So with the best wishes, and thank you, Dr. Nija, and the entire faculty of RML Hospital for, this carrying out this Appec every year. I hope this has continued. People go, but there's kind of the standards that are set. They stay in the department, and I wish that RML always is faring well and is shining, all over India, and is for which I have my best wishes to offer to everybody. Thank you, and please stick through the program. All the participants should just stick through the program. If whatever, time they are missing, they have the links available and they can go through it. And that's my best wishes for the program. And thank you so much, Dr. Nija and the organizers. Thank you.
Thank you, Dr. Mdikar, for your kind words and for your very encouraging words. The torch was lit during her tenure, and we are carrying forward that light. And we hope to continue it further for many, many more years. Now, I would like to invite our Dean of Guru Gobind Singh University, Dr. Vandana Talwar. She is an anesthetist and she was a medical superintendent earlier of Safdarjung Hospital. So a warm welcome to you, ma'am, and would like to hear some encouraging words from you. Over to you, ma'am.
A very good morning to all the faculty, organizers and students attending the Appec 2025, that is the Anesthesia Postgraduate Pre-Examination course organized by ABVIMS and Dr. RML Hospital, one of the most prestigious medical colleges under the Guru Gobind Singh Indraprasth University. The Appec was conceptualized in 2021, which was during the period of COVID, and at that time virtual teaching and learning was the need of the hour. Since then, it's become an important academic platform for exam-going postgraduates in anesthesia across the country. It is a vibrant national forum bringing together MD and DNB students along with an inspiring panel of teachers and mentors from leading institutes in the country. I, being an anesthesiologist, have been a part of Appec from the beginning, and I can assure you that it will provide an interactive clinical learning along with case discussions, both short cases, long cases, table vivas, and prepare you for all eventualities in the exam. I believe in the last 2.5 years, you've gone through your clinical postings, your emergency OTs, elective OTs, you've done classroom teaching as well, and now it's the time to combine or amalgamate both theory and practical. So this week, you will get consolidated learning. Hopefully, you'll have clearer concepts and be able to integrate and apply that information, both for the purpose of academics, your exams, as well as for clinical situations. Now that you've entered this profession, it's going to be a lifelong learning. So I urge you all to be regular with your reading, revising, and discussions. At this postgraduate forum, I hope you will get to organize and assimilate the information, you will gain knowledge, and you will get the confidence to appear in the exams. I'd like to congratulate the Department of Anesthesia at RML Hospital for organizing yet again this academic feast, and my best wishes to all the postgraduates who are attending the Appec 2025 for doing wonderfully well in the exams and for an excellent career in anesthesia. Thank you very much.
Thank you, ma'am. We have had the privilege of including ma'am as part of Appec faculty when we had started it, and she has been with us for 3 courses, and we are privileged to have her with us on this course also. Thank you, ma'am, for your blessings. And with this, I hand over to Dr. Jyoti for starting the first session.
Thank you, ma'am. To our respected head of the department, Dr. Neecha, madam, Dr. M.D. Kaur, ma'am, and our esteemed Dean, Indraprasth University, for their inspiring words and constant encouragement. With their blessings and guidance, now we move forward to begin our academic program. Let us commence today's session with enthusiasm and a shared commitment to learning and excellence. The moderator for the first session on oxygen therapy, pulmonary function test, and ASA physical status are Dr. C.K. Dua, ma'am. Ma'am was ex-director and professor, HOD, director, professor, and HOD in Department of Anesthesia at Maulana Azad Medical College and Santosh Medical College. Ma'am has various achievements, but she only mentioned few. So ma'am was president of ISA Delhi branch, Delhi State Award for meritorious studies and area of interest. Ma'am's areas of interest are airway and resuscitation, pediatric and obstetric anesthesia, teaching and training. Welcome, ma'am. The other co-chairperson or the co-moderator for the session is Dr. Nihar Nalini Madam. It's like, ma'am is professor and head of the department at PGIMR and Capital Hospital, Bhubaneswar. Ma'am is affiliated to the Odisha University of Health Sciences, and ma'am has various achievements, research articles in national and international journals, and co-author of a medical book, and faculty speaker in national and CME programs. Ma'am is also a mentor for PG students, and ma'am's area of interest are pediatric anesthesia and obstetric anesthesia. We welcome you, ma'am. Ma'am was with us also for a longer duration. We welcome you, ma'am. Over to you, ma'am.
Shall we start it? Good
Yes, ma'am.
morning.
Yes, sir.
Shall we start it, Jyoti?
Yes, ma'am. We can start, ma'am.
Okay. Good morning, Dr. Nilja Banerjee, Dr. Jyoti, Dr. Mohandeep, and all the other members of the organizing team, the participating faculty, and our dear participants. This is a very good morning, and we are starting. I have the opportunity to start the first session of the first day. I take this opportunity to thank Dr. Nilja Banerjee and her team for having invited me to be part of this academic deliberations, which is a 7 days extensive and highly useful course for the exam going students of doing post-graduation in anesthesia. And I would like to congratulate Dr. Nilja, Dr. Mohandeep, and all the members of the organizing team for this wonderful postgraduate program. And it will be a great success, and it has been very helpful and very popular since it has started. So let us start with the session. And I will request Dr. Jyoti to please show me the slide of the first speaker.
Yes, ma'am. Yes, ma'am.
Our first speaker is Dr. Aanchal Kakkar. She is the professor at RML Hospital. Her achievements are she is an ATLS instructor, BCLS and CCLS instructor, and associate dean in the academics. Her special areas of interest are laparoscopic surgery, trauma and resuscitation, obstetric anesthesia, and pediatric anesthesia. She is going to deliver a talk on oxygen therapy. And as we all know, this is also a very important aspect of patient care. And let us see how Dr. Aanchal Kakkar is going to give her the talk for our exam going postgraduate students. Dr. Aanchal, please start your presentation.
Good morning, everyone, and welcome to Appec 2025. I am Dr. Aanchal Kakkar. I am professor in the Department of Anesthesia at APVIMS RML Hospital, and I will be talking about oxygen therapy. Oxygen therapy is the most important and very basic of anesthesia training. So, in my talk, I shall be talking about the oxygen transport system from air to the tissue. How oxygen is transported. Then we will be talking about the oxygen hemoglobin dissociation curve, the indications of oxygen therapy, and various equipment used for oxygen therapy. So if we talk about the layman, we inhale air, oxygen is taken up, travels through the blood, reaches the tissue, utilized and transported back as carbon dioxide into the lungs and exhaled out. So this journey of oxygen, how does it actually happen? So it is described in the form of oxygen cascade from atmospheric air to the mitochondria. And if you see, this is a most commonly presented as a step ladder or in a flow chart. This step ladder, it starts from the atmospheric air with the partial pressure of oxygen at 159 millimeters of mercury, goes down to airways, then alveolar gas exchange, then the arterial blood, then it goes to the tissue, then it reaches the mitochondria. From 159, at every step, some of the oxygen is lost or utilized, and at the tissue level, it is 7 to 37 millimeters of mercury. So we will be talking about each step. To start with, atmospheric air at the sea level, the barometric pressure is 760 millimeters of mercury and water vapor pressure is 3.7 millimeters of mercury. So if we subtract that from the 760 and then we multiply it by 0.21, that is the 21% of oxygen which is present in the atmospheric air, the partial pressure of inspired oxygen at the sea level comes at 159 millimeters of mercury. So at higher levels where the barometric pressures are low, what happens to the inspired oxygen partial pressure? It decreases. Okay, from 760, it falls down to 250, 260 of barometric pressure. So automatically 21% of 250 is less than the 21% of 760 millimeters of mercury. Hence, at higher altitude, the inspiratory partial pressure of oxygen decreases. So next, where does it go? When we inhale, it goes into the respiratory tract. Our respiratory tract has a mucosal lining which humidifies the inhaled gases. So with each breath, the water vapors are added, and at the human temperature, that is 37 degrees, the partial pressure of oxygen, it increases to 47 millimeters of mercury. And if you subtract that and multiply it by 0.21, it comes as 150 millimeters of mercury. Then from lower respiratory tract, where does it go? The gases go into the alveoli. So when the inspired gases reach the alveoli are already having the residual gases of previous breath. So oxygen is utilized, carbon dioxide is added, the partial pressure of oxygen at alveolar level, it comes at inspiratory oxygen, a partial pressure of inspiratory oxygen minus PaCO2 divided by RQ. RQ, what is RQ? RQ is the respiratory quotient, which is 0.8 to 1. So it comes out to 104. So from lower respiratory tract, 150, it comes down to 104. From alveolar, where do the gases go? The oxygen is taken up by the arterial blood. So arterial pressure of oxygen is written as PaO2, which is 100 millimeters of mercury. Usually in ideal scenario, there should not be any kind of gradient between the alveolar and arterial oxygen content. But because of the presence of venous admixtures, which are the true shunts also and some abnormal shunts, if the patient is diseased, is having some specific problem, then the abnormal shunts will be there. There will be a VQ quotient mismatch will be there. But normally also venous admixtures are there in the forms of pulmonary veins and extrapulmonary veins, which do not carry the oxygenated blood, and they usually amount to 5% of our cardiac output. So the AA gradient, the alveolar arterial gradient, is 4 to 25 millimeters of mercury. This is a wide range. Why? Because it is usually 4 to 25 with, it is influenced by the age. It increases by 3 millimeters of mercury in every decade. So from arterial blood, then it is used by the perfusion happens. It is utilized by the tissues and the mitochondrial levels when the partial pressure of the oxygen decreases to 7 to 37 millimeters of mercury, and is again taken up in the mixed venous blood, where the partial pressure of mixed venous blood is 40 millimeters of mercury and corresponds to 75% of saturation. So let's see with the mitochondrial 7 to 37 millimeters of mercury, there is a critical point of 1 to 2 millimeters of mercury of partial pressure of oxygen in mitochondria, beyond which the aerobic metabolism does not occur. So this critical level of partial pressure of oxygen below which aerobic metabolism does not occur is also known as Pasteur's point. So let's see how the oxygen is transported in the blood. It is transported in two forms, the hemoglobin and the dissolved. The hemoglobin, oxygen binds to the hemoglobin, that is 97% of the oxygen is transported as a oxyhemoglobin. This is depicted by the sigmoid shape or the S-shaped graph, which is commonly known as oxygen dissociation curve. 1 gram of hemoglobin combines with 1.34 ml of oxygen. You must remember this. Rest of the 3% of the oxygen, it is carried as a dissolved form of oxygen in the plasma. So it is 0.003 ml of oxygen per 100 ml per millimeters of mercury at 37 degrees. Okay, so it comes as 0.3 ml of oxygen per 100 ml of plasma at PaO2, partial pressure of oxygen of 100 millimeters of mercury. Okay, so when we check the saturation of a patient, we are checking the oxygen bound to hemoglobin. But whereas when we check the arterial blood, PaO2, partial pressure of oxygen, then we are checking the dissolved plasma of the patient. Okay. So if we talk about the dissolved plasma, how can we, what is the law followed? It is the Henry's law. The gas concentration is equal to the gas solubility coefficient multiplied by the partial pressure of gas. So in this scenario, the gas is oxygen. So solubility coefficient of oxygen at human temperature 37 degrees is 0.003 ml per deciliter or per millimeters of mercury. So at 100 ml partial pressure of oxygen, it is 0.3 ml per deciliter. So for PaO2 partial pressure of oxygen at 100 millimeters of mercury, the dissolved oxygen in plasma is 0.3 ml per deciliter. So this is the oxygen dissociation curve which we were talking. If you see the x-axis, it denotes the partial pressure of oxygen, and on the y-axis, the vertical is the saturation. So it's a sigmoid shape, S-shaped curve. There is a steep increase and then there is a plateau. The increase is very less. So what is this point? It is the partial pressure of oxygen of 60 millimeters of mercury, which corresponds to the 90% of the saturation. So how do we actually, what do you mean by partial pressure of oxygen in 60 millimeters of, below 60 millimeters of mercury partial pressure, we define it as hypoxia. Okay, so 60 millimeters of mercury defines that 90% of saturation. When PaO2, partial pressure of oxygen, increases beyond 60 millimeters of mercury, the saturation increases from 90 to 100 very slowly, steadily. So that 93-94% also we are happy with it. Okay, if you see 90 millimeters of mercury, it corresponds to approximately 98% of saturation. So when PaO2 falls from 60 to less, then see the steep fall in the saturation also. Okay, so this is the how you depict oxygen dissociation curve. Another point which is very important is the point where the 50% of the hemoglobin is saturated. Okay, with the this is known as P50. 50% of hemoglobin is saturated, it corresponds to the saturation of 50% and partial pressure of oxygen of 27 millimeters of mercury. All right. So this S-shaped curve, it can shift to right or left. Okay. So increase with the this P50, it increases with the rightward shift of the oxygen dissociation curve and it decreases with the leftward. What do you mean by rightward shift? Rightward shift means there is decreased affinity to oxygen. The hemoglobin has a decreased affinity towards oxygen, so it readily loses oxygen to the tissue, whereas in the leftward, it has a higher affinity. So rightward shift is caused by acidemia, high temperature, increased 2,3 dpg, increased CO2. Leftward is opposite, that is alkalemia, low temperature, decreased CO2 and decreased 2,3 dpg. So now let's talk about the content of oxygen in the arterial blood. These are certain things which you must know. How much oxygen is there in our arterial blood? So we know how it is carried. So we add both the things, oxyhemoglobin and the dissolved hemoglobin. How do we, what is the formula? 1.34, we know that 1.34 ml is carried by each gram of hemoglobin. So 1.34 into hemoglobin into the saturation, plus this is the oxygen of the hemoglobin bound oxygen. To this you add the dissolved, which is the partial pressure of oxygen multiplied by 0.003. So saturation is never expressed in percentage in this formula. You always write it as a decimal. Putting in the values of HB as 15, saturation at 98.98, PaO2 of 90, we get 20 ml of oxygen per deciliter of blood. If you want to convert it to liters, then 200 ml per liter of the blood carried, 200 ml of oxygen is carried by per liter of blood. Okay, so this is the content of oxygen in the arterial blood. So similarly, when we talk about the content, now there is a very common question asked: is anemia more harmful or is hypoxemia more harmful? So now we know the formula of oxygen content in the arterial blood. Now, in case of anemia, you replace the hemoglobin of 15 with 7.5, and saturation remains the same. Partial pressure of oxygen remains the same. So only this is reduced by the 50%, which causes the reduction of content of oxygen in arterial blood by 50%. So from 20, it becomes 10 ml per deciliter. Whereas in hypoxemia, the partial pressure of oxygen decreases. So it falls below 60, let's take it 50 millimeters of mercury. Okay. So from 100 hota hai, normally we decrease it by 50%. So take it as 50 millimeters of mercury. Corresponding saturation on oxygen dissociation curve is 78%. So we put in the values 1.34 into 15 into 0.78 plus 0.003 into 50. How much is the fall? The fall is only by 20%. That is 16 ml per deciliter of oxygen is carried by the arterial blood in hypoxia patient. So you must realize that anemia has a much greater influence on the content of oxygen in the arterial blood in hypoxemia. So after talking about content of oxygen in arterial blood, what is the content of oxygen in venous blood? We simply, from saturation of arterial blood, we make it saturation of venous blood, which is 75%, and partial pressure of venous blood, which is 40 millimeters of mercury. Putting in the values, what do we get? We get 15 ml per deciliter. So what is the difference of oxygen content in arterial and venous? It is 5 ml per deciliter or 50 milliliters per liter. Okay, so next is the delivery of oxygen, or also known as oxygen flux. It is the amount of oxygen leaving the left ventricle per minute, and it is the amount which is delivered to the tissues per minute. Okay, it is denoted by DO2. So when we talk about per minute, then we talk about the cardiac output. So it is cardiac output into the content of oxygen in arterial blood multiplied by 10. This multiplier of 10 is to convert the ml per dl to ml per liter. So putting in the values, what do we get? We get 5 into 20 into 10, that is 1000 ml per minute. So next is the delivery of this oxygen. There are multiple factors. If you can see, there are multiple factors: cardiac output, then hemoglobin, saturation, partial pressure of oxygen. These are all the factors on which the delivery of oxygen is dependent. Next terminology which you should know is oxygen uptake. It is denoted by VO2. What is it? It is the rate of oxygen transported from systemic capillaries to the tissues. Okay, it is also a measure of oxygen consumption. So consumption, that means difference of content of arterial to venous. So cardiac output multiplied by CaO2 minus CdO2 into 10. This 10 is again the multiplier used to convert ml per deciliter to ml per liter. So if you see this equation, this is the reverse of fixed method. What is fixed method? Fixed method is the equation to calculate cardiac output. You have just reversed it to calculate the oxygen uptake or oxygen consumption. When we put in the values, we get 200 to 300 ml per minute, or if you put the body surface area, then it is 110 to 160 ml per minute per meter square. So generally, if we put, see, cardiac output is 5 liters per minute. The difference is again 5 ml per deciliter multiplied by 10. So the oxygen extracted from the capillary blood would be 5 into 50, okay, that is 250 ml per minute. So 5 into 5 into 10, that becomes 250 milliliters per minute. This is what is the normal oxygen consumption in an adult person at rest. So this is how you calculate what is the consumption of oxygen at rest in an adult person. Okay, you must know this. Coming on to the indications of oxygen therapy, there are multiple indications. One of them is hypoxia. Hypoxemia, it is defined as partial pressure of oxygen less than 60 millimeters of mercury or saturation less than 90%. In neonates, it is defined as PaO2 less than 50 millimeters of mercury and saturation less than 88%. Other indications are, there are various kind of poisonings which require oxygen therapy. There are situations where you suspect hypoxemia, where you want to decrease the work of breathing, you want to decrease the myocardial load of oxygen. Then there in anesthesia, we do pre-oxygenation to build up oxygen reserves. We do para-oxygenation to avoid fall in saturation while performing various procedures. Then you give oxygen for nebulization. You give oxygen to reduce myocardial work before heart surgeries, during exercise in certain patients. Then you also give oxygen in anemia. You give oxygen in post-operative period as well. So how do you give oxygen? There are various equipments which we are aware of. When you are asked to describe an equipment of oxygen therapy, you first identify it, then you classify it as low or high flow. You further classify it as fixed performance device or a variable performance device. You then classify it on the basis of the reservoir which is present or not, and brief description of the device. Okay. So next is the low flow system. Low flow system devices are generally variable performance and they're dependent on the patient. High flow systems they are fixed performance and they are independent of the patient's efforts. Low flow system, what is low flow? Basically the total gas flow is less than the patient's inspiratory flow rate. And it leads to sometimes air entrainment and variable performance is there. You cannot fix the FiO2, a range may be present. And there are factors which determine the FiO2. Which factors? There are equipment related factors, the type of equipment which you are using, how much FiO2 can be delivered, oxygen flow rate, how much you are giving, volume of the mask and volume of the reservoir. There are patient factors then, respiratory rate, inspiratory flow rate, tidal volume and the anatomical reserve of the patient. High flow system, these are the systems in which the total gas flow meets the patient's inspiratory flow or exceeds the patient's inspiratory flow. They are fixed performance. They deliver the precise FiO2 which you set them on, and they virtually eliminate the rebreathing. How do they do that? They create a constant proportion of air-oxygen mixture. Okay, so there's a constant proportion of air-oxygen mixture in the excess of patient's inspiratory flow rate. And the FiO2 which you deliver through the high flow system is directly proportional to the size of jet orifice of the gas, that is oxygen, and inversely proportional to the size of entrainment ports. Okay. So FiO2 is independent of the flow meter setting and the patient, it is independent of the patient factors. So to start with, first equipment on the screen is nasopharyngeal oxygen catheter. It's a plain simple catheter having multiple distal holes and atraumatic polyester foam to fix the length of the nasopharyngeal oxygen catheter which is inside the patient, and there's a proximal conical connector to connect oxygen. So it's a low flow variable performing device. There's no capacity, there's no reservoir here. It creates an anatomical reservoir in the oropharynx of the patient. How much do you insert? You measure the distance from the LA nasi to the trachea. Next is the nasal cannula, binasal cannula, you can say, or nasal prongs. So various parts are, these are the prongs. This is the adjustable strap, which either rests beyond your head, beyond the patient's head, or beneath the chin. Okay, like this. So it is also a low flow variable performance device. It creates an anatomical reserve in the nasopharynx. Okay, it's an ideal choice for the home-based oxygen therapy. So factors determining oxygen FiO2 is flow rate. How much flow rate do you give? How much is the peak inspiratory flow rate of patient? And what is the volume of nasopharynx? Okay. So maximum FiO2 which you can deliver is 0.4%, that is 40%. Advantage, it is easy to use. Disadvantage is you cannot use it, there is nasal surgery. So if we see with each 1 liter of increase in the flow rate, there is an increase of 4% of FiO2. Okay, and normally you do not use it beyond the 5 liters. Why do you not use it more than 5 liters of flow? Because higher flow rates do not generally increase the FiO2 much. Rather, they cause a lot of drying and irritation of the nasal mucosa, and patient discomfort increases. Patient becomes non-compliant to the oxygen therapy. Next is this mask. It's a common face mask, also known as shell type face mask. What are the parts? These are the holes on the each side holes you can see. So air entrainment during inspiration. Okay, what are these holes used for? Air entrainment, some kind of air entrainment. Usually these are used as the ports to for the passage of exhaled gases. Okay, so this is the part where oxygen is connected. So oxygen gets collected in the apparatus dead space. This is the dead space of the patient. When the patient expires, the exhalation of the gases occurs through these holes. During that time, the oxygen goes inside and it fills this dead space, so that whenever the patient takes the next breath, he or she inhales 100% maximum quantity of oxygen. This is this adjustable strap. So this shell type of face mask is also known as Hudson type face mask. It's a low flow variable performing device. The capacity or the dead space of the mask is 70 to 100 ml for pediatric patients, pediatric mask, and for adult it is 100 to 250 ml. So to for how much flow is required to fill in this dead space with oxygen is minimum of 5 liters of oxygen flow. Okay, so factors that determine the FiO2, again, you know, patient's inspiratory flow rate you have put in. Okay, maximum FiO2 which you can deliver is not beyond 60%. Small holes we know are used for exhalation, and minimum flow rate required to prevent rebreathing is 5 liters. Okay, 5 liters is minimum. So this is the table which tells you when you give it at 5 liters, 35% is there. When you give 6 to 7, 40%, 7 to 8, 50%, and 8 to 10 liters is 60% of FiO2. Not beyond 60% is delivered via shell type. Next is this variant. This is the nebulizer or aerosol mask. Look at the holes. They are now big holes. Okay, this tubing is also wide bore tubing, and this is the nebulization chamber where the medication is put. Oxygen is delivered through this. It causes aerosolization, and patient inhales the medication. It's a low flow variable performance device. Large bore tubing is there. Large bores for exhalation is there. Nebulization causes a lot of noise. Okay, so humidified oxygen is delivered through this mask. Coming on to this mask, this is the Venturi mask. We all are using it. So what are the parts? This is the exhalation port, Venturi barrel, adjustable strap. This is the air entrainment port. This is the oxygen jet port. So what type of device is this? This is a high flow fixed performance device. It is also known as HAFOE, that is high airflow oxygen enrichment system. It delivers the precise FiO2 whichever you set on it. So how does it do? It creates a constant. I have already explained. High flow equipment, they create a constant proportion of air oxygen mixture in excess to the patient's inspiratory flow rate. So this is the Venturi valve, which is there, single valve, which has an adjustable valve for FiO2, delivering various type of FiO2. Other than this, there are multiple valves now, interchangeable Venturi valves. These are color coded. Now, color coding is not very strict. What you have a percentage of FiO2 written on it. How much flow is required, that is also. So if you can see, this is 24% of FiO2 at 2 liters per minute, 28 at 4 liters per minute, 31 at 6, and 35% at 8, and 40% 10 liters. So these are interchangeable. So what is the principle of Venturi mass? It is based on the Bernoulli's principle, which is applied to both liquids and gases. For our purpose, we will talk about gases. It's a relationship between the velocity and pressure. Okay, so when the gas is flowing through and the path is then constricted, the velocity increases through the constricted part of the jet. When the velocity increases, that is the kinetic energy increases, it has to be balanced by the decrease in the potential energy. So potential energy is the pressure. So around the jet, the pressure decreases and it sucks in the air from the ambient air. So entrainment of the gases occur. This can be more clear from this, or rather this. So this is our source of oxygen. This is the normal width. Then there's a constriction. Here the velocity increases. This increase in velocity causes decrease in the pressure and entrainment of the gases through the entrainment port. So again, I have already told you that FiO2 which you deliver through this high flow oxygen fixed performance devices, it is directly proportional to the size of jet orifice and inversely proportional to the size of entrainment ports. So if you are asked, if I decrease the size of jet orifice, the FiO2 will decrease. If I increase the size of jet orifice, the FiO2 will increase. If I decrease the size of entrainment port, the FiO2 will increase. And if I increase the size of entrainment port, the FiO2 will decrease, as it is inversely proportional. Next equipment, what is this? This is the high flow nasal cannula or heated humidified HFNC. Most of us have used it through COVID times, and now also we use it for various other purposes, for generating CPAP also in certain patients. So it's a high flow device. It uses up to 60 liters of oxygen per minute. It delivers almost 100% humidified oxygen, heated at the 37 degrees of temperature. Oxygen air blender in the HFNC, it generates up to FiO2 1, that is 100% FiO2 at 60 liters of oxygen flow. It is lightweight, it is portable, it has a flexible tubing. The nasal cannula are silicone and they are atraumatic, very soft and flexible. So next, what is this? This is oxygen mask with reservoir bag. So can you make out the difference between the two masks? This one does not have any valves, this one has valves. So what is this has only exhalation ports, this has exhalation valve as well as inspiratory valve. So these are high FiO2, low flow, variable performing devices. The bag, partial rebreathing face mask is the one which does not have any kind of valves. It delivers 40 to 70% of FiO2 at the flow rate of 6 to 10 liters of oxygen per minute. The non-rebreathing mask has valves and it delivers up to 70 to 90% of FiO2 at the flow rate of 12 to 15 liters per minute. So I've already explained partial rebreathing and non-rebreathing. Non-rebreathing has one inspiratory and two expiratory valves. So the working principle, what is the principle? Basically, it conserves oxygen. How does it conserve? You start the oxygen, you fill in the reservoir bag. The reservoir bag of partial rebreathing mask receives the fresh gas flow and exhaled gases also, because there is no valve. So the gases go into the bag also. So the oxygen concentration of exhaled gases combines with the fresh gas flow and allows for the lower flow rates and conserves oxygen. So, okay, so we know that our exhaled gases also have approximately 17% of oxygen. So along with the fresh gas flow, those gases are mixed and Partial rebreathing is there, but the oxygen conservation is also there in partial rebreathing mask with the reservoir bag. How much is the minimum flow rate which is required? For the bag to be inflated, 10 liters. Okay, standard. Whenever you are putting a mask with the reservoir bag, the flow rate should be at least 10 liters. Okay, so what is this? This is also an oxygen phase tent. It doesn't cover over the nose, it covers through the chin. It is convenient for delivering of oxygen, humidified oxygen. It fits under the chin, loosely covers the mouth and nose. FiO2 delivered is 28 to 40% at the flow rate of 8 to 12 liters per minute. What is this type of mask? It's a capno mask, or you can say oxygen mask with CO2 monitoring. This is the capno mask with mainstream of carbon dioxide monitoring, and this is with the side stream carbon dioxide monitoring. So conventional medium concentration oxygen mask sampling port. It has a sampling port which permits sampling of exhaled carbon dioxide, and it is used in the conscious sedation. What is this? This is the oxygen hood. It has a gas inlet. This is the neck. Okay, this is the oxygen. The under reservoir, it becomes oxygen enriched environment. It delivers FiO2 of 80 to 90% at the flow rate of 10 to 15 liters per minute. Oxygen enters through the hood and exhaled gases are passed through the neck of the hood. Next, we come to the hyperbaric oxygen therapy. This is a specialized oxygen therapy given at the atmospheric pressure greater than 1. In our hospital, we have a dedicated hyperbaric oxygen therapy unit, and we have treated multiple patients with this wonderful hyperbaric oxygen therapy. The amount, what does it work on? It works on the Henry's law. It increases the dissolved oxygen in the plasma, and it has physiological effect. It decreases the air bubble size. It causes hyperoxygenation of blood. It causes vasoconstriction, neovascularization. So various indications for hyperbaric oxygen therapy are decompression sickness, carbon monoxide poisoning, air or gas embolism, trauma, Clostridium gangrene, necrotizing soft tissue, non-healing wounds, then refractory osteomyelitis, radiation necrosis. This hyperbaric oxygen therapy also comes with a lot of complications. You can cause barotrauma, rupture of tympanic membrane, pneumothorax in COPD patients, oxygen toxicity, sudden decompression syndrome, then claustrophobia, and sometimes fire hazards are also there. So we have talked about a lot about oxygen therapy. Now, what if oxygen is given in a larger quantity? So it causes oxygen toxicity. So higher concentration of supplemental oxygen for long periods, especially 100% of oxygen therapy for more than 12 hours, it can bring about changes in the pulmonary system. And infants, the premature, especially premature infants and neonates who get 100% oxygen therapy for more than 2 to 3 hours are at a greater risk of developing retinopathy of prematurity. So there's a table which defines that if you give 100% of oxygen for 0 to 12 hours, the physiological response of pulmonary system is that tracheobronchitis may occur. Substernal discomfort in patients can also happen. 12 to 24 hours, there is decrease in vital capacity. 25 to 30 hours of 100% FiO2, decrease in lung compliance and increase in the alveolar arterial gradient. 30 to 72%, there is decreased diffusing capacity. So there are two effects which are commonly asked or described in oxygen therapy. One is Smith effect, which is the pulmonary toxicity, and the other one is Burt effect, which is the CNS toxicity. So prolonged exposure of high FiO2 at normal pressures, they lead to pulmonary changes. As I already described, the changes decrease in surfactant and intraalveolar edema, interstitial thickening, they all can lead to ARDS and later pulmonary interstitial fibrosis. The CNS toxicity generally occurs when there is exposure to hyperbaric therapy at very high partial pressure. So it starts with twitching of perioral or small hand muscles, then vasoconstriction leading to causing facial pallor, diaphragmatic twitching which causes cogwheel breathing, vertigo, nausea, seizures, convulsions, and neurogenic pulmonary edema. So my dear friends, don't forget that oxygen is also a drug. You prescribe it with a lot of caution, only in patients where it is absolutely indicated. Oxygen, we all know, is the most used and misused drug in our healthcare setup. So people say that people say that we cannot live without love, but I think oxygen is much more important. So I hope you have understood the concept of oxygen therapy. All the best and thank you.
Thank you, Dr. Anchal. It was a very nice presentation. To the point, all the theoretical aspects of oxygen delivery to the tissues, tissue oxygenation, and how the oxygen cascade and what is the oxygen reserves, everything has been taken up very nicely. And I think for the postgraduates, the way the equipment has been described, that is how usually the questions are asked in the examination to the students. And it's very simple if you just know that the various aspects of the oxygen equipment, whether they are low flow, high flow, variable performance, fixed performance, low capacity, no capacity, high capacity, or high flow oxygen systems. I would just like to add, she has rightly said that it is a drug and we are supposed to use it judiciously, although it's the mainstay of patient management. But still, another important aspect is that we have to be careful regarding when to give, what to give, how much to give. And if needed, high flows are required for acute cases, then we have to bring down the concentration to safe levels as early as possible. But another important catch is that it's very important for us to ensure that the equipment is also giving the same concentrations what it is designed for at those flow rates, and hence daily check of the oxygen equipment is very crucial. In adults, daily check is required, and for neonates and infants, even it is recommended that after every 2 to 3 hours, one must check the equipment whether it is delivering what we are delivering to the patient. So, what about the questions? We will have it later, or if asked for, Dr. Jyoti?
Ma'am, at present, there are no questions. And
Okay,
maybe we can take at the end of the session
okay, okay.
after
Thank
all
you.
the speakers. Thank
Okay, thank you, Jyoti. Thank you, Dr. Anchal, for the wonderful presentation.
Thank you so
Now
much,
I,
ma'am.
pardon.
Can we have the slide, CV slide of next speaker?
Yes, now I will request my co-chairperson to please invite the next speaker.
Thank you, madam. Okay, here the slide. Thank you, Nirja ma'am, and thank you, MD Kaur madam. Thank you, Dr. Jyoti and Anchal. Thank you all the organizing team for the effort they have put for this PG session. So now let me introduce Dr. Devlina Goswami. She is a professor and from AIMS, New Delhi, and her achievements are researchers with publication in national and international journals. And her areas of interest are difficult airway, TIVA, oral and maxillofacial anesthesia, ENT anesthesia. So I welcome Dr. Deblina Goswami for this session.
Thank you so much, ma'am.
Thank you.
Greetings to everyone. Today I shall be presenting the pulmonary function tests with special reference to the anesthesiologist. The pulmonary function tests, they are a group of non-invasive tests that evaluate the functioning of the lungs, which includes the lung volumes and capacities, airflow rates, and transfer or diffusion of respiratory gases across the alveolar capillary membrane. The PFTs, they help in the diagnosis and in monitoring of various respiratory conditions such as the COPD, fibrosis, and many more. The aims and objectives of this presentation is to understand the basic tests of PFTs and to learn how to interpret the data, to understand its applicability in anesthesia practice, and to use the data to strategize and plan the anesthetic management of the patient. It is also important to understand the limitations of the test because they cannot be taken as the only parameter for diagnosis. We have to correlate it clinically. The indications of doing PFT are a diagnosis of pulmonary cases, for monitoring the response to a therapy, such as an example that I'd like to give would be response to bronchodilator therapy in asthmatic patients. A PFT is also needed for documentation of the course of a disease process, and it is needed for evaluation of disability in relation to the respiratory diseases, and also to evaluate disease prognosis. For an anesthesiologist, it has a special place in the preoperative assessment for lung resection, cardiac surgery, or non-cardiothoracic surgery. The contraindications to doing PFTs are a recent myocardial infarction, especially within 1 month of the incident, the presence of unstable angina, or a recent thoracoabdominal surgery, or a recent ophthalmic surgery. They are not good choices for a PFT test in that duration. Yeah, aortic aneurysm or presence of a pneumothorax also precludes doing PFT. The broad classification of PFTs are either the bedside test or the complex laboratory test. First, we go to the bedside test. They are the most invaluable test, as a lot of information that we can gather from history, a lot of laboratory values may not be able to give us. Like in history, we can find out about the recent or ongoing respiratory tract infection, smoking, or poor oxidized tolerance. All of this may lead to post-operative pulmonary complications. Likewise, a physical examination may reveal the presence of wheal crepitations, chest deformity, or the movement of the chest, or obesity. All these things which may be taken care of by optimization and special therapies before going for some kind of elective surgeries. Or even in emergency surgeries, we may administer some medications before taking up the patient. There are a plethora of bedside tests. We may not be able to remember so many, and it is not necessary to memorize so many things when for the bedside, but the few important ones I'd like to enumerate and describe very briefly. One is the Sapras's breath holding test. It is about holding the respiration after a maximal inspiration and maximal inspiration after exhalation to residual volume. So the normal values, if somebody is able to breath hold more than 40 seconds, that is a good cardiopulmonary, that is a good reserve. Yeah, a very severe complications may happen if the breath holding time is less than 15 seconds. Here, the patient may have a lot of complications in the intra-op or the post-operative period. Now, there is a Snyder's match blowing test, which probably we do not know, but it's an interesting test. And there's no harm in knowing about this test because it measures the maximal breathing capacity or the FEV1. Earlier, before the so many modern technologies came up, what they used to keep a flake candle burning at about 15 centimeters, and with the mouth open and nose pinched, the person would try to extinguish the flame. The candle would slowly be brought forward, but anything in this particular distance of 15 centimeter, if the maximum breathing capacity is more than 60 liters or the FEV1 is greater than 1.6 liters, we can conclude that the patient has adequate respiratory effort. Other bedside tests are like a single breath count test a single breath count test of more than 30 seconds is considered to be normal, and there are bedside pulse oximetry, and if the saturation drops below 4%, if the saturation drops more than 4% during the recordings, then there is likelihood that the patient has obstructive sleep apnea. Arterial blood gas analysis, it may not be a non-invasive test. However, it can be easily done in the bedside. How it helps? ABG, if you know the baseline parameters of a patient who has been suffering from respiratory disease, we might have some idea if we need to optimize the patient or if at all optimization is possible. We can have the ventilatory settings to adjust to his blood gas values. We can plan weaning or extubation or even decide upon post-op ventilation. Some cases such as the COPD, where the patients might be used to a slightly higher levels of carbon dioxide in the blood, trying to overcorrect them may not be a very prudent decision. So that is how arterial blood gases help us. Then comes the lab-assisted pulmonary function test. Here we have the static lung volumes, like the tidal volume or the vital capacity. We have dynamic lung tests like the forced expiratory volumes or the forced vital capacity. We also have diffusion or transfer capacity, mostly measured with carbon monoxide diffusion. And there are also integrated function of the respiratory and the cardiovascular system. We will learn about them one by one. But before that, we have to know what are the basic methods of respiratory measurements. The respiratory measurements are done either via pressure measurements, which are measured by transducers in the breathing system, or by flow, as just as a graph from the pneumotachograph or a peak expiratory flow devices. Volume is measured by spirometers or impellers and turbines. Many of the modern anesthesia machines also have an integration of flow with respect to time and gives us real-time values in the intraoperative period or in the ICU. There are values, statistical values, as how to present the PFTs, like the absolute volume at body temperature and pressure saturators, BTPS. This may not be very clinically relevant, but good to know that some of the values may be presented this way. Then there is a percent predicted, which is the patient's values are matched with a mean value of a normal populations, and how much to expect or how much of deviation is from that normal population, that is checked in this part. Then there is another one, lower limit of normal, which means in the lower 5% of the mean average population measurements, the subject values are matched. So if it falls within the lower 5% of the values, the likelihood of postoperative complications are high. Then there is JET score. This is the patient's values are given as number of standard deviations away from the reference population. So this is how they will be presented. Now the tests, which are frequently or commonly conducted to learn about the lungs. One is the lung has its own respiratory mechanics. Then there are diseases of the lung parenchyma. Also there is evaluation of the cardiopulmonary interplay. We have to learn and understand how each of these tests functions. For the test for respiratory mechanics is mostly by a spirometer, which was first described by John Hutchinson in 1846. The earliest spirometer by John Hutchinson, it is the picture which is shown in the middle of it, and the newer spirometers which are portable and light, very lightweight and very easy to use, is a modern spirometer on the right hand side. So this spirometer describes the mechanical behavior of the lungs and the chest wall as air moves in and out of the lungs. So the first we come to the static lung volumes. These are the volumes that are measured when no air is moving in and out of the lungs. So which means these are measured at different levels of either inflation or deflation of the lungs. So the static volumes that do not include residual volume can be measured by a spirometer. The spirometer will never give the value of a residual volume. Yeah. So this is the blue line. It represents uh, the lung volumes, and the smallest is the tidal volume, and this is the expiratory reserve volume, which touches the residual volume, and followed by this is the inspiratory reserve volume, which are achieved by maximal inspiration and expiration. Now, when two of the volumes are combined together, then we get a capacity. I mean, two or more than two. So like the total lung capacity is a calculation, is a summation of the inspiratory reserve volume, tidal volume, ERV, and respiratory volume, and the residual volume. We will learn how these values, why these values are important to us. These are some reference values for an average healthy adult male and female. However, it is better to express these values as per kg body weight. Now, how to measure the residual volume? One is the gas dilution method, which is done with an inert gas like helium, and it is based on the principle of gas equilibrium between the spirometer and the lung. And there are complex derivations and equations how to get this. Likewise, there is a nitrogen washout technique. This is similar to the pre-oxygenation. Here, the patient inhales 100% oxygen and keeps exhaling into a chamber where there is a nitrogen analyzer. Now, with each subsequent breath, the nitrogen in the lungs are washed out to the entrapped area, and the lungs is filled with 100% oxygen. The nitrogen analyzer, after analyzing all these breaths, gives us the value of the residual volume. Now, there is another method called the body plethysmography, which is based on the Boyle-Marriott law, which takes into account the pressure and the volume. Here, a patient or a person is seated within the airtight transparent cubicle, and he breathes to a breathing circuit, and all the recordings are done outside. All the changes in the pressure are extrapolated into volume readings so as to give the residual volumes and other lung volumes. Let us clinically correlate some of these volumes with this with some of the lung conditions, like a tidal volume, which happens to be the volume of gas exchange that happens in a quiet breathing. It is about 6 to 8 milliliter per kg. Tidal volume decreases when there is decrease in lung compliance or there is weakness in the respiratory muscle. These are few of the conditions to name. Now, vital capacity, which is a summation of the tidal volume and inspiratory reserve volume, and is approximately about 60 ml per kg. This correlates with coughing and deep breathing. It decreases in atelectasis and pulmonary edema or pleural effusion. Again, just to name a few. So it also correlates that if a patient has decreased vital capacity, patient may not be able to cough out his sputums in the postoperative period, leading to pulmonary complications. The functional residual capacity, again, it correlates with lung compliance and it influences the ventilation perfusion in the lungs. So it is decreased in cases like fibrosis or atelectasis due to inherent conditions of the lungs. And it can be mechanically decreased because of pregnancy or obesity. And increased FRC can be found in patients of COPD or in emphysema, where the FRC is increased only because of air trapping in the lungs. Now, the second is the dynamic lung volumes. These are volumes which are measured during either forceful inspiration and expirations. There are several volumes like the forced vital capacity, forced expiratory volume in different time periods, and also the peak expiratory flow rates. Now, these are represented in a volume time graphs. The blue line out here shows a normal curve where when a person forcefully expires, the maximum amount of maximum expired volume happens in the first 1 second of the expiratory phase. Now, at the end, we get the functional vital capacity, the forced vital capacity, Now, this FEV1 is important because it is decreased in both restrictive and in obstructive diseases of the lung. Then how do we differentiate? Because in restrictive diseases, the graph remains the same as the normal curve. However, both the volume and forced expiratory volume, both are decreased simultaneously. So a ratio of FEV1 by FVC remains normal. Whereas in obstructive disease, FEV1 decreases, but likewise, the forced vital capacity is not, FVC is not decreased to that extent. So the ratio is much less than that of a normal curve. Now we have the flow volume graphs or loops. Here we have the flow in ones in the y-axis and the volume in the x-axis. So the tidal volume happens to be a very small part of the entire lung capacities. Now, if we come to this these four graphs, the blue graph, it shows a normal inspiratory and expiratory phase. When it comes to the restrictive pattern, the graph is the same. The loop is the same as a normal person's breath, but however, the volume is much less, both in the inspiratory and the expiratory phase. In an obstructive pattern of respiratory day here, the inspiratory curve is normal. However, the expiratory part is flattened out. And the FEV1 is less out here. And if there is a fixed upper airway obstruction, then both the inspiratory and expiratory phases are much lower than the normal loop, and they are also flattened out. Now, how to test for the lung diseases of the lung parenchyma? It is done by much more complex tests than the ones which I have described before. So it is either diffusion of respiratory gases across the alveolar capillary membrane, which is measured either as represented as either transfer of carbon dioxide in the lungs or diffusion of lung carbon monoxide. Carbon dioxide is used as a surrogate for oxygen for measuring gas exchange properties of the lung because it does not otherwise take part in any other metabolic activities. Nitric oxide may also be used, and it has a more scope in the future. Now, factors which affect diffusion are age, weight, height, smoking, ethnicity, anemia, etc. So the results of abnormal tests have to be adjusted accordingly, taking these variables into account. So there are tests which evaluate the cardiopulmonary interplay. So these are the functional walking tests, the simpler ones, which is like a 6-minute walk test or incremental shuttle walk test or endurance shuttle walk test. It correlates strongly with the perioperative complications, lower values, yes. And however, the standard references for comparison are not yet available for this test. And the cardiopulmonary exercise testing is about measuring the peak oxygen consumption, where recording of oxygen concentration exercise is done, and there is an anaerobic threshold, a point during which where the oxygen delivery is insufficient in the tissues and the anaerobic metabolism it entails. And then there is ventilatory equivalent of carbon dioxide, which is the volume of ventilation required to eliminate the volume of carbon dioxide. These tests are applied when they are indicated in some for higher function studies of the lung, where it is required to come to definitive diagnosis, like as in a resection of lung, in resection of lungs, in lobectomies or pneumonectomies. Now let us correlate some of the PFTs with clinical scenarios. Like in asthma, what does it happen? Here in asthma, airflow obstruction is observed in dynamic lung volume. Reversibility of obstruction to bronchodilator therapy can also be seen, and rapid changes in FEV1 by FVC is also a marker of asthma. Peak expiratory flow variability of more than 20% strongly is suggestive of asthma. However, none of these can predict a perioperative bronchospasm. It is the history here, or the history of having asthma in the previous 30 days is more likely to be associated with poor respiratory outcomes in the postoperative period, or having a bronchospasm in the postoperative or intraoperative period. Yes. In COPD, what happens? The forced expiratory volume in 1 second by FVC is less than 70%, where FEV1 is reduced more than the FVC. This grading of severity can also be matched with the percent predicted, where FEV1, if it is greater than 80%, then we can term this as mild disease, whereas FEV1 of less than 30% is very severe and associated with poor outcomes. There are neuromuscular diseases like myasthenia gravis or Guillain-Barré syndrome, where we can know the need for ventilatory assistance if the patient has a FVC of less than 20 ml per kg, or a FVC max inspiratory or expiratory pressures are less than 30% of the predicted values. So do we require preoperative assessment in the form of spirometry or any other test in routine practice? No, spirometry is not routinely recommended because PFTs cannot quantify postoperative pulmonary complications. Patients who has a ASA physical status of more than 3 or 4 due to respiratory disease undergoing major surgery may get spirometry tests for quantification and timing of surgery. If from this test, we might also have an idea if the patient requires some kind of intervention or we need to wait till their results, or maybe there could be conditions where it is unlikely to improve with any kind of medications, and how to proceed after that has to be decided with the surgeons and anesthetists together. Now, cardiopulmonary exercise testing. So how does it help in the preoperative assessment? This cardiopulmonary exercise testing, it quantifies objectively the functional capacity of a subject to respond to increased metabolic demands, for example, a major surgery. Now, if the peak oxygen consumption is less than 10 ml per kg or less than 35% of predicted, then it is associated with high risk of perioperative complications. Now, PFTs have found its place in thoracic anesthesia because here it is very important. It gives some idea about assessing the suitability for lung resection. A preoperative FEV1 of less than 60% is usually associated with significant postoperative pulmonary complications. A transfer of lung carbon monoxide and the percentage of predicted postoperative transfer of lung carbon monoxide are independent prognostic factors. And a maximum oxygen consumption of 10 to 15 ml per kg has a high risk for perioperative complications and mortality. Now, in lung resection surgeries, it is prudent to calculate the predicted postoperative values for lung operations, because these tests, either via anatomical calculations and ventilation perfusion calculations with the equations given here, they give us an idea whether a patient will be able to withstand lung resections or whether they'll be able to withstand pneumonectomies. Here, they take into account the number of unobstructed segments to be resected and the total number of unobstructed segments, or if there's fraction of total perfusion to the lung to be resected, they give a value of a predicted postoperative FEV1, and from this, the surgeons are able to decide whether the patient can withstand a lobectomy or a pneumonectomy in the postoperative period, or whether he or she should go for a palliative care. Now, there are some modern imaging devices. They are usually not done unless the previous methods shows some defects. Only then they proceed for the quantitative CT scanning or the dynamic perfusion scanning. They are able to show the diseased and the normal portions of the lung, and thereby allow for thereby allow for decision making for lobectomies or pneumonectomies. So as I said, there are limitations of all these tests because there is variability in the normal predicted values. And active patient participation is required for the pulmonary function test, which may not be possible in many cases if the patient is very debilitated, if the patient is uncooperative, or if there is some psychiatric problem, then active patient participation is not possible. And also the test results are sometimes very complex and many times there may be inability to interpret without expert help. And experienced personnel are needed for carrying out the more complex tests. So these are some of the articles which have mentioned about pulmonary function tests. They have done away with some of the obsolete old tests and have mentioned about the newer tests. So along with your textbook, you can read these few articles for a better understanding because 30 minutes cannot do a full justice to a topic like a PFT or any other topic. We are here just to give you the ideas, what are the areas to touch upon. Thank you so much for your patient hearing.
Thank you, Dr. Devlina. It's very nice presentation, very nicely demonstrated. Different lung volumes and the test, very nicely done. Thank you very much. And it's a very important topic. You have covered very smoothly, nicely. Thank you very much. So there is no question now, I think, in the chat box.
No, ma'am, there are no questions yet in the chat box.
I will proceed further. Next.
Yes, ma'am.
Thank you.
Please unmute.
Ma'am, can you please unmute because we cannot hear you?
I'm sorry. Now you can hear me, please? Yes.
Yes,
So,
Yes, ma'am, now we can hear you, ma'am.
okay, thank you. And our next speaker is Dr. Sheetal Singh. She is assistant professor at ABBIMS and Dr. RML Hospital. She is IRC certified ACLS and BLS instructor. She has awards in paper presentation in the national conferences and ISA Delhi YuvaCon 2023 awards in culture, arts and literature. Areas of interest are obstetric anesthesia and pediatric anesthesia. Dr. Sheetal Singh is going to talk on ASA, physical status classification. So I request Dr. Sheetal Singh to please start with her presentation.
Hello everyone, I'm Dr. Sheetal. Today we'll be discussing about ASA physical status. Now, why we need about it?
The voice is not audible.
That we can assess degree of patient sickness
In the video, the voice is not audible. Can you?
or giving anesthesia to the patient. Besides this,
Please, she is not audible.
communication in between the colleagues.
Yes, Sheetal is not audible.
For statistical analysis. Now, dive into Hello everyone, I'm Dr. Sheetal. Today we'll be discussing about ASA physical status. why we need to study about it?
Can't hear you, Sheetal.
So that we can assess degree of patient sickness or
No.
It is not at all audible.
Voice is very slow.
Besides, it also helps us in record keeping and better communication between the colleagues. It also creates a uniform system.
I request the organizers to please look into the matter. She is not audible.
Yes, ma'am, she will be joining us live.
1941 by
Ma'am, she's just joining in few minutes, ma'am.
Now let's see further these classes. Example, ASC1
Ma'am,
ASC1 in pediatric.
Sheetal, if you can share your screen also
uh,
for your presentation.
ma'am, I'll just open it. This is on my mobile. I'll just open my laptop. Just give me 2 minutes.
Yes.
मैम वैसे भी उन दोनों केसेस क्लासेस सही है जो पहले वाली थी.
Meanwhile, we can see the MCQs. We have 2 MCQs for the delegates. As I think Sheetal is having some problem in network, so she will join us soon. Till then, we can see the MCQs which we have chosen for the delegates. Can we see the MCQs? So we have our first MCQ. It is decreased FEV1 and FEVC, but normal FEV1 by FEVC is characteristic of A, obstructive airway disease, B, restrictive airway disease, C, fixed airway disease, or D, all of the above. I will repeat the question. Decreased FEV1 and FEC, but normal FEV1 by FEC is characteristics of A, obstructive airway disease, restrictive airway disease, fixed airway disease, or all of the above. Can I have the next question, please? The second MCQ is, which of the following contributes to the drop in PO2 from ambient air to alveoli? Choice A is increased barometric pressure, B, addition of carbon dioxide in alveoli, C, water vapor dilution and gas exchange, D, oxygen consumption by alveolar macrophages. I will repeat the question. Which of the following contributes to the drop in PO2 from ambient air to alveoli? A, increased barometric pressure, B, addition of carbon dioxide in alveoli, C, water vapor dilution and gas exchange, D, oxygen consumption by alveolar macrophages. You have to put the answer in the chat box. Ma'am, Dr. Sheetal is having some issues in network, so we are concluding this session and we will have a tea break. And after the tea break, we will announce the answers for the MCQs. Thank you, Dr. Dua Madam. Thank you, Nihar Madam, for sparing your precious time and chairing the session. Thank you, ma'am.
Thank you. Thank you.
She's having some issues, so maybe when the issues will be solved, we will show the PPT,
Okay.
ma'am.
Thank you.
Thank you, ma'am. Thank you so much. Tea break now. 5 minutes tea break we will take.
Good morning, ma'am.
Can we have the MCQs again? The slide for the MCQs? Yes, first question was decreased FEV1 and FEVC, but normal FEV1 by FEVC is characteristic of, the answer is B, restrictive airway disease. The second question, which of the following contributes to the drop in PO2 from ambient air to alveoli? A, increased barometric pressure. B, addition of carbon dioxide in alveoli. C, water vapor dilution and gas exchange. D, oxygen consumption by alveolar macrophages. So answer is C, water vapor dilution and gas exchange. Today we have the case discussion session. The case is on a 28-year female with post-burn contracture neck and fixed flexion deformity, planned for contracture release and flap cover. So the case moderator of the case is Dr. Ranju Singh ma'am, and the PG who's presenting the case is Dr. Sugam Bhola, and Dr. Akash Jadon, our senior resident, will summarize the case. Can we have the CV of ma'am? Ranju ma'am is HOD Lady Harding Medical College, and ma'am has various achievements, publications and awards, and ma'am is also member of various societies. We welcome you, ma'am. The area of interest of ma'am is pediatric anesthesia, obstetric anesthesia and life support. We welcome you, ma'am. Now over to you, ma'am.
Thank you so much, Dr. Jyoti. And my heartfelt thanks to Team Appec for giving me this opportunity of interacting with students on such a wide scale across the country. So thank you once again. I will request Dr. Sugam to present his case so that we can start the discussion without any further delay. Thank you so much. Sugam, can you share your presentation, please, and start your presentation?
Yes, ma'am. Sure. One minute. Boom together. खुला हुआ है ना
कितनी देर से बैठ के कब के मारते हैं?
पहले डाउनलोड एग्जैक्टली है ना ये डाउनलोडेड है डाउनलोड वाला डाउनलोड खोलो डाउनलोड ओपन हो ये ब्राइट से खोल रहा है हाँ इसको बड़ा करो ये शेयर होगा अभी अभी शेयर करो हाँ पे शेयर होगा कैंसिल करना मैंने बोला था ना शेयर
And we will soon share the screen.
No,
At
no,
the
it's okay. It's okay.
moment.
Even with the best planning, sometimes it takes a little while to get things going. It's absolutely okay.
Yes, ma'am.
Good morning, ma'am.
Good morning. Can we
Good
start?
morning.
Things have got sorted out? Right. So, Dr. Jyoti, make sure that our timer starts when he starts presenting because we've lost 10 minutes in the process.
Yes, ma'am. Yes, ma'am. You.
Okay. Please start, Akash.
My patient is 20. Yes, ma'am. My patient is a 28-year-old female who is a resident of Paharganj, New Delhi, homemaker by occupation, who presented to the hospital with the chief complaints of restriction of neck movements for the, since 2 years, excessive scarring over the neck and chest since last 2 years.
The
History of
slides are not
prevalence.
moving forward.
Patient
I
was
can't see.
Please keep it on slideshow. Please keep it on slideshow.
Okay, yeah, sure. Is it now? Ma'am, is the slide visible?
Yeah, slide is visible, but is it on slideshow? You've put it on slideshow?
No, currently it is not a slideshow. Shall I put it in the slideshow, ma'am?
Okay, fine, continue.
Okay, ma'am. History of present illness. The patient was apparently well till 2 years ago when she sustained an accidental flame burn over her face, neck, shoulders upper chest and both the upper arms from stove burn in the kitchen while she was cooking. Following this, she was immediately taken to the hospital. Primary treatment with the IV antibiotics, intravenous fluids was given, burn dressing was done, and she was discharged after 3 days with the instructions to follow up, but she was lost to the follow-up. During the course of hospital
Sugam,
stay, there was no history.
Wait. Go back to the slide you have.
Okay, ma'am. Yes.
You've specifically mentioned that it's an accidental flame burn. Why did you mention this?
Yes, ma'am. Ma'am, because she was actually accidental flame burn. She was cooking food on the cylinder, and
Is it relevant to mention the
she
flame burn?
accidentally. Yes, ma'am.
Is it important to mention how she got burned?
Yes, ma'am. It is important when
Why?
because it will define what would be since she got a flame burn, it could also lead to various consequences related to the burns. Such as it could also
It is
be an
important.
inhalational injury, and
It is important to mention the flame burn because the type of burn will influence the pathophysiology. Okay,
Yes,
not
ma'am.
the concept. The pathophysiology will be different when it's a flame burn. The pathophysiology will be different if it's an electrical burn. It will be different if it's a chemical burn. So that is why it is important to mention in the history how she got burned. Okay.
Yes, ma'am.
Okay, move on.
Yes, ma'am. During her course of hospital stay, there was no any history of difficulty in breathing, change in the voice or chest tightness, no history of fever, cough, or expectoration, no history of dizziness, loss of consciousness, vomiting,
I
or the
can't
chest
see the
pain.
slides moving. I cannot see the slides moving. I wonder if the rest of the people can see it. We are still, yeah. Okay.
During her course of hospital stay, there was no history of any difficulty in breathing, change in the voice or chest tightness, no history of fever, cough, or expectoration, no history of dizziness, loss of consciousness, vomiting, or the chest pain, no history of difficulty in swallowing or eating, no history of use of any oxygen therapy or eye strain.
Okay. Please move on.
Yes, ma'am. Later on, she developed restriction. Later on, she developed restriction of neck movements, particularly in the upward direction. She also developed excessive scarring over the chest, upper arm, and hands, for which she now presented to the hospital. These are her chief complaints.
Okay.
Okay, ma'am. Past history, there is no any history which is suggestive of diabetes, hypertension, thyroid disorder, respiratory disease, seizures or any psychiatric illness, any other cardiac disease, kidney disease, or any GI disease. There is no history of any trauma, blood transfusions, drug allergies, radiation exposure to the neck, any previous surgical history, or anesthesia exposure.
Okay, continue.
Yes, ma'am. Personal history. She has a mixed diet with normal bowel and bladder habits. She is a non-smoker,
And your slides
non-alcoholic.
have disappeared. Sugam, your slides have disappeared. I don't know what is this problem.
Please share your slides.
Ma'am, now, is it now visible, ma'am, to you?
No. Okay, continue. We can
Ma'am,
keep
now is it
hearing you
visible?
because we're wasting such precious. No, it's not visible, but you can continue. Whoever is listening in can listen carefully.
Okay, there is
Yes,
no
it
any
is
significant
visible.
family.
Okay.
There is no any significant family
Okay,
history.
fine. Go ahead. Go ahead.
She is unmarried.
Go ahead.
Okay. General examination. The examination was done after taking the consent from the patient in the presence of a female nurse. She was fully conscious and oriented to time, place, and person, sitting comfortably on bed. Average build. No peripheral veins were appreciable in her upper limb. Her weight measured was 62 kilograms and height was 158 centimeters with a BMI of 24.8. No pallor, icterus, clubbing, cyanosis, or lymphadenopathy or edema at the time of presentation. Her pulse rate, it was 78 per minute, right radial, regular with good volume. All the peripheral pulses, these were palpable with no radial or radiofemoral delay. Blood pressure, 126
Okay.
over 72 millimeters.
Okay.
126 over 72 millimeters of mercury recorded in the right upper limb in the sitting position. Respiratory rate 18 breaths per minute. Temperature 98.7 degree Fahrenheit. Coming on to the local examination, ma'am, on inspection, there was an extensive burn scarring measuring approximately 35% of the surface area on her face, neck, upper chest, and arms. Both of the angles of the mouths were scarred. Hypopigmentation was noted over the neck and upper chest. Fixed flexion deformity of the neck is present. A thick fibrous band is seen running around from the neck towards the upper chest. No ulcer or sinuses were seen. Visible distended veins were seen.
Okay.
Palpation
You said that the area of the burns was 35%. How did you reach that figure, Sugam?
Okay, ma'am, in
You said
adults,
that the
there is.
area of the burn.
Yes, ma'am. Ma'am, in adults, to assess the total burn surface area, we use Wallace rule of 9, ma'am, which states that the total burn surface area can be divided into percentage of 9, starting from the head and neck, involving upper arms, which comprises 9% of each, coming on to the anterior abdomen and lower abdomen, which comprises total of 18%. Similarly, the posterior part.
So, yes. So for all the students listening in, he's talking about Wallace rule of 9. In all your textbook, a beautiful picture is given. Sugam, do you have a picture anywhere?
Yes, ma'am. I have a
Of the
picture. I
rule
will
of
just show.
9, which means that you can divide the body into sections and calculate the burn percentage according to this rule of 9. Okay?
Yes, ma'am.
Yes, this
Yes,
rule
ma'am.
of 9. Does the rule of 9 is it equally applicable to children? You have a small picture of a baby on the side. Is it equally accurate in children?
No, ma'am. The Wallace rule of 9 does not applicate to the children since they have got relatively larger head and neck area. So in these patients, we use London-Browder's chart, ma'am.
So the rule of 9 is not accurate for estimation of surface area in children. In them, the go back to your examination.
Yes, ma'am.
You were on local examination.
There is an extensive burn scarring, approximately 35% on the face, neck, upper chest, and arms. Both angles of mouth are scarred. Hypopigmentation was noted over the neck and upper chest. Fixed flexion deformity of the neck was present. A thick fibrous band is seen running from the neck to the upper chest. No ulceration or sinuses were seen. Visible distended veins were seen. Coming on to the palpation, the fixed flexion deformity of the neck was present. There was no tenderness over the scar tissue. Sternal notch cannot be palpated. Thyroid, cricoid, cricothyroid membrane, and trachea, these were not palpable.
तो वहां से चल रहा है उसका. What is the problem occurring over there? Okay. Sugam, can you hear me?
Yes, ma'am, I can hear you.
Okay, चलो आगे बेटा.
Ma'am, coming on to the airway examination, so general visual inspection, distorted facial features, scarring, receding chin, restricted neck movements were seen. Bilateral nares, they were patent. Mouth opening, it was a 2.5 centimeters with normal tongue, no loose or missing teeth, no prominent incisors. Palate was normal, unable to protrude lower jaw beyond the upper
इसमें कुछ
incisors. Normal.
significantly कुछ significant है इसमें? What is
Yes, ma'am. There were
what is not normal in this?
Ma'am, first of all, facial features have been distorted due to
Facial
the thermal
features
injury.
and
Ma'am, there is an excessive scarring. Ma'am, there is also
okay,
microstomia.
what else? Okay. The mouth
Yes,
opening
ma'am.
is reduced. Okay. चलो
Yes,
आगे
ma'am.
चलो.
There is, yes, ma'am. Coming on inter-incisors gap, it was around 2.5 centimeters. Malampatti test came to class 4. Upper lip bite test, class 2.
How did
Atlanta occipital.
how did please Sugam साथ साथ सुन लो. You keep rushing, then you don't listen to me. How did you check the Malampatti in this when the mouth opening was restricted? Malampatti देखने के लिए पूरा खुलवाना जरूरी है ना?
Yes,
The
ma'am.
patient has to open his mouth completely, protrude the tongue. You have to sit at the patient's mouth height and then see into the mouth. So if
Yes,
the
ma'am.
mouth opening is restricted, how can you see Malampatti?
Right, ma'am. We cannot see the Malampatti.
तो ये तो आपने जो 4 लिखा है ये या assumption से लिखा है, कैसे लिखा है ये 4? नहीं हो सकता ना बेटा, आप assess ही नहीं कर सकते. तो Malampatti test and it you should write cannot be assessed because
Yes, ma'am.
if you say 4, then the examiner understands that either somebody else has told you this or you are trying to fib. So if you have not seen it or cannot adequately assess, patient का मुंह खुलता है but probably कम खुलता है, इसलिए आप posterior pharyngeal wall तो देख ही नहीं पाए इसमें, ये दिखी थी.
Little bit of a hard palate was visible, that's why I written this.
Huh?
Otherwise, complete mouth opening was not there.
Then you cannot comment on Malampatti, please. Okay?
Yes, ma'am.
So जैसे आपने लिखा है thyromental and sternomental distance you were not able to assess, Malampatti also you are not able to assess. Okay?
Yes, ma'am.
Okay. Atlanto-occipital extension कितना था? 10 degrees. Normal कितना होता है?
It comes to around between 75 to 80 degrees, ma'am.
So it is significantly reduced.
Yes, ma'am.
Okay, great. 4. चलो आगे बेटा. Next.
I'm coming on to the systemic examination.
Is there anything significant? Is there anything significant in any of the systems? So let's move on. Okay. If there's nothing significant in the cardiovascular and respiratory system, let's come to your provisional diagnosis. Okay.
So my provisional diagnosis
so you should say based on the history and examination, my provisional diagnosis is.
Yes, ma'am. Based on my history and examination, my provisional diagnosis is a 28-year-old female patient with post-burn contracture involving face, neck, anterior chest, and both the arms, sustained from thermal burns 2 years ago with flexion neck deformity, scheduled for contracture release and skin grafting.
Okay. So this patient has come to you 2 years after her burn for contracture release and skin grafting. Okay.
Yes, ma'am.
But any burn case, when you get in the examiner can ask you questions in the entire spectrum. Students must remember that they should not have like this fixed flexion deformity. They should not have a fixed path, thinking that sirf contracture release पूछेंगे और कुछ और नहीं पूछ सकते. So the examiner, the burn is a very long and wide topic, and everywhere the examiner can ask you a question. Okay, so let's briefly, because we have time, also cover some aspects of acute burns before we come on to chronic burns, so that you know what questions can be asked in a case like this. Okay, now ये patient आपके पास आया PSC में, but still suppose this patient had come earlier to you And they,
Yes, ma'am.
you get a call from the casualty sometimes when you are on duty to assess a patient of burns. How
ma'am.
do you assess the severity of burns?
So again, ma'am, the severity of burn, it is assessed by calculating the total burn surface area and also the depth of the
Severity of
burn injury.
burns first is assessed by two methods, by noting the body surface area involved and the depth of burns. इसका जवाब ये है, ठीक है? Body surface
Yes, ma'am.
area involved and the depth of burns. Now, the body surface area involved can be assessed by
Ma'am, rules of or Palmer's area method, ma'am.
Okay, so Wallace rule of 9, as you said, Palmer surface area and the Lund and Browder chart.
Yes, ma'am. Which is
Remember,
used for the
Palmer
pediatric
surface
population.
area is applicable in burns which are approximately 15 to 20%. If the burns are more than that, then Palmer surface is not a good method to assess burns. Okay? We've already
Yes,
talked
ma'am.
about that this rule of 9, Wallace rules of 9, is not applicable in full. Okay. Then the other
ma'am.
method of assessing the severity of burns is the depth of burns.
Yes, ma'am.
Can you classify burns based on their depth?
Yes, ma'am. Ma'am, based on the depth of injury, burns can be classified as follows. First degree burns. These are the burns that are confined to the superficial layer of skin, that is the epidermis. These
Okay.
burns
Okay.
and they heal spontaneously. Second degree burn,
Okay.
superficial and deep. In superficial second degree burn, there is involvement of epidermis along with 1/3 portion of the dermis. In these burns also, there is no scarring but there is blister formation, and these burns are painful.
Okay.
Second degree
Okay.
deep burns, they involve epidermis along with significant area of dermis.
Okay.
Then there are third degree and fourth degree burns. In third degree burns, it is also known as full thickness burn, which involves epidermis and all of the dermis area. In fourth degree burns, there is also involvement of the
आपके लिए ये
surrounding
क्यों
structures such
important
as
है?
fascia.
Why should you know this as an anesthesiologist? ये तो surgical question हुआ ना, हमने आपसे ये क्यों पूछा कि आपको degree of burns पता
Ma'am,
होना चाहिए, depth of burns पता होना चाहिए?
Ma'am, because the depth of burn, it defines mainly two things. One, the mortality of the patient. If more would be the thickness of the, more would be the degree of burn, such as third or fourth degree, there would be an increase in mortality.
The
And ma'am,
mortality is
second,
directly related to the depth of burns. It is also related to the body surface area that is involved.
Yes, ma'am.
Okay. In
Yes,
fact, there
yes.
is a formula which says mortality is equal to percentage of burn surface area into age.
Yes, ma'am.
So
That
if
is
you
known as
have
Box
a
formula.
35-year-old patient with, if you have a 35-year-old patient who has 30% burns, he will have a higher mortality than a 35% burns in a 20-year-old.
Yes,
So the surface area involved, the depth of burns define the prognosis. It also defines your anesthetic management. It defines the amount of pain the patient will have. It defines the physiological changes that will occur. Less the burns, less the physiological change, greater the burn in area or depth, greater would be the systemic inflammatory response, and greater would be the physiological disturbances that are seen in this patient.
Yes, ma'am.
ठीक है, तो हम ये जो physiological disturbances की बात कर रहे हैं, what is the effect of burns on various systems of the body? हम कह रहे हैं कि जितना ज्यादा burns होगा या जितना depth होगा, उतना ज्यादा patient को problem होगी. तो what are the physiological changes that we are talking about?
Ma'am, first of all, due to the burns, there is increase in the fluid. That means the extravascular compartment.
Okay. So can you divide it system-wise instead of just randomly telling me the changes, Sugam? It is better when a question like this is asked, you should divide your answer into categories. It's easier to remember.
Yes.
The examiner understands that your thought process is extremely systematic and regulated. Okay. So can you give your answer system-wise?
what is the effect on the cardiovascular system or the hemodynamic changes?
Ma'am, coming on to the cardiovascular, there is decrease in the cardiac output.
Okay.
There is first of all there is peripheral vasodilatation, due to which capillary becomes leaky, and there is fluid sequestration.
Okay.
Yes, ma'am. And ma'am, coming on to the pulmonary system.
Is that all in cardiovascular? Is there all? Akash, can you add to this?
Ma'am, in cardiovascular system, ma'am, there is a hypovolemia and there is a myocardial depression because of release of vasoactive substance because of the local injury cause.
Yes.
And
Yes.
ma'am, it is in the initial phase. And ma'am, in late phase, there will be, because of the resuscitation, there is a large amount of fluid that will cause the increase in cardiac output, ma'am.
Okay. So there is increased capillary permeability because of the systemic inflammatory response. The capillaries become leaky. There is extravasation of fluid along with albumin. There is hypoalbuminemia. Along with this, there is a decreased hepatic albumin production. Why do these patients, you said there is loss of albumin, why do these patients suffer from decreased albumin? आपने कहा ना hypoalbuminemia होता है.
Yes,
so
ma'am.
not only is it extravasation and loss of albumin from the intravascular space, there is also decreased hepatic albumin production because it's a catabolic reaction.
Yes, ma'am.
Okay? Now this albumin that extravasates adds to the fluid collection and edema in the interstitial spaces. Okay? Any other reason why they can have edema besides the extravasation of fluid due to albumin? These patients also have decreased ATPase activity. There is generalized decrease in ATPase activity, which then decreases the function of the ATPase cellular pump, which means that there is accumulation of intracellular sodium and water, which further depletes the intravascular volume. Okay? So there is loss of fluid from evaporation and exudation from the wounds. There is decreased albumin in the intravascular space. There's decreased albumin production, decreased ATPase activity, which causes accumulation of sodium inside the cell and decreased intravascular volume and increased sense of increased edema. Okay. Another thing that happens in the circulatory system is there is peripheral and splanchnic vasoconstriction, Sugam. There is no vasodilatation. So this peripheral and splanchnic vasoconstriction causes increased in SVR in these patients. Also, as a result of the systemic inflammatory response, there is decrease in cardiac contractility. So the systemic changes must be very clear to all of you. And when the examiner asks you, instead of just, hesitating, you know that this question is going to come. It should be on your tips.
Yes.
Okay. Any other system? For example, what happens in the respiratory system?
Ma'am,
We
again,
have
due
to
to
start
the
answering a little quickly because then we'll run out of time very soon.
Ma'am, due to injury, there could be development of pulmonary edema, and in severe cases, ARDS
Okay.
can also be developed. There is decrease in FRC, decrease in lung capacity, and decrease in
yes. Very good. Okay. And bronchoconstriction. Because of the inflammatory response, ARDS or bronchoconstriction. Okay. What about the metabolic responses?
These patients have an increased metabolic response. There is an increase in metabolism.
Very good. That lasts how long? This
Ma'am, it can last
hypermetabolic
even up to
response lasts.
Ma'am, it can even last for up to an year, ma'am.
Very good. It can last almost up to a year. There is, because of this hypermetabolic response and catabolic ongoing process, there is decreased protein synthesis, there is increased muscle breakdown, increased gluconeogenesis, and increased lipolysis.
Yes.
Okay? Increased gluconeogenesis and increased peripheral lipolysis. What about the thermoregulatory system?
Ma'am, the skin barrier is lost. there are two things. These patients are more prone to
Very good.
hypothermia, and their thermoregulatory thermostat response is set at a higher level than as compared to normal individuals.
Very,
And since their
very
skin
good.
barrier is lost,
Absolutely.
vasoconstriction property is also lost.
Yes. So because suppose in deeper burns, the skin appendages are lost. So sweating, piloerection, and other activities of the skin are lost. The evaporative
Yes,
losses become very high because of the disruption of the skin barrier. And as you said, the thermoregulatory control is reset. Okay. What about the immune system?
Ma'am, skin acts as a protective barrier. So since skin burn injury is there, immune response is lost, ma'am. Immune response, these patients are very prone to getting infections, ma'am.
Yeah, there is a very high risk of infection in these patients. What about the hematological system? That's another system which is very greatly involved.
Yes, ma'am. Ma'am, coming to the hematological system, there is decreased production of RBCs. There is increased hemolysis of RBCs. And ma'am, due to dilution also, excessive fluid resuscitation, again, there is dilutional anemia in these patients.
Okay. So
Coming on
anemia
to
can
the
be because
platelets,
of
there
multiple
is
causes.
thrombocytopenia.
Increased loss of erythrocytes, blood loss, decreased production, and decreased lifespan. All contributes to anemia. And then there
Yes,
is
ma'am.
dilutional coagulopathy. Okay. What
Yes, ma'am,
about the
dilutional
renal
coagulopathy.
system?
Ma'am, renal system,
What about
there
the
is
renal
an
system?
yes, ma'am. Ma'am, increased surge of catecholamines and ADH would be there, which will lead to vasoconstriction. So again, decreased renal blood flow would be there, leading to AKI.
Very good. Very good. So when the examiner asks you either the systemic effects or asks you what you will examine in this patient or asks you the generalized effect on the body system, this is what you need to answer. Cardiovascular, hematological, respiratory, immunological, renal, everything must be included in your answer. Okay. Now,
Yes,
how do you define major burns?
ma'am, major burns definitions are as follows. Full thickness burn involving more than 10% of total body surface area.
Okay.
Ma'am, partial thickness burns of more than 25% of total body surface area,
Okay.
plus involving 20% of area at the extremes of age. Electrical
Okay.
burns, chemical burns, inhalational injuries, and burns which are associated with trauma.
Okay. So burns associated with trauma, extremes of age, more than 25% in adults or more than 10% deep thickness burns. You've talked about inhalational burns. You said inhalational burns are major burns, right? Now, how
Yes,
would you suspect inhalational burns in any patient? अगर ये patient आपके पास casualty में आता, आप inhalational burns की बात कर रहे हो, कैसे suspect करोगे कि patient को inhalational burns है?
And first of all, we will take the history of the patient. There are certain points which will favor us the history of inhalational injury. If the burn has been occurred in a confined place, ma'am, there is facial burn, facial injury. The patient had lost the consciousness. He or she was unconscious at the time of event, or the patient was also under the influence of alcohol intoxication. These all gives us hint. And ma'am, on examination, there would
So
be facial, nasal
history,
injury,
examination, and investigations. Each of them you should define. History में, as you said, alcoholism, confined space, history of explosion, history of unconsciousness, history of toxic fumes. Okay. On examination.
Ma'am, on examination, there would be swelling of face, lips, and nasal hairs also. There would be thickening of nasal hairs. And along with that, ma'am, we can also find deposition of carbon or soot particles within the airway coming onto the lips.
So anything that
from
involves
these
the
patients,
face and neck, burns of the face and neck, if there is evidence of burnt nostrils, tongue, there is edema of the tongue, there is soot deposition, there is singeing of hair, there is circumferential neck or chest burns, okay? And if there is redness of the tongue, mucosal edema is there, redness is there, erosion is there, all this indicates that there may be some evidence of inhalational injury. It's very difficult to diagnose. You cannot see anything on X-ray. It's very difficult to diagnose because fibroscopy is very difficult in these patients. So a high index of suspicion should be maintained based on history and examination. अगर पेशेंट को इनहेलेशनल इंजरी है तो उसको कैसे ट्रीट करेंगे या आप क्या करोगे उसके लिए? इनहेलेशनल इंजरी का एक बहुत इंपॉर्टेंट कंपोनेंट क्या होता है? व्हाट आर यू वरीड अबाउट?
Ma'am, during the first 24 to 36 hours, there is very high chances of development of airway edema, which can compromise the airway. So we need to secure the airway.
So not secure the airway, early securing of airway. In patients में बहुत जल्दी airway edema हो जाता है, particularly when you start fluid therapy. They really swell up. There is very rapid involvement of the upper airway and there is closure. So you have to intubate the trachea of these patients very early based on clinical suspicion. ठीक है? और क्या relevance है आपके लिए inhalational injury?
Ma'am, we need to know about the basically type of the toxin, such as whether it's a carbon monoxide or yes.
Okay. So if there is inhalational injury, there is a high chance that these patients can have carbon monoxide poisoning. उसके क्या signs and symptoms होंगे?
Ma'am, depending upon the concentration, ma'am, patient can present to us with following symptoms: hypotension, dizziness, and also there is also disorientation, confusion, hallucination.
So depends upon the amount of carbon monoxide. Yes, the pathophysiology that students can read of carbon monoxide poisoning, that it basically interferes with oxygen transport. It binds to the heme of hemoglobin and prevents binding of oxygen. Similarly, the myoglobin is disrupted and there is cellular hypoxia. Okay, so the students can read that, and the signs and symptoms depend upon the concentration of carbon monoxide in the blood, which can range from simple headache, nausea, vomiting to unconsciousness and seizures. And the treatment?
Ma'am, since treatment, ma'am, they will provide the patient with a high percentage of oxygen. Ma'am, carbon monoxide half-life at the room air, it is around 4 to 6 hours. But if we give 100% of oxygen, it reduces to 40 to 60 minutes, and further 15 to 30 minutes if we give hyperbaric oxygen therapy.
Right. So oxygenation, mainly 100% oxygen, even hyperbaric if you have available, support of circulation, support of respiration is what is actually required in these patients. And if there is only smoke inhalation and no evidence of carbon monoxide, again, the therapy is mainly supportive. Early intubation, as Sugam has said, supportive therapy, bronchodilation, pulmonary toilet, good hydration of the airways, and supportive therapy.
Yes.
Okay. Okay. Now, what about the fluid therapy quickly in these patients who come to you with acute burns?
Okay, ma'am, we will resuscitate the fluid by using the formula, that is Parkland formula, which states that we have to resuscitate the patient with a 4 ml per kg of body weight per percentage of total body surface, total burn surface area. Ma'am, preferred choice of fluid is balanced ringer lactate. We will resuscitate the ma'am. The half of the calculated fluid, the half of the calculated fluid is given within the first 8 hours since the time of injury, and the next half is given in the next 16 hours. For the first
so many formulas, including Parkland formula, which is most commonly used. As he said, the therapy of choice is crystalloids. Why not albumin or colloids?
Ma'am, within the first 24 hours, we need to adequately resuscitate the patient. Ma'am, albumin or the colloid therapy, it is given after the initial 24-hour resuscitation period has been done.
So after 24 hours, you can use albumin as a resuscitative fluid itself, because that will help pull water into the intravascular and maintain the colloid oncotic pressure. It's a good thing to give to burns patient because they have low albumin anyway. Okay. What is the complication of excessive fluids?
Yes. Ma'am, again, excessive fluid, it can lead to the tissue edema and it can cause hematological changes such as dilutional anemia and dilutional coagulopathy.
Excessive fluid is not good because it can produce compartment syndrome. Remember, too much fluid can produce compartment syndrome. It can produce more leakage from the capillaries which are already leaky and produce the phenomenon of fluid creep. Akash, can you tell us what is fluid creep?
Yes, ma'am.
Ma'am, fluid creep is a condition when there is a due to over resuscitation, ma'am, there will be tissue edema, abdominal compartment syndrome, and ma'am, it can be dealt with the early replacement by the colloid or hyperosmolar fluid, ma'am.
Okay, so complications of fluid therapy, everybody must be aware of. Fluid therapy complications can produce compartment syndrome and the feature of fluid creep. The details of which are given in every textbook, and the student can go ahead and read these acute burns and the details. We've just given a very small overview of how and what you can be asked in a burns patient when there is presentation as acute burns. Okay, now let's come back to our patient. Now, this patient has presented to you in the PAC for contracture release and skin grafting. ठीक है, आपने एक हिस्ट्री ले ली, एक एग्जामिनेशन कर लिया, आपने क्या इन्वेस्टिगेशंस करानी है इस पेशेंट में अगर ये कॉन्ट्रैक्चर रिलीज के लिए आता है?
Ma'am, complete blood count.
Okay, complete
Liver
blood
function
count.
test, kidney
We've
function
about
test.
the fact, we've already talked about the fact that these patients can have a high incidence of anemia. They can have further blood loss during the skin grafting. And the risk of infection is very high. So you need to know the TLC and the DLC. Okay?
Yes.
Okay, or?
Ma'am, apart from this, kidney function test, urea creatinine, serum electrolyte, sodium, potassium, ma'am, blood group cross matching.
Okay.
Because for perioperative losses, we need to do. Ma'am, apart from this, liver function, which will test us the liver enzymes acid. Apart from these, ma'am, I will also go for chest X-ray, PA view, and
why do you need a
X-ray.
chest X-ray? Why do you need a chest X-ray?
To know the position of the trachea and lung status, ma'am.
Okay, so if the patient has not got examined before, you don't know how much damage was done. If there's any physical damage or fibrosis that is existing in the lungs, you can get an X-ray chest to find out baseline about the lungs, and will also tell you about the position of the trachea since she has such severe contractures in the neck. ठीक है, और कुछ कराओगे?
Ma'am, X-ray neck, I will go. AP and lateral view, since it's anticipated difficulty airway, ma'am.
Okay, okay. What else?
Ma'am, for I will also go for a PT INR to rule out any coagulopathy.
Okay, you will go for a coagulation status. Yes. Okay. What else? Hemopoietic system is involved. You would like to have a baseline coagulation of this patient. What else? ECG कराना है?
12 lead ECG would also be done. Dyselectrolemia, it can also lead to dysrhythmia, to look out for any dysrhythmias, ma'am. Arrhythmias.
लेकिन अगर उसका पोटेशियम नॉर्मल आएगा तो ECG कराओगे? Young adult female है. If you know about the type of injury, you can not do it. But if you are not sure about the type of injury, आपको नहीं पता कि कुछ electrical injury का component था या नहीं था, तब आप ECG करा लें, because electrical injury would have produced a lot of arrhythmias and residual damage in the myocardium. So an ECG is acceptable.
Yes.
एक blood sugar भी करवा लो, because these patients are put on therapy. May need supplementation pre-operatively, intraoperatively. You will like to get a baseline blood sugar also done. Okay?
Yes.
So investigations we've got done. अब इस patient के क्या complications या क्या perioperative concerns हैं? आपने ये सब investigations करा लिए. We'll come to the findings of the investigations. What are the perioperative concerns? The most important question in your entire viva is probably this. What are your perioperative concerns in a patient who's undergoing contracture release?
So, one
Sorry, I didn't hear that.
there is also anticipated
सुनाई नहीं दे रहा बेटा.
ma'am, anticipated difficult year.
Okay. Anticipated difficult airway से पहले
Ma'am,
कुछ है वो
anticipate,
obvious है. Anesthesia concerns, which means all the factors which are going to influence your anesthesia management. जब भी आपसे एक क्वेश्चन पूछा जाता है, इसका मतलब है कि आपने पेशेंट को देख लिया, हिस्ट्री ले ली, एग्जामिनेशन कर लिया, इन्वेस्टिगेशंस कर लिए. आप एक कोहेसिव असेसमेंट करोगे कि आपके लिए इस पेशेंट में क्या प्रॉब्लम आने वाली है. Can you hear me, Sugam? Can you hear me? Hello? Can you hear me?
Are you able to hear me? Yes.
Sugam?
Ma'am, yes, ma'am, I'm able to hear you, ma'am.
Okay, तो बताओ बेटा, anesthesia concerns बताओ.
Ma'am, there would also be difficult venous access in these patients.
Okay.
Yes.
First concern is regarding
Hello.
the area of burns and the depth of burns.
Ma'am, are you able to hear me? ma'am?
है ना? That should be your first concern कि mild burn है, ज्यादा burn है, third
Are you
degree
able to hear
burns
me,
था,
ma'am?
second degree superficial था, second degree deep burns था. So area of burns, type of burns, thermal burn था,
Yes, ma'am.
electrical burn था. ये सब हमने अभी बात करी है ना कि इसकी पैथोफिजियोलॉजी फर्क होगी, तो ये आपका एनेस्थीसिया कंसर्न होगा.
Yes, ma'am.
टाइप ऑफ सर्जरी एंड ड्यूरेशन ऑफ सर्जरी, बिकॉज
that
दैट
will
विल
also-
इन्फ्लुएंस कि कितना फ्लूइड देना है, कितना ब्लड लॉस होगा, कितना हाइपोथर्मिक होगा.
Yes, ma'am. These patients.
So area of burn, type of burn, type and duration of surgery is an anesthesia concern.
Yes.
Then as you said, difficult venous access.
Yes, ma'am.
Then mechanical issues related to monitoring. इसमें आप
Ma'am,
ECG कुछ लगा सकते हो कि नहीं, आप बीपी कफ आर्म में बांध सकते हो कि नहीं, कितना जला हुआ है, एक्सेस है कि नहीं.
Yes,
So
ma'am.
that is an anesthesia concern.
Yes, ma'am.
Okay, what else?
Ma'am, altered drug metabolism.
Okay, altered drug metabolism. A better way to answer this, Sugam, is changes in pharmacodynamics and changes in pharmacokinetics. ठीक है?
Yes, ma'am.
तो pharmacodynamic changes क्या है, pharmacokinetic changes क्या है?
Ma'am, since ma'am, coming on to the kinetic, ma'am, these patients have an increased metabolism.
Pharmacodynamic
all of
बता
the
रहे थे ना बेटा. You understand the
all-
difference between pharmacodynamics and pharmacokinetics?
Yes, ma'am.
Okay. So the pharmacodynamic
kinetic
changes
changes.
are
Ma'am,
what are the
I mean,
pharmacodynamic?
ma'am, there is, ma'am, in pharmacodynamics, ma'am, there is an increase in the concentration of alpha-1 acid glycoprotein.
Very good.
So
Okay.
the drugs which are weak such as lidocaine or non-depolarizing muscular blockade, these tend to bind with it and their free fraction is decreased. So that's why we have an increased requirement of these drugs. And burn patients, these are also have a tendency resistant to neuromuscular depolarizing, non-depolarizing muscular blockades.
See, you have to understand the difference between dynamics and kinetics. For all the students listening in, एक general answer बना के खिचड़ी नहीं पकानी है, please. When you are asking about pharmacodynamics, it means volume of distribution, it means binding, it means a lot of things which are related to the dynamic. जब kinetics पूछा जाता है, तो सिर्फ kinetics, for example, these patients have decreased affinity to beta adrenergic receptors. So they have decreased response to catecholamines.
Yes.
That's a pharmacokinetic response. Changes in volume of distribution, as Sugam has said, changes in protein binding is a pharmacodynamic response. They have decreased albumin and increase in alpha-1 acid glycoprotein. So the binding of basic drug increases and the binding of acidic drugs decreases. Okay, so basic
Yes.
drugs, as he said very nicely, lignocaine and muscle relaxants, there is a change. The requirement becomes more and the duration of action becomes less of non-depolarizing muscle relaxants. Any change in depolarizing muscle relaxants, since we are talking about drugs?
Yes, ma'am. Ma'am, we avoid depolarizing muscular blockade in these patients, ma'am, because there is an upregulation of just extrajunctional receptors of the acetylcholine and there is an increased surge of potassium ion. So we tend to avoid these drugs in these patients.
Okay. So what is the duration with which you can give scoline, since you've mentioned it, and when can you avoid?
Ma'am, the time of usually 48 hours till the 2 years. It says,
Okay,
ma'am, we have
so
to,
it is because of the proliferation of extrajunctional receptors, they become extremely sensitive. So up to 48 hours, this change hasn't taken place. So you can safely give scoline in acute burns.
yes, ma'am.
But then usually now the recommendation is 1 year, not 2 years. Up to
Yes.
1 year, you should avoid succinylcholine. Thereafter, you can give, but one, you should have potassium levels. You should have ECG monitoring, and you should have neuromuscular monitoring whenever you are giving
Yes.
scoline to a patient of major burns. It's not
Yes.
relevant in minor burns. Remember, that's why we had asked you what are major burns. So any increase burn surface of more than 35% burn surface area, total burn surface area, is where the problem with succinylcholine occurs. Minor burns में problem नहीं होगी.
Yes, ma'am.
Okay, you can give up to 48 hours. Between 48 hours to 1 year is contraindicated. More than 1 year you can give, provided you have neuromuscular monitoring, you have ECG monitoring, and you have the potassium levels. ठीक है?
Yes, ma'am.
और क्या changes होते हैं इन पे? और perioperative concerns क्या होते हैं?
Ma'am, these patients, they are very prone to hypothermia.
Okay, very good. They're prone to hypothermia. You must, as we've already outlined, we will not repeat that. Prone to hypothermia or?
Ma'am, extensive blood losses because total burn surface area which they are positive to
They
grafting,
are,
they tend to bleed a lot.
very good. They will have extensive blood loss. इसीलिए आपने blood grouping cross matching कराया. इसीलिए आपको blood arrange करके रखना है. इसीलिए आपको allowable blood loss का बहुत ध्यान रखना है इन patients में. ठीक है? Because इनको
Yes, ma'am.
preoperative anemia भी रहता है. You have to be very careful. You have to arrange
Yes, ma'am.
blood if there is involvement of large areas of the skin. Or, very good. Or?
Ma'am, ma'am, pain management, perioperative pain management for these patients.
उससे पहले. They have anemia, they have malnourishment, they have a hypoproteinemia.
Hypoproteinemia.
Okay? Yes. They have, as you said, tendency to develop hypothermia. They may have associated comorbidities. उसका भी तो ध्यान रखना है. Suppose
Yes,
patient साथ में diabetic, hypertensive होता तो, या asthmatic होता तो.
Ma'am,
So
then we,
associated comorbidities, then psychiatric issues. Many of these patients have undergone extensive burns, social isolation, disfigurement. They may be anxious, they may be depressed, they may have other psychiatric issues which need to be taken into cognizance. Okay, so
Yes, ma'am.
associated psychiatric issues, associated comorbidities, then you have, as you said, pharmacodynamic, pharmacokinetics में सब कुछ involve करना, albumin, glycoprotein, volume of distribution, resistance to muscle relaxants, ये सब आपके concerns हैं. ठीक है? They have increased metabolism. They are all catabolic patients, therefore they may need perioperative administration of parenteral nutrition and its consequences in the perioperative phase and postoperative. Okay. Now there are concerns for regional anesthesia in these patients.
yes,
अगर burn site ऐसी है, क्या पता आप regional दे ही ना पाओ. Regional में chances of infection are very high.
yes,
Okay? You may have large areas of the skin which need to be harvested, and no regional anesthesia may be suitable for large areas.
Yes, ma'am.
So concerns of regional anesthesia are also there in these patients. So ये सारे concerns आपको they're almost 10-15 of them. You must be able to outline each of these concerns in a patient who comes for contracture release. Okay. Now, one of the concerns you has mentioned was difficult airway.
Yes, ma'am.
Okay. Now, how do you assess the airway in these patients? And how do you identify what is difficult? Do you have a slide which you can show? This is such an important part.
Yes, ma'am.
आप बोलते भी जाओ साथ साथ अगर एयरवे में क्या क्या कंसर्न हो सकता है इस पेशेंट
Ma'am, okay. Ma'am, these patients have difficult face mask ventilation.
Okay.
Difficult
हम आइडेंटिफाई करते हैं कि इस पेशेंट में क्या क्या प्रॉब्लम थी इसका माउथ ओपनिंग रिड्यूस था देयर वाज माइक्रोस्टोमिया देयर इज रिस्ट्रिक्शन ऑफ नेक मूवमेंट देयर इज अ लार्ज फाइब्रस बैंड ऑन द चेस्ट all right मल्लम पट्टी could not be assessed you must be able to identify कि क्या क्या इस पेशेंट में प्रॉब्लम थी okay और उसकी वजह से what are the problems in management which you will experience कैसे करते हैं इन पेशेंट्स का एयरवे असेसमेंट सुगम
Yes.
कैसे करते हैं इनका एयरवे असेसमेंट
Yes, ma'am. Yes, ma'am. Ma'am, first of all, we will look at the generalized facial features, as you stated. Hello.
और बोलते जाओ बेटा
Yes, ma'am. Generalized facial features. We will look, ma'am. Ma'am, we will also look for the patency of nares patency, mouth opening, incisor distance. We will also look for the head extension fraction movement in these patients, which was restricted, particularly in my patient.
बेटा ऐसे रैंडमली नहीं बताया करो प्लीज आपसे सब स्टूडेंट से रिक्वेस्ट है कि प्लीज एक सिस्टम वाइज आप बताया करो इन अ ऑर्डर in a regulated manner in a specific manner अब आपने माउथ ओपनिंग और नॉस्ट्रल के बाद सीधा आपने नेक एक्सटेंशन की बात कर दी so there is a line of sight assessment
yes ma'am
line of sight assessment for assessment of the airway means जैसे जैसे आप देखते जा रहे हो वैसे वैसे बोलते जा रहे हो कोई निमोनिक याद करने की जरूरत नहीं है कुछ भी it is not you don't have to commit anything to memory as you see and as you proceed from front to back and from top to bottom so this is known as the line of sight assessment you will see the nostril, you will see the facial symmetry, you will see the maxilla and the mandible, you will see the nasal patency, then you can see the mouth opening, you can see the scarring, you can see the teeth, the dental hygiene, then you can see the neck, you can ask the patient to open the mouth, you can see the mallam patti, you can see the tonsils, you can see the palate, then you come down, you will be able to see the neck movements, you will be able to see the distances, and finally the neck circumference and access to the airway from the front.
Yes, ma'am.
So please don't go haphazard के एक बार nostril बोल दिया और उसके बाद सीधा आपने range of movement बोल दिया. ठीक है?
Yes.
और उसके बाद after you have done this line of sight assessment, you should be able to identify what in the airway is difficult. सिर्फ कहना है difficult airway is not enough. एयरवे में क्या डिफिकल्ट है आपको आइडेंटिफाई करना है एंड दिस स्लाइड शोज इट वेरी वेल इस पेशेंट में मास्क वेंटिलेशन डिफिकल्ट है लैरिंगोस्कोपी डिफिकल्ट है सुप्राग्लॉटिक डिवाइस डिफिकल्ट है ट्रेकियल इंट्यूबेशन डिफिकल्ट है एक्सट्यूबेशन या इमर्जेंस भी डिफिकल्ट होगा और इन्वेजिव एयरवे भी डिफिकल्ट है ठीक है सो वी बीन एबल टू डू a complete assessment and identify the areas of difficulty in this patient. Okay? अब ये पेशेंट आपके पास आ गया आपने हिस्ट्री ले ली एग्जामिनेशन कर लिया एयरवे एग्जामिनेशन कर लिया प्रॉब्लम्स आइडेंटिफाई कर ली इन्वेस्टिगेशंस कर ली कैन वी हैव अ लुक एट दिस पेशेंट्स इन्वेस्टिगेशंस अगर इसकी करवाई थी तो
yes ma'am
ये इसकी प्री ऑपरेटिव इन्वेस्टिगेशंस है फ्रॉम व्हाट आई कैन सी एवरीथिंग रिलेटिवली अपीयर्स नॉर्मल थोड़ा सा ब्लड शुगर बढ़ा हुआ ये रैंडम ब्लड शुगर है
yes
ओके, रैंडम ब्लड शुगर थोड़ा सा बढ़ा हुआ है, बाकी हीमोग्लोबिन कम है, रेस्ट एवरीथिंग इज नॉर्मल।
Yes, ma'am.
इस पेशेंट को एक्सेप्ट करना है एनेस्थीसिया के लिए कि कुछ चेंज करवाना चाहते हो?
Ma'am, we will accept this
We
patient.
will accept. So there is no need to treat this anemia pre-operatively. This much is acceptable.
Yes.
And we will take this patient under what ASA grade?
Ma'am,
ASA grade?
Ma'am, ASA class 1.
Why 1? Anemia है इसको?
Anemia, but there is not any underlying systemic disease.
लेकिन
or
anemia is
comor-
a systemic disease. Anemia is a
Yes.
systemic disease.
Ma'am, then it will come under the ASA physical class 2.
It will come under ASA 2. ठीक है, आपने ASA 2 में इस पेशेंट को एक्सेप्ट कर लिया। ठीक है, आप इसके क्या प्री ऑप ऑर्डर्स दोगे आप, और क्या आपका प्लान ऑफ एनेस्थीसिया है? What is your plan of anesthesia for this patient?
Ma'am, my plan of anesthesia for this patient would be awake nasal fiber optic intubation.
So nasal intubation, awake, fibroscopy.
Yes, ma'am.
हम बाकी प्लान्स की बात करेंगे। ये आपका प्लान ए आपने बना लिया। इसके लिए आप कैसे पेशेंट को प्री ऑप ऑर्डर्स लिखोगे? सो आपने इन्वेस्टिगेशंस बता दी, आपने प्री ऑपरेटिव कंसर्न्स बता दिए, अब आप इस पेशेंट को क्या प्री ऑप ऑर्डर्स लिख के दोगे पीएससी में?
Ma'am, I will order nil per oral for solubilities for 12 hours, clear liquids for 2 hours.
Okay, so remember that इस पेशेंट का डिफिकल्ट एयरवे है, इसको 6 घंटे 8 घंटे पहले आपने खाना नहीं खिलाना। Please remember, this patient needs a slightly longer fasting period for food. However, because they can get dehydrated, you can allow them water orally till 2 hours.
Yes, ma'am.
लेकिन please don't all the students say 6 hours for solid food or 8 hours for solid food, and इसको आपने थोड़ा सा फास्टिंग रखना है। यूजुअली अगर आप इसको सुबह कर रहे हो तो ओवरनाइट फास्टिंग इज एक्सेप्टेबल। हाउएवर फ्लूइड्स, क्लियर फ्लूइड्स कैन बी अलाउड अप टिल 2 hours।
Yes, ma'am.
ताकि डिहाइड्रेशन नहीं हो। ठीक है, सो एनपीओ स्टेटस और
Ma'am, apart from the written and informed consent for anesthesia, high risk consent.
written informed consent, high risk consent with consent for ICU management, consent
Yes,
for
ma'am.
shifting to ICU, and possibly elective ventilation if the area of burn is larger.
Yes, ma'am.
Okay, what
Ma'am,
else?
Ma'am, we will also ask for blood and blood group, blood products.
Arrange
since
for blood
they
and
tend to
blood
bleed a lot.
products.
Yeah.
Okay, or
Yes, ma'am. Anti-aspiration prophylaxis for these patients.
very good. It's a difficult
which
airway, so it is sensible to give anti-aspiration prophylaxis. क्या देना है और कब देना है?
Okay, ma'am, we can give tablet pantoprazole 40 milligram, 1 tablet HS, followed by 1 more tablet on the morning of surgery with sips of water.
Okay, morning of surgery at 7 a.m. you can give 1 tablet. HS you can give 1 tablet. What else? सिर्फ
Ma'am, along with
पैंटोप्राज़ोल
this,
चाहिए
we
या
will
कुछ और भी
also-
चाहिए? You want to give an
Ma'am, we can al-
anti-epileptic or a gastric
metoclopramide.
herring agent?
Yes, ma'am.
क्या?
Metoclopramide we can give, ma'am.
किस रूट से और
10
कैसे?
milligram.
10 milligrams?
Orally. Ma'am, orally.
और तो पूरा बेटा एक ही बारी पूरा बोल दो ना, इंस्टेड ऑफ द एग्जामिनर कंटिन्यूअसली आस्किंग यू कितना दोगे, किस रूट से दोगे, कब दोगे। जब आप प्री मेडिकेशन बताते हो फॉर ऑल द स्टूडेंट्स, please be specific on what pre-medication you wish to give, how much and with what route. So 10 milligram
Yes.
tablet orally on the morning of surgery.
Yes, ma'am.
Okay. जब आपने 7 बजे या 8 बजे इस पेशेंट को पैंटोप्राज़ोल दिया, उसी टाइम आप 10 मिलीग्राम्स ओरली मेटोक्लोप्रामाइड की टैबलेट दे दो। ठीक है?
Yes,
You
ma'am.
have a slide for pre-op orders, Sukam?
Yes, ma'am.
Okay. So NPO, anti-aspiration prophylaxis, consent for ICU stay. What else? Counseling and explaining the procedure is very, very, very important. Okay?
Yes,
Because these patients are undergoing a block or topicalization. You want to do an awake fiber optic. The consent counseling of the patient is extremely important, and there is no shortcut for this. This must be done in
Yes,
the
ma'am.
PAC, this must be done pre-operatively, and this must be done on the morning of surgery.
Yes, ma'am.
Okay? Any other pre-op orders? You've arranged for blood.
Yes,
What else?
ma'am,
No
antibiotics.
sedation is no pre-op orders. जो दोगे वो
Yes, ma'am.
लिखोगे ना, जो नहीं दे रहे
Yes,
वो
ma'am.
मेंशन करना है. ठीक है? आगे
Yes,
चलो.
ma'am.
Anything else?
Ma'am, lignocaine sensitivity. That is local anesthetic
Okay, fine.
sensitivity. we
What
can
else?
check.
What
Ma'am,
else?
ma'am, we will also pose this.
Okay. So
schedule
now that you've
this
given
case
this pre-op orders,
first in the-
okay, how will you prepare this patient for your plan A, which is awake fiber optic nasal intubation? How will you prepare this patient?
So, ma'am, we are going to do awake fiber optic nasal intubation. First of all, ma'am, we will explain the procedure to the patient. We will do counseling of the patient.
कर दिया ना वो तो?
Ma'am, second, yes, ma'am. Ma'am, secondly, we will decrease the secretions. Patient has already got an IV line, so we will give her injection glycopyrrolate 0.2
Okay,
milligram
wait,
IV.
wait, wait.
That
So
will-
आपने ये pre-op orders लिख दिए, आपने रात
Yes,
को
ma'am.
पेशेंट को पैंटोप्राजोल दिया, सुबह
Yes,
भी
ma'am.
पैंटोप्राजोल और आपने ओरल मेटोक्लोप्रामाइड दे दिया, और पेशेंट को ओटी में लाना है कि अभी ओटी में नहीं लाना? ये सब
Ma'am, first, ma'am, these are the ma'am. No, ma'am, not inter. This is the pre-op before going to the OT preparation, ma'am.
हाँ तो pre-op holding area में आप
Waiting area,
पेशेंट
yes,
को
ma'am.
लाओगे सुबह?
Yes, ma'am. Pre-op
तो
waiting.
अगर ये
holding area.
पेशेंट 9 बजे शुरू हो रहा है, आप 8 बजे इसको होल्डिंग एरिया में ले आओ.
Yes, ma'am.
You have a pre-op holding area or a pre-op room?
Yes, ma'am. We have.
Okay. So the patient is shifted to the pre-op area in the morning with an IV
Yes,
line.
ma'am. With ma'am, with
With an IV line, or if it's not there, then the first thing you should do in the pre-op area is to put an IV line.
Yes, ma'am.
That is the first thing you should do. I will shift the patient to the OT holding area or pre-op area and put an IV line if it is not already there.
Yes, ma'am.
After that, you will attach monitors. Pre-op में भी monitor होगा.
Yes, ma'am. We
Heart
have.
rate तो आप लगा ही सकते हो, saturation and heart rate.
Yes, ma'am.
उसके बाद अब आप ग्लाइको दो.
Yes, ma'am. Baseline vitals would be noted up, and then
Okay.
injection glycopyrrolate 0.2 milligram IV would be given, ma'am.
Okay, so 0.2 milligrams IV can be given once the patient has an IV line in situ.
Yes, ma'am.
Would you like to give an IM injection? Because that's the commonest question which the students end up asking me. कि आपने IV क्यों बोला और IM क्यों नहीं देना?
Ma'am, we will try to avoid IM in these patients. Ma'am, because it
Okay,
will further.
she already has an IV line. उससे आप fluid दोगे, उससे आप बाकी sedation दोगे. तो line तो patient को लगी हुई है, तो उसी line से आप IV दे दो.
Yes, ma'am.
I give another intramuscular injection to a patient that is painful also. And because the skin is so badly burnt and scarred, you don't know how much of muscle damage is there underneath. कोई muscle plane नहीं बचा, कैसा absorption होगा, कितना होगा, you don't know.
Yes, ma'am.
So from the photograph, I remember her upper limbs are completely burnt. The chest and the limbs are burnt.
Yes,
तो
ma'am.
कहाँ injection लगाओगे? फिर आपको थाई में लगाना पड़ेगा. So कितना absorption होगा, कितना muscle mass है, उसमें कितना scar tissue है, you don't know. When you
Yes.
have an IV line, then you give the glycopyrrolate IV and allow sufficient time for the anti-scope action to occur.
Yes, ma'am.
You give it a good 20 to 30 minutes for the anti-silagogue action to reach its effect.
Yes, ma'am.
ठीक है? तो आपने IV लाइन से उसको मॉनिटर लगाया, फिर आपने IV लाइन से फ्लूइड शुरू किया और साथ में आपने ग्लाइकोपायरोलेट लगा दिया.
Yes, ma'am.
कुछ और देना चाहोगे बेटा?
Ma'am, we will topicalize, prepare the airway for awake fiber.
कुछ और sedation नहीं देना. पहले topicalize airway. कुछ sedation दे सकते हो?
Ma'am, we can give midazolam.
You can नहीं, you should.
We will give midazolam.
Don't say can give. This is a word which has to be avoided by all students. You can do anything. What will you do? So you will
I
give
will-
midazolam. हाँ, you कितना दोगे, कैसे दोगे?
Ma'am, I will give injection midazolam 1 milligram IV.
Okay, you can give injection midazolam. Any other sedation you would like to give? अगर आप sedation time से शुरू करोगे तभी उसका effect आएगा.
Yes, ma'am.
ठीक है, आप पहले टॉपिकलाइजेशन उसके नाक में कुछ घुसेड़ दो, the patient will get too anxious. So you start the sedation before you pounce on the patient to do all the topicalization. आपने मुंह में कुछ डालना है, नाक में कुछ डालना है, करना है ना ये सब कुछ अभी। तो प्लीज आपसे रिक्वेस्ट है सब स्टूडेंट से कि आप पहले sedation बोलें। सबसे पहले ग्लाइकोपाइरोलेट, आईवी लाइन, फ्लूइड, ग्लाइकोपाइरोलेट, मिडाजोलैम। कुछ और sedation देना चाहोगे बेटा? कितना, कैसे, किस रूट से?
So I will give a loading dose 1 microgram per kg of body infusion at a rate of 0.2 to 0.7 microgram per kg per hour.
So you give a bolus of 1 mic per kg followed by an infusion of 0.2 to 0.7. Over 10 minutes आप बोलस दे दो और उसके बाद स्लोली इन्फ्यूजन शुरू कर दो। जब तक आप अपना बाकी काम करोगे तब तक डेक्समेट का इफेक्ट आ जाएगा। ठीक है, अब आप टॉपिकलाइजेशन बताओ। नॉस्ट्रल की पेटेंसी देख ली आपने?
Yes ma'am, bilateral nasal were patent.
ओके, तो अगर एक नॉस्ट्रल पेटेंट है तो सिर्फ वही प्रिपेयर करना है या दोनों प्रिपेयर करने हैं?
We will prepare both the nostrils.
You will prepare both nostrils, even if there is one less and one more patent. Please prepare both the nostrils. कैसे prepare करेंगे बेटा?
So first of all, we will perform the nasal decongestion using xylometazoline 0.1% concentration drops. 2 to 3 drops of this would be given in each of the nostril.
To be repeated 2 or 3 times.
Yes ma'am.
So you start early. That's why the patient is there with you. You put xylometazoline drops, 2 to 3 drops in each nostril, and repeat the process 2 or 3 times at an interval of 10 minutes.
Yes ma'am.
Okay, what else?
Ma'am, then we will use long cotton swab.
Long cotton swab क्या होता है?
Cotton pledget ma'am. Cotton pledget.
हाँ.
Cotton pledget. Ma'am, we will get it soaked into 2% of lidocaine and going parallel to the flow.
Lidocaine is a term the Americans use.
Lignocaine, ma'am. Lignocaine.
Lignocaine, okay.
Sorry.
With
2%.
adrenaline, without adrenaline?
With adrenaline, ma'am.
With adrenaline. पूरा बोलो ना. So lignocaine 2% with adrenaline से आप छोटे छोटे cotton के pledgets soak कर लें and then push them into the nostril पीछे तक posteriorly.
Yes, ma'am. Posterior.
This will produce local as well as vasoconstriction. Local anesthesia plus vasoconstriction.
Yes, ma'am.
ठीक है. What else?
Ma'am, then we will using 4 ml of 4% of lignocaine, we will nebulize the patient.
So we have prepared the nostril. We have caused decongestion of the nostril. Now we will take 4 ml of 4% lignocaine and nebulize the patient with an oxygen flow of 10 to 12 liters per minute. Please पूरा बोलना. 4 ml of 4% xylocaine nebulized using 10 to 12 liters of oxygen. अब ये जो आपने nasal preparation किया, इससे आपने कौन से nerves block किए?
So using the cotton pledgets, I have particularly blocked this phenopalentine ganglion, and by using this nebulization method, anterior ethmoidal nerve, which is the sensory innervation of the nose, that has been blocked.
Okay, so you must know the nerve supply of the entire upper airway. Okay, it's a very common question which is asked both in theory as well as in practice. But that's not enough. It's no step blocks nerves. Prepare the nose. You are basically trying to anesthetize the septum as well as the lateral turbinates.
Lateral.
Okay, so the greater palatine, the sphenopalatine, and the anterior ethmoidal nerves.
Yes, ma'am.
Okay, need to be blocked, and this is how topicalization blocks these nerves. Sphenopalatine ganglion के greater palatine, nasopalatine, and anterior ethmoidal nerve. You can read up कि ये किस nerve की branches हैं.
Yes, ma'am.
ठीक है?
Yes, ma'am.
उसके बाद आपने nebulization जो किया, उससे आपने क्या block किया?
So nebulization, we are blocking the nerve supply of the oropharynx, that is particularly glossopharyngeal nerve.
Okay, so you block the glossopharyngeal nerve. Anterior 2/3 of the tongue किससे supply होता है और posterior 1/3 किससे होता है?
Ma'am, the general sensation is the lingual nerve and the posterior 1/3 is via the glossopharyngeal nerve.
Okay, you must know what all the glossopharyngeal nerve supplies. So the questions can be asked in any manner. You must know कि glossopharyngeal nerve से क्या क्या supply होता है, और if the examiner asks you a particular structure, you must know कि वो structure किस nerve से supply होता है.
Yes.
So nerve supply, glossopharyngeal, for example, the tongue, the posterior and lateral pharyngeal wall, the vallicula, the epiglottis, the tonsillar pillar are all glossopharyngeal.
Yes, ma'am.
Posterior surface of the epiglottis.
Ma'am, again, this is superior laryngeal nerve derived from the vagus nerve. Ma'am, particularly internal
Exactly.
branch. Yes, ma'am.
Yes. So anterior surface is glossopharyngeal. Posterior surface is?
Ma'am, internal branch of the superior laryngeal nerve, ma'am.
Okay. So vagus. So
Yes,
जब
ma'am,
आप
vagus.
nebulize करते हो तब आप glossopharyngeal block करते हो, लेकिन posterior 1/3 of the tongue usually नहीं ठीक से block हो पाता.
Yes, ma'am.
So epiglottis की anterior surface is for gag reflex and posterior surface is for cough reflex.
Yes, ma'am.
Okay, so usually the base of the tongue and the posterior surface and is not usually well anesthetized. Hypopharynx is not well anesthetized with the mask. Can you do something else to take care of the glossopharyngeal? The parts which are left out by the inhalation, nebulization?
Yes, ma'am. Ma'am, we can use 2% lignocaine viscous solution, ma'am.
Okay, you can use gargling with the help of 2% viscous solution. Ask the patient to take 5 ml aliquots on a tray. Give him a thick straw to take it. If अगर mouth open है तो वो वैसे ही पी लेगा, अगर mouth closed है तो straw से ले सकता है. Then ask him to do it 3 times. The first 2 times he can swish it in his mouth and throw it, and the last time he can swallow that. तो उससे upper esophageal sphincter भी anesthetize हो जाता है. ठीक है? तो आपने नेबुलाइज कर दिया, उससे ग्लॉसोफिरिंजियल, आपने the posterior 1/3 of tongue as well as the posterior pharyngeal wall is also anesthetized with the help of gargling. ठीक है? Then the entire nerve supply you must know, above the cords, below the cords, superior laryngeal क्या सप्लाई करती है और recurrent laryngeal क्या सप्लाई करती है, ये आपको बहुत अच्छे से theoretically पता होना चाहिए. The remaining part of whatever is left will be supplied, will be anesthetized by the technique which is known as SEGO, spray as you go. तो अभी जो भी हमने किया ये कॉर्ड्स के ऊपर था, कॉर्ड्स के नीचे नहीं सप्लाई हमने अफेक्ट करी, हमने एनेस्थेटाइज नहीं करी. कॉर्ड्स के नीचे सप्लाई एनेस्थेटाइज करने के लिए आपको ट्रांसट्रेकियल देना पड़ता है. अगर आप ट्रांसट्रेकियल नहीं देना चाहते तो स्प्रे एज यू गो ऑल्सो हेल्प्स टू एनेस्थेटाइज द एरिया बिलो द कॉर्ड्स, जो रेकरेंट लेरेंजियल नर्व की सप्लाई है. ठीक है? तो आपने ये प्रिपेयर कर लिया, नेबुलाइज कर लिया, पेशेंट को नॉस्ट्रल प्रिपेयर कर लिया, आपने गार्गलिंग करवा ली, सेडेशन ले ली. अब आप पेशेंट को ओटी ले जा सकते हैं. आपने ओटी कैसे तैयार करना है फटाफट बताओ, ये रनिंग आउट. ओटी कैसे तैयार करोगे बेटा?
Okay. So, ma'am, we check all for the suction anesthesia machine. In particular, airway, we will prepare the difficult airway cart.
Okay, difficult airway cart आपके पास होनी
And we
चाहिए.
will prepare
अगर
for airway
examiner
cart apart
आपसे
from the generalized anesthesia monitor. Yes.
your machines should be ready, your fibroscope should be ready, your difficult airway cart should be ready. The difficult airway cart में क्या components हैं, the examiner can ask you. इस पेशेंट के लिए कौन सा फाइब्रोस्कोप तैयार करोगे और उस पे कौन से नंबर की ट्यूब रेडी रखोगे?
So I will prepare this Olympus fibroscope, which is available in our institution. 6 mm
There
of
is no
ID
need to
number.
take the name.
And
There is no need to take a name. आपके पास जो भी adult fibroscope, आपके पास outer diameter 5.5 वाला है. Okay, so adult fibroscope with an outer diameter of 5.5. Then you will take, इसका अगर nostril ठीक ठाक है तो 6.5 या 7 number की tube, depending upon the size of the nostril, can be softened can be deflated, can be lubricated, and then mounted
ma'am.
on your fibroscope. तो ये सब आपने
Yes,
बोलना है. It will be softened, it will be deflated, the cuff, and it will be well lubricated and mounted on the fibroscope.
Yes, ma'am.
ठीक है? Suction should be ready. Resuscitation
Yes, ma'am. Suction.
equipment should be ready.
Yes, ma'am.
And you should have your difficult airway cart ready. ठीक है? अभी हमने इतनी सारी लिग्नोकेन की बात करी थी. ये भी बता दो कि मैक्सिमम डोज ऑफ लिग्नोकेन कितना अलाउड है?
So for topicalization, it is 9 milligram per kg of body weight.
For topicalization, it is 9 milligrams per kg body weight. ठीक है?
Yes.
अब आपने पेशेंट को टेबल पे ले आए, आपने प्रिपेयर कर दिया, and you will start your fibroscopy with the most patent nostril. Preferably a senior or an experienced person should do this fibroscopy. If you
Yes, ma'am.
require more sedation, what can you do? और fibroscope में एक चीज रह गई बेटा बतानी, आपने उसमें सेगो के लिए कुछ तैयारी करनी है fibroscope में?
We will take 3 syringes and we will take 2 ml of 2% lignocaine solution in each. So we will, yes, ma'am.
It is preferable to take Xylocard at this time. आप syringe में Xylocard ले लें 2%.
Yes, ma'am.
Connected to an
Yes, ma'am.
epidural catheter which runs to the port which is meant in the fibroscope for.
Yes,
एक
ma'am.
port
For
होता है
say as
जिसमें
you go
से आप
technique.
biopsy-
Yes.
हाँ.
Yes.
Okay, working port जो होता है उसमें से आप एक
Working
epidural catheter डाल के रखें. Make sure that the tip of the epidural catheter is not protruding from outside the scope.
Yes.
Attach the syringe to it. Air-filled syringe with the local anesthetic, Xylocard here. Okay?
Xylocard. Yes.
Once you have done the scopy, identified the glottic opening, then you can introduce the endotracheal tube inside.
Yes, ma'am.
Okay. Then what you should do?
We will give the induction agent and followed by neuromuscular.
Induction. Okay, you can give something to increase the hypnosis. Okay.
We can also, yes, ma'am.
Connect the tube to the circuit. How will you check the placement of the tube?
Ma'am, by the confirmation of ETCO2 and also by
ETCO2 confirm करें. Okay. Check the placement of the tube by ETCO2, connect it to the circuit, start inhalational agents and give a muscle relaxant at this time now.
Yes.
We've already discussed कि हमने muscle relaxant ज़्यादा डोज में देना है और उसका duration of action भी कम होगा.
Yes.
ठीक है? Okay. Now after placement of
Yes,
the
ma'am.
tube, confirming the tube, placement of the tube, what are the perioperative concerns now in this patient? आपने patient handover कर दिया surgeon को, उसको अच्छे से tube को fix भी करना है. Make sure that the tube is
Yes, ma'am.
fixed well, confirmed, fixed.
Yes,
Then you hand over to the surgeon. What are the perioperative concerns now? Intraoperative, sorry, concerns.
Okay. Ma'am, extensive blood loss,
Okay,
development of
very good. Hypothermia,
pain
blood
management,
loss,
periop-
and pain. So would
Ma'am,
you like
perioperative.
to catheterize this patient? इसका काफी लंबी सर्जरी होगी.
Yes, ma'am. I will.
So after
I will catheterize.
you have done your intubation and everything is settled, you can request the surgeons to catheterize the bladder of this patient.
Yes, ma'am.
ठीक है? Okay.
Yes,
Now pain के लिए क्या देना है?
For pain, I will like to give IV opioids, ma'am.
Okay. Which opioid? How much?
I will give, ma'am, we can give morphine for this patient. It is about 1 milligram per
Again, we
kg
can
IV.
नहीं. I will give.
And
You can give morphine IV
I will give
in
ma'am,
good.
IV morphine.
Okay, IV morphine. Will you like to supplement it with something? Would you
Ma'am,
like to
I
give
can
some
also give,
paracetamol along with the morphine?
Yes, ma'am. I will give paracetamol also, 1 gram IV.
Are there any concerns for giving NSAIDs?
Ma'am, if the liver function is fine, there is no deranged renal profile, we can give NSAIDs. But
Is it
ma'am,
the liver you are worried about or is it something else you are worried about?
ma'am, NSAIDs,
अगर उसका क्रिएट 1.6 था लेकिन लिवर फंक्शन नॉर्मल है तो आप दे दोगे उसको NSAID?
no, ma'am, we won't give, ma'am.
Okay. So renal function is more important. So hematologically, you must see that the patient is okay. INR ठीक था, platelets कम तो नहीं थे, कोई और coagulation dysfunction तो नहीं था, ठीक है? और renal function अगर ठीक है, तभी आप NSAIDs दें, नहीं तो NSAIDs avoid.
Yes.
And multimodal analgesia is a better thing to do in these patients than just IV opioids. तो opioids को आप paracetamol और साथ में some form of local combine कर सकते हैं. They
Yes,
can be local infiltration, they can be wound, they can wash the wounds with a dilute solution of local anesthetic. All this can be done in combination with your IV opioids and your NSAIDs or paracetamol, whichever you are giving. Okay.
Yes.
If there is an area which can be managed with a block, तो
Yes,
आप
ma'am.
regional anesthesia भी साथ में दे सकते हैं. Okay. So pain is a very important component of the post-operative management of these patients. Anything else you should be careful in the post-op? Fluids, blood, management of hypothermia and pain. These are your main concerns.
Yes, ma'am.
ठीक है? Post-operatively, the patient should continue to be monitored in a high dependency area because they will have large areas which are bandaged. They will have fluid shifts in the post-operative period. The hypothermia will continue and the pain will continue.
Yes.
Would you like to shift this patient to the ICU?
I will shift this patient to the ICU.
Acha, before that, would you like to extubate the trachea on table? Is patient ka?
Ma'am, I will wait for the next 24 hours. I will not extubate this.
Okay, so if the burn area is very large, multiple
Due to the
skin grafting,
development of
extensive skin
the-
grafting has been done. If you find that there is a large bandage on the neck, there is restrictive chest deformity in the restrictive chest movements in the post-op, then there may be a lot of edema. As we said, कि hypoalbuminemia रहता है, आप fluids दोगे, तो there is increased chance of airway edema even in the perioperative period after so long. So you may like to take the patient to the ICU and extubate once the edema and the pain have settled after 24 hours. So elective ventilation may be required in this patient. Post-operatively, under controlled conditions in the ICU, you can extubate the trachea.
Yes.
Continue to monitor the urine output, look for blood loss, replace blood adequately, start early nutrition. Early enteral nutrition is recommended in these patients. Take care of the temperature and most importantly, take care of the pain. Okay. Now, suppose your plan A had failed. Was there a plan B?
Yes, ma'am. If our plan A has failed, ma'am, we can release the neck contracture using ketamine in sub-anesthetic
So
doses,
plan A or
and we
plan
can
B or
perform
plan
feeding.
C भी, yes, very good. बना के चलना है. As you said, plan B could probably have been a rapid release of the contracture under ketamine so that neck movements are reinstituted. And once the neck movements come through, you can put the laryngoscope in the patient's mouth or use a supraglottic device to take control of the airway and oxygenate the patient. कितना contracture कटवाना है, कैसे पता चलेगा? Is there a desi jugaad for that? You can, with the little mouth opening, you can put the laryngoscope in the patient's mouth, a video laryngoscope preferably, and ask the surgeon to cut the contracture with the laryngoscope in the mouth. जैसे ही आपको epiglottis या glottic opening देखे, आप surgeon को रोकते हैं कि अब I can intubate. सारा कटवाने की जरूरत नहीं है. It will completely disrupt the surgical planes and their subsequent surgical plan.
Okay.
Understood?
Yes,
And
ma'am.
then you can insert a supraglottic device or insert a video laryngoscope and manage the airway. The examiners may also ask you a term known as tumescent anesthesia. You know what that is?
So, in tumescent anesthesia, we give a very large volume local anesthesia into the subcutaneous plane, but particularly talking about this case to release the neck contracture. Ma'am,
So,
in this
उसका
case,
solution
a large
बनाने का
volume.
तरीका है?
Yes, ma'am. We 25 to 30 ml of 2% of lignocaine along with 1:1000 epinephrine concentration, which is being added in a 1000 ml sodium lactate. This is what we have prepared for this case.
So,
ma'am.
in a bottle of normal saline, you can add lignocaine and adrenaline separately, along with 1 ml of hyaluronidase.
Yes, ma'am.
And that dilute solution can then be used. इस patient में क्या tumescent anesthesia actually काम करेगा? हमें बहुत शौक है ये पूछने का.
No, ma'am.
But usually tumescent anesthesia, like they use very frequently in liposuction, requires well laid out or well defined surgical planes.
Yes, ma'am.
इसमें तो contractures बने हुए हैं.
Yes,
There
ma'am.
is so much of scar tissue, so much of contracture. You don't know where your planes are, so that subcutaneous and infiltration of the local anesthetic may not be very successful. Okay, okay. Thank you so much. We've practically discussed everything with burns. I think we'll give Akash 5 minutes. He's been waiting patiently to review the topic and give you the synopsis of burns and anesthesia. Thank you so much, Sugam. Over
Thank
to
you.
you, Akash.
Thank you, ma'am. Thank you. Sorry, election of 6
Hello, am I audible?
Yes, Akash, you're audible.
Yes, ma'am. After the detailed discussion on this topic, I would like to summarize this topic. In introduction, burn have a high rate of mortality and morbidity, and the management in acute stage of burn determines the survival rate of that patient. And a wide range of derangement in physiology of the patient warrant the proper understanding of to ensure the favorable outcome. A burn injury, which is caused by the application of heat or chemical substance to the external or internal surface of the body, which cause the destruction of the tissue. Application of heat may be direct or indirect. A minimum temperature of 44 degrees Celsius is required to produce the burn. The type of burn can be chemical, electrical, thermal, cold, or radiation burn. Uh, on the basis of depth of burn, the degree of burn is defined by the first degree burn, which is limited to the epidermis layer of the skin. In second degree, it is a partial thickness of the dermis. And in third degree, it extends up to the full thickness of the dermis. In fourth degree, it includes the muscle fascia and the bony structure. And there is a systemic involvement of the burn in major burn injuries. Almost every system is involved. Like in cardiovascular system, in initial phase, the patient goes into the shock where there is a hypovolemia and decreased cardiac output. And the late stage, there is a increased cardiac output and heart rate. And it is in the early phase, there is also capillary leak that will cause edema and increase in the third space volume of the fluid. In respiratory system, there is inhalational injury, airway edema, and bronchospasm. And in late complication, there can be a pulmonary edema due to the large volume of fluid resuscitation, and also cause the ARDS in some patient. And in renal system, there is a decrease in renal perfusion that can cause acute tubular necrosis. And in electrical burn, because of myoglobinuria, there can be acute kidney injury also. In GIT, because of decreased sphincteric perfusion, there will be ileus and stress ulcer may develop in this patient. So it is advised to deflate the stomach within 4 hours of the burn in, and also start the feed so that there is a decrease in bacterial translocation in such patient. And in the CNS, there will be a delirium agitation, and also some psychiatric disturbance can be seen because of the PTSD and depression, anxiety, and body consciousness. And in hematological system, there is a hemoconcentration and on coagulopathy, and that will increase the risk of thrombosis. And because of hemolysis and blood loss, there will be anemia also. And in these patients, immunosuppression is also a factor, decrease in cellular immunity. In endocrine, there will be a hypermetabolic response, increase in oxygen caloric requirement, hyperglycemia, increased catabolism, and nitrogen loss. Muscle.
Zoom ही नहीं है यार ये थोड़ा shit हो रहा है.
Thank you, Akash. Thank you, Ranju ma'am, for a very enlightening discussion. And thank you, Suga. Now, before moving to our next lecture on endotracheal tubes in the morning, we missed our
Ma'am,
lecture on ASA physical status.
go ahead.
So first, we would like to listen to the ASA physical status.
Go ahead.
Thank you, ma'am. Thank you so much. It was a very nice discussion, ma'am. Thank you for enlightening all the postgraduates and we all. Ma'am, your speaker
Actually,
is
the
off,
discussion
ma'am.
is not completed.
Unmute,
Sorry.
ma'am.
Thank you to Team Appec, and thank you Akash and Sugam.
Ma'am,
Thank you.
uh, ma'am, actually, my presentation is not over yet.
You want to
Ma'am, actually, my
continue your
presentation is not over
presentation?
yet. I can continue. I can continue.
Akash, are you continuing or should
Yes,
we
ma'am.
move to the next session?
I can continue, ma'am. Okay. In these patients, the
Sorry,
extent of burn
audience,
is
we missed
calculated by
part
rule
of
of
the
9.
session.
Yes, ma'am.
Continue, Akash.
According, yes, ma'am. According to the American Burn Association, the full thickness burn more than 10% of total burn surface area, and the partial thickness burn of more than 25% in the adult, or 20% at extremes of age, and the burn involving the face and hand, feet, and perineum. It is called taken under major burn, and the extent of burn can be calculated by rule of 9. And it is the chart given that is different for adult and infants, and the London border chart are more accurate, and Palmer method is used for the smaller areas of burn. And the role of anesthesiologist in this such patient is in a resuscitative phase, that is similar to the ATLS in ABC, where we'll try to secure the early airway. In breathing, we'll ensure the breathing and ventilation strategy. In circulation, we'll have an IV assist and provide the adequate resuscitation to such patient. And in stabilization phase, the burn dressing analgesia services are provided, and in reconstructive phase, there is a release of burn contraction is done. And, coming to the fluids, the IV fluid resuscitation, the 15% of total body surface, and burn smoke inhalation. The Parkland or group formula are mostly used, and it is titrated and urine output rather than just solely depending on the Barclay formula or any other fluid resuscitation formula. And in under resuscitation, there will be impaired tissue perfusion and on end organ damage, and extension is given. There will be over resuscitation and electrolyte disturbance, hyponatremia. And also, there is a abdominal compartment syndrome if the fluid is given more than 250 ml per kg in 24 hours. Uh, uh, Here will also fluid creep. This is and compartment syndrome. The mortality extension of the burn injury. Factor responsible are overestimate the burn size, emphasis on supraphysical hemodynamic target period utilization. The strategic is initiation of perfusion capillary is restored, and use of tonic saline can cause nutrition cautious use. And the role of colloid in detecting a fluid creep reduce the overall fluid volume and mitigate the fluid creep. The endpoint of resuscitation should be seen as 0.5 to 1 ml per kg per hour of urine output, and the blood pressure target should be more than 70 Hg, and venous pressure monitoring, and there should be blood urine nitrogen and creatinine ratio should also be followed. And the pain management is an important aspect of the burn, and the better oxygenation and fluid resuscitation improve the patient outcome, and followed by there can be multiple type of pain and background pain that is the whole day of the after break with the sudden increase in pain and procedure during any procedure and post-operative chronic pain will be there. Because of the increased opioid is being given, there is tolerance may develop in such patient, and there is also altered kinetics, and opioid-induced hyperalgesia and respiratory depression can be caused. The assessment tool that we can use is a numeric rating scale and visual analog scale and behavioral scale in pediatric patient. And pharmacological can use opioid, ketamine, gabapentinoid, alpha 2 agonist, and PCM is also uh, for opioid sparing agent. And NSAID should be used with caution as it can cause renal impairment. And regional technique can be used if it is accessible and there is a low risk of sepsis in these patients. And also we can add the non-pharmacological adjuncts such as psychological music therapy and virtual reality and for distraction in the therapy for children. The best practice would be use of multimodal analgesia and regularly reassess the pain and adjustment of the individualized care plan should be in reconstructive phase. Because of the persistent edema, wound infection, poor posture and position, prolonged immobilization, and inadequate skin coverage, there is a development of the fibrotic deformity in such patient. And the problem associated with the contracture of neck is grossly restricted neck movement. Patients are likely to be malnourished, anemic, hyponatremic, possibly of restricted mouth opening and narrow nasal passage, difficulty laryngoscopy under tracheal intubation, difficulty in putting the supraglottic airway devices and surgical airway access. The patient also has psychiatric tendency in such patient because of the trauma of post-traumatic stress disorder, anxiety, and there can be a possible drug interaction during anesthesia. The period of evaluation is being discussed in very detail, and so we come on optimization of such patient. The optimization, the hemoglobin and hematocrit to be optimized, and correction of dyslipidemia, and optimization of fluid balance and adequate fluid resuscitation should be provided prior to the and correct hyponatremia, prevent and treat the infection, and antibiotics are given. And there should be psychological support and pain management. Anesthetic challenge for such patient is difficult intravenous access, difficult in placement of monitoring device, airway management, fluid and electrolyte management, alteration in pharmacodynamics and pharmacokinetics of this patient, and choice of drug muscle relaxant, hypothermia, and increased susceptibility to infection. For IV access, there will be edema, scarring, infection. So the surgical debridement may be required just prior to placement of the vascular catheter, or we can place the central line. Surgical cut or shifts route can be taken, can be assessed, and also ultrasound guidance can be used. And there will be difficulty in placement of the monitoring device. So the ECG lead can be placed on the posterior surface of the body or with the surgical clips, or for SpO2 monitoring, there can be other places can be used other than the fingertip, and for uh, uh, for continuous BP monitoring, there can be invasive arterial line can be inserted. Assessment of airway is absolutely essential for the safe airway management, and focus history should be taken. There are numerous scale described for the airway assessment. Then, in which line of sight method, from which nose, malar region, cheek, mouth, teeth, and oral cavity, lower jaw, and mandibular space are assessed, and USG can also be used for imaging of such patient. Our plan of anesthesia will be awake fiber optic nasal intubation, and plan B neck contracture release under ketamine followed by video laryngoscope, and plan C will be tumescent anesthesia for contracture release followed by video laryngoscopy. In airway management, the patient preparation and counseling is very important. And to allay anxiety, we can give the midazolam. And to clear and dry the airway, we'll give anticelluloid such as glycopyrrolate that will decrease the secretion and ensure the local anesthetic agent used for topical anesthesia don't get diluted. For prevention of aspiration, we will give anti-aspiration prophylaxis. And for pre-medication, dexmedetomidine and midazolam we can give, and we'll properly topicalize the airway so that there is a less disturbance and less discomfort to the patient and airway. The post difficult airway card should be prepared, and in such patient there is a there are pharmacodynamics and kinetics of the drug are disturbed, and opioids there is increased requirement because of the hypermetabolic state and opioid tolerance develop in such patient. In ketamine there it can cause myocardial depression, hypotension, and increased requirement after 48 hours because of the proliferation in NMDA receptor, and thiopentone can cause hypotension, propofol, etomidate, and these are harmful. Okay, temperature management should be done, and patient should in post-operative period the analgesia and location and warm room should be given. Physiotherapy is very important, and aseptic precaution should be followed, and patient should be isolated to avoid infection, and watch for the signs of sepsis, and proper prognostication should be done. Thank you.
Thank you, Akash. Now the chairperson for the next session is Dr. Sanjay Agarwal. Can we have the CV slide of sir? Sir is professor and head of the AIMS Rishikesh, and sir has various achievements. Sir is fellow of Airway Management Foundation, more than 100 index publications, 5 chapters in a book, and sir is examiner for MD, PDCC, DM, and DNB. And sir is an instructor of AHA and ATLS and member of governing, sir is a governing council member of ISNACC, and sir's area of interest is neuroanesthesia and airway management. Over to you, sir.
A very good afternoon to you all.
Good afternoon, sir.
Thank you, the organizers, for inviting me to chair this session. And in this session, we have 2 lectures. The first is by Dr. Anjali Kochar, who will be talking about the endotracheal tubes, the laser tubes, and the microlaryngeal tubes. And Dr. Anjali is an associate professor at VMCC and Safdarjung Hospital with an area of interest in simulation in anesthesia, airway management, teaching, training, and innovation in anesthesia. So over to Dr. Anjali for her lecture on airway equipments.
Thank you, sir, for the nice introduction. And my topic is on endotracheal tubes. I am sharing my slides. So is the screen visible? Kindly
Your
inform.
screen is visible, not only.
Thank you, sir. Hello, all the students. So the topic is endotracheal tubes. And as you know, this is equipment that is kept on for the table viva. And I will try to cover all the questions that are asked related to standard endotracheal tube or specialized endotracheal tube in the exam. Endotracheal tube, as we know, is a device inserted through larynx into trachea to deliver oxygen and anesthetic gases and serves as a connection between the breathing circuit and lungs. It's a definitive airway for emergency as well as elective procedures that include resuscitation, delivery of anesthesia, as well as mechanical ventilation in the critical care setup. As we know, endotracheal tube and orotracheal intubation is the gold standard for airway management. Now, whenever you are given the endotracheal tube to describe in the table viva, hold the tube in the anatomical position. That is, you will hold the tube as you will hold it for the orotracheal intubation in the same manner and start describing it, the material it is made of, the size, and then start identify the patient end and the machine end and start describing from one end to the other end. For example, we can start from the patient end to the machine end and try to pronounce all the parts of the tube. The examiner can always interrupt you and ask you about the specific question that he or she is intended to ask. So the parts starting from the patient end, which is also the distal end because it is away from the operator, starts with the bevel, the Murphy eye, the cuff, the curvature of the tube, inflation line with its pilot balloon, markings of the tubes are there, and there is a standard 15 mm adapter or connector at the machine end of the endotracheal tube to connect it to the embu bag or the anesthesia circuit. With regards to the endotracheal tube, you may be asked questions, what material the endotracheal tube is made of. So there are various materials that can be used. Previously, red rubber tubes were very, very common in use. And nowadays, we know we use polyvinyl chloride tubes, which are made of PVC. The ideal endotracheal tube material should always have a low cost, should not cause any tissue toxicity, should be transparent so that we can see the secretions, the breath, and any other things. It should have sufficient strength so that the wall is thin. If it's a very thick wall, then the internal diameter will not be as big. Tube should have thermoplasticity so that it can conform to the patient's anatomy. It should have sufficient body to maintain its shape during insertion and to prevent occlusion by any excessive pressure or rotation. It should not react with the jelly, lubricant, or anesthetic agents. It should not catch fire if we are using laser. And it should allow smooth passage of suction catheter or bronchoscopes without causing any trauma. More commonly, we are using disposable tubes, but in case of specialized tubes, we do reuse them, but we should be able to sterilize the tube if it's a reusable one, and the tube material should be durable to undergo repeated sterilizations, and tube must be latex free to avoid the risk of allergic reactions. So all these qualities are difficult to match, but commonly we are using PVC tubes that are made of polyvinyl chloride, which is a polymer of vinyl chloride monomer. And we know it is a disposable endotracheal tube. It has several advantages. The first of all, it is transparent. So it allows observation of the breath or the tidal volume or the respiratory moisture, as well as any secretions or blood or any vomiters if is there in the lumen of the tube. Other advantage of this PVC tube is that it is stiff enough at room temperature to allow intubations easily, and in the body, when the temperature is 37 degree, it tends to conform to the patient's airway as it softens a little bit. Also, you must have seen that for nasal intubation, we try to keep this tube in the little warm water so that the tip softens and to avoid the nasal trauma to the turbinates and nasal mucosa when we are planning for nasal intubation. Also, this tube has a smooth surface, and thus any suction catheter or bronchoscope when passed through the endotracheal tube facilitates easy passage. And this is also less likely to kink as compared to the rubber tubes. Also, that as compared to the rubber tube, this PVC material, we can easily embed some material which is radio opaque, as PVC is now radio opaque. So we embed material to make it radio opaque so that X-ray it can be easily visualized. So this advantage is there with PVC against the red rubber tube, where this facility is not available. Also, the inflation line, it can be placed just outside the tube, and it can be secured. It doesn't come off easily. So that is also another advantage of PVC material. Also, it is inexpensive and it is compatible with the body tissues. However, it has certain disadvantages, that it is rigid, it can cause trauma, and all we know is why we are moving away from orotracheal intubation and using supraglottic devices is that risk of sore throat is there whenever we use endotracheal tube for orotracheal intubation. Coming to the red rubber tubes, they are mostly made of natural latex. Their advantages include that they are reusable. They can be sterilized, they can be cleaned, they are rigid. So even blind nasal intubation is easier, and at the same time, they are less traumatic because they are made of rubber. The problems with red rubber tubes are that they are non-transparent, they become sticky and harden with repeated use, and they kink very easily. They also can get clogged by dried secretions. And if the patient had secretions, we can't even see that within the tube there are secretions, and there may be tube block. And they don't soften at the body temperature. So the same stiffness remains inside the body for the period the tube is inside the patient. And there is a risk of latex allergy. This is Oxford tube, which is a preformed red rubber tube. So all uncurved as well as curved varieties of the red rubber tubes are available, both straight as well as the preformed ones. But they are out of use nowadays because we have better material available for endotracheal tubes. Silicone endotracheal tube is, as we know, silicone is a synthetic material made of polymers of siloxanes. So silicone is sometimes also a layer of silicone is coated over the PVC endotracheal tube to siliconize it, but they are fully also made of silicone. Some of the tubes, particularly the laser tubes, tubes used for endotracheal tubes used in the laser surgery, as well as the endotracheal tube that comes with the intubating LMA. They are made of silicone. The advantage of silicone is, first of all, it is latex free, and it can be sterilized and reused multiple times. The disadvantage, of course, they are a little expensive. And again, because the silicone material is non-transparent, we cannot see the secretions or the patient's breath through the tube. There are some other materials used for endotracheal tube making. For example, polyethylene. Polyethylene is a polymer of ethylene monomer. This material is used in specialized endotracheal tubes. This material serves as a base material where go for antimicrobial coating or embed silver nanoparticles. As we know, the VAP is a common ventilator-associated pneumonia is a common problem in the ICU setup. And coating with silver nanoparticle has been shown to decrease biofilm formation and decrease the incidence of VAP. So with the polyethylene material base, this serves as a base for embedding antimicrobes as well as the silver nanoparticles. So that is the use of polyethylene endotracheal tubes. Then we have nylon material, which is kind of a nylon coil or a mesh is used for the tubes which are used for the microlaryngeal surgery, again a specialized tube. Teflon, again specialized use in laser surgeries for the endotracheal tube making. And steel. Tubes are now not manufactured anymore, but Norton laser tubes are made of steel rings, and they are reinforced and used for laser surgery. And this is the only material that is laser resistant. So these materials, as of course I told you, they are used for specialized endotracheal tubes. Coming to the endotracheal tube design and the anatomy of the endotracheal tube, as we have already covered the parts of the tube, the examiner may ask you little in detail about each of the part. For example, the bevel. As we know, bevel, it is located at the patient end, and the angle is 38 degree plus minus 10. It is located on the left side because we need to have continuous visualization of the glottis when we are intubating the trachea. So when we do direct laryngoscopy, we keep the bevel is situated on the left side. It helps in the continuous visualization. The Murphy eye is located on the opposite side of the bevel of the tube, and this is kind of a hole and which provides an additional vent. Suppose the main hole through which the ventilation is happening gets blocked by the patient's secretions, or sometime if the tube is too far in, it may be hitting the carina. So the ventilation can still continue through the side hole. That is the Murphy eye, introduced by Dr. Francis J. Murphy in 1941. However, the problem with the Murphy eye is that sometimes there is a risk of a tube changer or fiber scope may go through the Murphy eye and get stuck into the tracheal wall rather than going straight into the glottis. So that can be one issue with the Murphy eye. So some tubes are there without the Murphy eye. They are called McGill tubes. And the advantage of that McGill tube is that cuff can be placed slightly closer to the patient end or the tip, and it can decrease the risk of inadvertent bronchial intubation. The curvature of the tube, as we know, the tube takes the shape, takes the anatomical curve that matches the natural curvature of the oral cavity, and it has a radius of 140 plus minus 20 mm. So this is to match the normal anatomical curvature, and Sir McGill introduced this curvature in the endotracheal tube because he started making tubes from the rubber. And then, you can imagine that rubbers also have a natural shape. So from there, they use this McGill curve in this for the making of the endotracheal tubes. Also, this round shape of the tube also decreases the risk of kinking because the elliptical and oval shapes are more prone to kinking as compared to round shape. The cuff of the tube, there can be two types of cuff. Either it's high pressure, low volume, or high volume, low pressure. So high pressure, low volume, it was previously there with the red rubber tubes. And also nowadays, the silicone endotracheal tube that comes with the intubating LMA, that has a high pressure, low volume cuff. The difference between these two types are that the high pressure cuff, it inflates in a, as we know, this is the trachea. This picture, this here, it is a trachea. As you can see, it is a D-shaped thing. And the high pressure cuff, when we inflate it, it takes a round or the circular shape and it distorts the trachea. And as you can see, the point of contact is very less with the tracheal wall. So less point of contact, it needs to put more pressure to make a seal with the tracheal wall, and hence there is a risk of ischemia to the tracheal mucosa, which is very, very sensitive. As the pressure increases more than 30 centimeters of water, the impaired capillary perfusion happens. So if we have intubated the patient's trachea with a high pressure, low volume cuff tube, we should not keep that tube in situ for prolonged period. We have a patient going for post-op ventilation. We are we have intubated the patient for ICU management. Then this is not the cuff of choice because there is high risk of ischemia of the tracheal wall. Whereas the high volume, low pressure cuff, as it with the PVC tubes, it is thinner, area in contact with the tracheal mucosa is large. So the less pressure is exerted, there is less risk of tracheal ischemia, and it also provides adequate seal by conforming to the irregular borders of the trachea. So the choice when it comes, it is preferable to use high volume, low pressure cuff tubes. There have been some modified cuffs available, like a foam cuff that is made of polyurethane or silicone. It is also high volume cuff. It has a larger contact area, so the pressure exerted is less and also provides a good seal. This foam cuff comes with the silicone tubes that are used for laser surgery. We will talk about it in later slides also. Another modified cuff is a lance cuff, which is a kind of a cuff inside a cuff. There is a pressure regulating valve inside this pilot balloon, which is made of latex, and it sort of auto regulates the pressure and keeps it fixed around 30 centimeter of water. So prevents both under as well as the overinflation of the endotracheal tube cuff. So as we know, there's a lot of discussion about the use of cuffed versus uncuffed tubes in pediatric age group. They have certain advantages as well as disadvantages of using cuffed or uncuffed tubes in pediatric age group. But I will not be covering this topic in detail. Then moving on to the cuff inflation system. This part of the endotracheal tube, the cuff inflation system, it has an inflation line which is located outside the ETT lumen. It has a very small diameter, which is less than 2.5 mm. Along with it has a pilot balloon, which also has certain markings, particularly the tube size, the inflation valve, and it is a one-way spring valve. The spring is there, and there is a valve here, which is a Leolock type of valve to which we attach our syringe when we have to inflate the cuff. And we have to make it rotate the syringe to make a good lock it with the Leor lock and inflate the cuff and then disconnect the syringe, and it's a one-way valve, so there will be no air leak after we have filled the cuff. Old red rubber tubes, they did not have this kind of technology, so they either need we had to clamp it, or there was a plug available to keep the air inside intact. So this is the good afternoon, everyone. I think there was some interruption. Can I restart?
Yes, please. There was some interruption and you can restart.
Yeah.
You can start from.
Yes. Yeah. So coming to the cuff pressure, so we were talking about the cuff inflation system, and we talked about the PVC cuff, the newer version and the old ones. Now as we discussed that ideally the cuff pressure should be kept between 20 to 25 centimeters of water, and it should not exceed 30 centimeters to avoid injury to the tracheal mucosa. So to keep that pressure in check, we have this cuff pressure monitor. As intraoperative also, initially, even if you have kept it to 20, then intraoperative also it may increase, because we mostly use nitrous oxide with our anesthesia gases. It may change because of the head tilt, coughing and straining by the patient, or sometimes the pressure by the surgeon's hand is there. Even at high altitude, there is because of the low pressure, the cuff pressure may go up. So cuff pressure monitor, it helps us to keep the pressure in check. And other methods can also, so one should always keep the pressure in check. So as you can see in this video, there is a red button here. Sometimes it is here, and some monitors it is on the side. And you can easily, you can see that pressure was around 60, and with the use, we can reduce it to between 20 to 30. That is the green zone where we should keep it ideally. So to limit rise in intra-cuff pressure, one is monitoring it at regular intervals, use the cuff pressure to adjust, use minimal occlusive volume. Don't fill a larger volume in the beginning. Saline can be used instead of air. And even the modified cuffs that we are talked earlier, they can also be used in a high-risk situation. So the markings on the tube, there are several markings on the tube, as you can see. Starting from the patient as you can see, there is a black mark here. In fact, there are two black marks in this tube. So they can be either a continuous black marking, or there can be two marks, or there can be a single black mark in some of the tubes. So the idea is that this is the length that should be inside the vocal cord. So this black mark should be just inside the vocal cords. That tells about the position of the endotracheal tube. Then we have maybe the manufacturer's name, the internal diameter and the size of the tube. Then the outer diameter also needs to be mentioned on the tube, and there should be a standard outer diameter because we want a thin-walled endotracheal tube. There should not be a large difference between the internal and outer diameter, because as we know, the resistance to the airflow is inversely proportional to the radius. So if the radius of the tube it decreases, then the resistance to airflow is going to be high. So the difference between ID and OD should be minimal. Then in the markings, we have the markings related to the length of the tube, which typically start around where the inflation line connection is there at the same difference of 2 centimeters. Whether the tube is for oral use or nasal use. Nowadays, the endotracheal tubes there is a single tube that can be used either through the oral or the nasal route. There is no difference. No difference is there. Whether the tube is single use or reusable, that mark should be there. And also there needs to be a quality check mark, which is not there in this tube. But definitely Indians also, they are supposed to follow the ASTM, that is American Standard of Testing and Materials for making of endotracheal tube. And also the implantation testing in the tissues is also done before making the endotracheal tube used in the patients. So Americans and Europeans, they have their own standards, and Indian still it is not standardized, but it is supposed to follow ASTM standards. Towards the machine end, we have a connector, which is made of plastic material. It has 15, it is a universal male connector so that it can be easily connected to the bag mask, circuit, anesthesia, or ventilator circuit. Having one standard size allow interchange between the devices. And if it's a removable, it is better, because sometimes we have to pass the endotracheal tube via supraglottic devices and for use of intraluminal catheters as well. Also in pediatrics, sometimes, although these days this we don't cut the endotracheal tube size to reduce the dead space, but previously this practice was there. So with a removable adapter, it becomes easier to resize the endotracheal tube whenever the need is there. Now, how to select the appropriate tube size for the patient? There are several formulas, but typically neonates and infants will be using 3 to 3.5 mm sized endotracheal tube. And children, we have formulas for children age less than 6 years, it's age over 3 plus 3.5 mm Ig. And for age more than 6 years, age divided by 4 plus 4.5 MMID. Modified Coles formula can also be used to calculate the size of the endotracheal tube. Approximately this is for the internal diameter. So if you look at the little finger of the child, then you can estimate the outer diameter within the endotracheal tube. But that is a rough estimate and should not be your first answer to the examiner. We all know that adult male will take 8 to 8.5 mm size tube, and for female 7 to 7.5 ml. And for nasal intubation, we cut down the size by 0.5 to 1 mm as compared to the oral endotracheal tube. To tube depth or the tube insertion length, again there are certain formulas, but adult male patient, it is usually between 22 to 24 centimeters, and for female patient 18 to 21 centimeter. For nasal intubation, another 4 to 5 centimeters needs to be added for the added length. Children, although there are several formulas that are given in the literature, and still we see papers coming with to where to fix the tube in a neonate or a infant. But commonly I use is age divided by 2 plus 12 centimeter. This is the formula that I use more commonly. And thus rough estimate is the 3 times the size of the tube. If you have taken a 4 mm ID tube, you can fix it at maximally at 12 centimeters. Definitely you need to use other checks, bilateral auscultation, recheck the position of the tube with change in position, creation, pneumoperitoneum. Monitoring is very important, the peak airway pressure, end-tidal volume, saturation, and end-tidal CO2. And in ICU patients, X-ray is also a good guide. Then the tube tip should lie 4 centimeter above the carina. That carina we know is at the level of T4. Now, this was most of the questions related to the standardized endotracheal tubes. Now we have specialized endotracheal tube, which is the second part of the presentation. The first tube here, as you can see in the picture, is the armor tube, also called the flexometallic tube. These are reinforced with the steel wires. These are all steel wire causing doing reinforcement and making it flexible. So this tube is also called reinforced tube. As you can see, there is no Murphy eye with this tube, and the tube tip is not having any steel rings because it can be traumatic to the patient to have it till the tip. Also, the connector with this tube is usually non-detachable. As it is a flexible tube, so it needs a stellate while insertion. And most commonly it is used for head and neck surgery, where the anesthesiologist will be staying away from the head end of the patient. So it is easy to fix it anywhere towards the head side, away from the patient. Also used for submental and retrograde intubation. The advantage is, as it's flexible, it is kink resistant, and good surgical access can be provided by fixing tube away from the side. However, it is difficult to insert it without the use of stellate, and it is not suited for nasal intubation. Because of the recoil property of the steel rings, there is a risk of accidental extubation. I think it's just theoretical thing, because we have used it we are using it all the time rather in head and neck surgery, so there is no problem. It is not suited for prolonged ventilation. It should not be kept in situ for long periods, cannot be cut, and it can be deformed if there is a patient bite. Another armored tube, which is intubating LMA endotracheal tube. This tube, as you can see the shape, it is a straight tube made of silicone. It is also wire reinforced. The end is very typical. It is tapered, it is blunt, so as to avoid any trauma when we are inserting this tube through ILMA. As because this, when we are using it through the ILMA, it is likely to hit the anteriorly in the larynx. So the tip has been modified to avoid any trauma. This comes with a detachable connector, because after insertion of the tube, we will have to remove the ILMA over the tube. That is why the metal connector needs to be detached, and it is a reusable type of tube. Then we have RAE tubes, which are preformed. The full form for RAE we know is ring, Adair, and Albin tubes. They have a preform curved at the length appropriate to the size of the tube. So suppose we have a size 7 tube, to around 21 centimeter we need to fix it. So at that point there is a preformed curve. So we have a oral tube, which is south pole, and we have a nasal tube, which is north pole. And mainly it is used for the in pediatric, both cuffed as well as uncuffed tubes are available. For example, if we have a pediatric patient coming for a cleft lip or palate surgery, we will use an oral or the south pole tube fixed in the midline. So that will also keep the tube away from the surgeon, because surgeon will be at the head end. And also it will give the surgeon some hint at the symmetrical position of the when they are doing the lip reconstruction. So they will know where is the midline and how to symmetrically construct the lip. North pole nasal tube, more commonly used for the surgeries around the mandible. If there's a mandible fracture, we can fix the tube towards the nasal end, and this lower jaw can be fixed. Also, these tubes are used for head and neck surgery. The advantage is mainly the good surgical access, but as because of the curve, the suctioning becomes very difficult, and they may offer higher resistance as compared to the normal endotracheal tube. And because this curve is prefixed and one size doesn't fit all, so there can be some anatomical variations, so it may not fit the patient perfectly. Specialized pediatric tubes, we have a Coles tube that is having a tapered tip. You can see the tip is tapered, used for neonatal resuscitation. And the microcuff tubes in pediatric age group, where there's a concern about the subglottic placement of the cuff. This microcuff tube comes with high volume, low pressure polyurethane thin cuff, especially designed for pediatric age group. The microlaryngeal tubes, these tubes are suited for microlaryngeal surgery where the airway is narrowed or there is some growth, vocal cord polyp, and also the surgeon is also working around the same area. So we use a smaller ID tube with the same length as if the patient is adult, the length of the tube is as for an adult, but the internal diameter is around 4 to 6 mm to give surgical access to the patient around the vocal cord area. This comes with a thin, high volume, low pressure cuff to avoid any trauma or injury to the tracheal mucosa. Problems with these tubes are, though they provide a very good surgical access, but they offer high resistance. The exhalation may be incomplete, and also they can be easily occluded by the secretions. If you have a patient with COPD or asthma, then the airway pressure may be very high. High airway pressure may be required to ventilate the patient. Another tube that can be used for microlaryngeal surgery is the Hunsaker-Monjet tube, though I have not personally used this particular type of tube, but it is used along with a jet ventilator. Because sometimes the surgeons wants flowless, like they should not be much flow in during when still area for the surgery. So that time, as you know, the jet ventilation, it's a very small catheter type of a tube, which is placed in the subglottic area, and it has two connections. One is for ventilating, and this is the tube through which the ventilation will be done. After the insertion, the stellate is removed, and this is the plastic sheath. It will keep the jet of the jet ventilation tidal volume in the center to avoid trauma to the tracheal mucosa. And there is another line which is for the monitoring of the carbon dioxide levels and airway pressure. As we know, jet ventilation, there is risk of CO2 retention. So that monitoring is very, very important. Again, this tube is used for microlaryngeal surgery. Another tube that is used in the ENT setup when the patient is coming for laryngectomy particularly is laryngectomy tube with a J shape. You know, the tip is curved like this. So you might have seen laryngectomy cases, the tracheostomy is done intraoperatively. And once we shift from the oral tube to the tracheostomy tube, it becomes very difficult to fix the anesthesia circuit around the tracheostomy tube. And it makes a right angle, prone to disconnection as well as obstruction. So this tube is armored also. It has short tip, so it can be easily inserted to the tracheostomy site and can be connected to the anesthesia circuit slightly far away from the surgical site. So that is the advantage of laryngectomy tube. Now, certain tubes, they help us with the patients who have anterior larynx, particularly when we are using video laryngoscope. You know, it is difficult sometimes to pass the tube through the vocal cords. We have a good vision, but we cannot intubate the trachea because the tube is either going posteriorly. So these tubes, they have, one is the endotracheal tube, which has a trigger loop. This is the loop that, as you can see, we will pull the loop like a trigger, and the anterior portion will get flexed, and it's likely to be, the intubation is likely to be more successful. Similarly, this endoflex tube, this has this slot, we can hold from here, and this tip of the tube is going to bend. helps with the blind nasal intubation in cases where the larynx is anterior, and in cases where we don't want to move, do any head extension. There also the bendable distal tip is likely to be more successful in intubation of the trachea. Another modified tip, this Parker flex tube, where you can see the typical beak-shaped tip of the tube, which is very soft also. And cuff is also thin and polyurethane made. And this tube also comes with two bevels. There are bevels on the either side of the tube. And this is mainly designed for the atraumatic intubation using a fiberscope, because it will keep the fiberscope in the center, and at this portion, if it hitting the tracheal wall, it is likely to be atraumatic as compared to the other tubes. This subglottic suctioning tube, as you know, the problem of VAP, we already discussed in brief about it. So in ICU setup, we can have this tube where there is another port for suctioning. This suctioning, the tip actually lies just above the cuff. Here is the tip of this suction tube, which can be connected to continuous suction and can be suctioned intermittently to decrease the pooling of secretions in this subglottic area to reduce the incidence of VAP. Lita, this is another modification of the tube, which is a laryngotracheal installation of local anesthesia. As you can see, this is the pot for installation of local anesthetic, and there are holes, approximately 10 holes are there above and below the cuff. So to prevent extubation response, this type of tube can be used. Another tube that has specialized tube is endotracheal tube that is used for intraoperative neuromonitoring. Particularly for thyroid surgery, we have this tube. For head and neck surgery, where vagus nerve may get involved. So there are surface electrodes which are placed around this area, around 4 surface electrodes, and they are here is a wiring which will connect it to the nerve stimulator. So intraoperative, the current is given and the area is stimulated. So if there is a recurrent laryngeal nerve is stimulated, we'll see some movement of the vocal cords, and that is how we can protect the recurrent laryngeal nerve at the time of thyroid surgery. So the last part of the lecture, that is about the laser tubes. As we know, with the use of laser, there's a risk of airway fire, and laser is used in the for the in the area of the vocal cords, so where the tube is placed. So if the tube is made of material which is likely to catch fire, the risk of airway fire will go very high. So there are some modifications done to the PVC tube, or the tubes are made of silicone to avoid this ignition of the endotracheal tube and risk of airway fires. So this tube, this I have used laser flex tube. This is made of stainless steel. And as you can see, it has 2 cuffs. That one is the stainless steel is less likely to catch fire. The 2 cuffs are there because if there is accidental rupture of one cuff, we can inflate the other cuff, and without any risk of aspiration, and without another problem with the cuff rupture is leakage of the gases. If there is leakage of oxygen around the surgical field where laser is being used, the risk of fire goes high. So that is why this modification is there in the laser tubes. Many of these tubes come with double cuff, so that as a safety feature. And the material in this laser flex tube, it is made of stainless steel tube. Also important point is that not all tubes, laser tubes, are fit for use with all type of lasers. As in the previous slide, the commonly used laser in the airway surgery are carbon dioxide laser, ND-ZAG laser, KTP, and argon. So with this laser flex, it is suited mainly for the CO2 laser and KTP laser, and not to be used for ND-ZAG laser. So this precaution you need to take. Another tube used for laser surgery is this laser tubus. This is made of rubber, white rubber with a Merocell sponge and a silver foil. Again, it has a cuff, but there is a cuff within the cuff. So that if the outer cuff is destroyed, we have an inner cuff. And also they advise to keep the cuff soaked So if there is a soakage around that cuff area, it is less likely to catch fire, and it is suitable for all types of lasers. Then we have Sheridan laser tube. It is a single-use red rubber tube, but red rubber is further wrapped with a copper foil and a fabric which is water absorbent to decrease the risk of airway fire. Again, the outer layer needs to be kept saturated, and it is suitable for CO2 and KTP laser. Laser shield is another type of tube. Also, when in the laser surgery, we usually fill the cuff with a saline, and it is even better if you fill it with a methylene blue, because in case of cuff rupture, there is a blue dye leaking around, so the surgeon is immediately aware that there is a cuff leak, so the proper precautions can be taken. Norton tube, not manufactured nowadays, but they are made of stainless steel, thick walled, and they are the only tubes which are laser resistant. Others can be laser proof, but here there is no risk of fire. But problem is this is uncuffed tube, so the air leak around the tube is a problem, but anyways it is not manufactured anymore. Lastly, the Bivona foam cuff tube. This tube again is not a proper laser tube, but it is used for the CO2 laser surgeries. It is made up of aluminium and silicone rubber spiral, and it has the inner surface of this tube is non-inflammable, but the outer surface is not laser resistant. It can catch fire, but the cuff is special. It is a foam sponge cuff, so it maintains seal even if punctured by the laser. And because if the cuff seal is maintained, the airway fire, even if it happens, the debris will not go inside the trachea. So that advantage is there, and it is commonly used for CO2 laser, although the outer surface is still inflammable in this type of tube. So that was all about the endotracheal tube. This is a slide showing the history of endotracheal tube. You can go through this for extra brownie marks if you are able to answer the rest of the questions and suggested reading. And best of luck for your exams. And thank you so much, Team Appec, for having me here.
Thank you, Dr. Anjali, for very comprehensively covering all the type of endotracheal tubes that are usually asked in the exams, especially the differences between the common tubes, which the examiners are very fond of asking. You have very comprehensively covered all those things. Questions
Sir,
will
we
be
have like little change in the program, sir. As I've discussed with you, Dr. Rakesh sir will be taking next lecture, and after that, Dr. Nidhi's lecture will be there. So, sir, for this session, Neecha ma'am will be joining you as chairperson. Ma'am is HOD in our department and the force behind this program. Neecha ma'am.
Thank you, Dr.
Good.
Jyoti. Good afternoon,
Good
Dr.
afternoon, ma'am. Good afternoon, ma'am. How are you?
Pleasure to be part of this at this time. Dr. Rakesh Sharma will be joining us in another 2 minutes. Sir, would you like to introduce Dr. Rakesh Sharma? उनका slide share कर देते हैं.
So it is my proud privilege to introduce the teacher of teachers of Delhi or all over India, Professor Rakesh Kumar sir, my teacher. He taught me a lot when I was a senior resident under him. He was a former director professor and former teaching consultant, president AMF and vice president LSA, with an affiliation to Mamsi and Lok Nayak Hospital and Dr. BSA Medical College and Hospital. He is a renowned figure in airway management, and most of us, what all we are doing, we learned it from him only, and basic life support skills, especially in North India through 2 dedicated teams of instructors known as airway managers and lifesavers. Led or conducted more than 500 workshops, skilling thousands of healthcare personnel and layperson. With an area of interest in simplified transfer of skills. Sir is very good in that, airway management and life support. So it's a proud privilege to welcome Professor Rakesh Kumar, sir.
I have also, I'll tell you, I did my post-graduation from MAMC, so I've also been taught by sir, and it is a proud privilege to be taught by him. And today is a special day for sir. Today is his birthday. He's superannuating. So this is and we are really privileged that this last day also he's spending with his students, imparting knowledge to them. And one of his most favorite subjects, the airway, we have a very special topic he'll be teaching us. Sir, have you joined us, sir? Dr. Sharma? We'll wait for a moment for Dr. Sharma to join.
Yes, ma'am.
Yeah, I will wait. So Dr. Sharma will be joining us soon. We are in touch with him. So he's connecting. Before we start his PPT, we would like him to say a few words before we start his lecture. It's a pre-recorded lecture. So he'd like to say a few words before he starts.
Sure. Hmm. Hmm. Hmm.
Dr. Sharma has joined. Hello, sir.
Namaskar.
Good afternoon,
Good
sir.
afternoon, sir.
Namaste.
Yeah. It's a pleasure to have you with us on this special day.
Thank you very much. Thank you.
Happy birthday from Team Appec.
Happy birthday to you, sir.
Thank you very much. Thank
Happy
you.
birthday,
Thanks a
sir.
lot.
Wishes and regards from all of us, sir.
What a pleasure. What a pleasure. Yeah.
And a pleasure for us to have you with us, imparting knowledge of the most important topic that for the PGs and something that you love, the airway
Yes,
and the
yes.
equipments related to that.
Absolutely. It is a pleasure to be doing that. And after quite a few years, actually, I did this presentation and it was very nice. Of course, we are doing it regularly, the AMF specialty workshops, but it was very nice. I hope that the PGs and everybody will like the presentation. And of course, it's a pleasure to see Dr. Sanjay there to introduce.
So
So that's great.
it's my pleasure, sir.
And
It's a
Anjali
pleasure to have you.
smiling, Anjali smiling there. So very nice. Thank you very much.
Wish you very happy birthday, sir.
Thank
And
you.
I am actually lucky to share the space with you virtually on your special day. Thank
Yeah,
you.
yeah. It's very close to your special day as well.
Yes, thank you, sir.
Right? Okay.
Thank you.
Chalo.
Okay. Shall we play the lecture now?
Yes, yes. It's up to Sanjay. He is the boss.
No, sir, it will, sir, please. We can start, sir.
Yes.
Okay, we can start the lecture.
स्टार्टिंग में लेकिन आवाज
Pressure is maintained until it
हेलो स्टार्टिंग आवाज में उसके बाद
I'm not able to hear it. Can others hear it? Require lung isolation at times and orthopedicians as well, as I'll tell you a little later. And even in ICU for differential ventilation. On behalf of Team Airway Management Foundation, I extend a big thank you to Team Appec for allowing us to talk about this topic of double lumen tubes and bronchial blockers today. It's a good idea to know about double lumen tubes and bronchial blockers for anesthesiologists and intensivists because isolating lungs is an important skill for anesthesiologists who are working for thoracic surgery, giving anesthesia for thoracic surgery, and for other surgical procedures. Surgeons, both the adult and pediatric surgeons, require lung isolation at times, and orthopedicians as well, as I'll tell you a little later. And even in ICU for differential ventilation, one may require isolation of the lungs. We have had our share of experience with the thoracic anesthesia, although not working in a cardiothoracic center, but had an opportunity to work and innovate for thoracic anesthesia in my 40 years of career. And so a couple of devices that we created at our center, and also worked with a couple of surgeons who are very enthusiastic about doing thoracic surgery. And out of these, two of my very very nice friends, Dr. P. N. Agarwal, head of surgery, and Dr. Sudhir Kapoor, an orthopedician. Together, we did a series of cases, transthoracic decompression of tubercular spondylitis, and published it as well. So had a good amount of exposure to thoracic anesthesia that I think justifies that I can talk about double lumen tubes. And historically, these are the tubes which have been used from Carlins and White, which are mirror images of each other. The Carlins is for the left-sided intubation, and the White is for the right-sided intubation. And there were specific thing or special feature which they had was a carinal hook, which was supposed to get engaged at the tracheal carina, and therefore allow us to position them properly. But a lot of operators found them as a hindrance, and they used to shave it off. I have used the Carlin's tube in a couple of cases, never used the White tube because we didn't have bronchoscopy to assist the final positioning of the tube. The Bryce Smith salt and Bryce Smith was the left-sided tube, and the Bryce Smith salt was the right-sided tube. And the special feature of these tubes was there was a couple of Murphy eye which were present at the end of the tracheal part of the tube. And as I said, I haven't used either the Bryce Smith or salt, and nor did I use Robert Shaw personally because they were not there in the department. But most of the modern day tubes are based on the principle of the Robert Shaw tube. So they are available for the right side and left side. And I hope you all know that the right-sided tube has a opening in the cuff to allow the right upper lobe bronchus, which is given out at a much shorter distance from the tracheal carina, to be ventilated properly. So if you are asked about this tube, when you define this tube, you place it in a manner that the tracheal curvature is the concavity forward. Then if you place it in the right manner, you will know which side the bronchial tube is going, and thereby you will know that it is a double lumen tube, which is the left-sided or right-sided, and also the opening for the right upper lobe bronchus on the in a right-sided tube. So many companies are making these double lumen tubes, but Ambu is also making a Viva Site 2 double lumen tube, which has a camera incorporated at the end of the tracheal lumen, which will allow you to actually see where you have placed the tube and which side and where the bronchial tube has lodged itself. So the double lumen tubes, mostly the left-sided tubes are used for a simple reason that the left main bronchus is longer and it is easier to place the left-sided tube. And therefore, they are available right from French size 41 to 26, while the right-sided tubes are available from 41 to 35 French gauge. And you remember that the French gauge means the outer circumference in millimeters. So a 39 French tube basically means 13 millimeter external diameter, where both the tubes are together. That means the tracheal as well as the bronchial tube. So that is one thing. The strange thing is that most of these tubes do not mention about the diameter of the bronchial part of the tube. But Ambu Viva Site is unique in this way that it mentions about the French gauge as well as the external diameter of the bronchial tube as well, which is a good idea, I feel. And because we have two cuffs, the bronchial cuff and the tracheal cuff, there are two inflation lines, two pilot balloons. The blue is bronchial and the colorless one is the tracheal one. So that is about the double lumen tubes, and they offer us a great advantage that they can be placed quickly. They hardly need repositioning or just a little bit of repositioning, especially the right-sided tube. And the placement is theoretically possible even without a bronchoscope being there, but it is a good idea to use a bronchoscope to finally position these tubes. It is easier to do bronchoscopy of isolated lung. The suctioning is possible. The CPAP can be added to the blocked lung or the one which is being operated on, which is collapsed, and you can alternate one lung ventilation to either lung very easily. But they have the disadvantage that the size selection is not so easy, and it is difficult to place in patients with difficult or abnormal anatomies and difficult airways. And there is because it's a thick tube or a big tube, so potential of laryngeal and bronchial trauma are there, and the need of very thin size 4 or below flexible endoscopes to place the final position. And right-sided tube, as I said, is a little difficult to place. And we'll talk about the selection of size a little later. When you use DLTs, there are 3 steps that you need to know about. How do you choose the size, the diameter and the length of insertion, how to place the double lumen tube, and check how to check the correct placement. Although not part of this this presentation, I'll touch upon it a little bit. We can choose the diameter based on the radiographs, the CT scans and imaging, which are mostly available in these patients, and you can use that to choose the diameter of the appropriate diameter of the tube. But even a good quality digital X-ray can be used if you don't have the other images, and you must go and see one good quality digital X-ray today to find out that there is a there is a marker on the side which tells how much is the length of 1 centimeter in the radiograph. So if you check in this, through this you can extrapolate and find the tracheal size at the level of the interclavicular plane, and from there you can decide which size tube to be used. There are other methods of predicting the DLT sizes based on the chest radiograph, CT scans, and the gender and height of the patient. So these are easily available in your book, and you can look at that. The depth of insertion, the formula used is 12 plus patient's height in centimeter upon 10 in centimeters, but I feel that it's very easy to individualize this length by just measuring the length from the angle of Louis, which is equivalent to the tracheal carina, to the angle of mouth in the parasagittal plane, and add another 3 centimeter for the bronchial tube, and you will get the tube size or the length which is likely to be introduced in this particular patient. So placement of the double lumen tube, as I said, this is the most commonly used double lumen tube. You begin by doing laryngoscopy, either with a direct laryngoscope or a video laryngoscope, and you saw that the concavity was forward, as if you are putting the tracheal tube only. Once you have negotiated the vocal cords, then you take out the stellate and rotate. During the time that you are rotating this tube, you must maintain this tug on the laryngoscope so that the tube doesn't just twist inside the pharynx and not inside the trachea. So to do that, you must maintain this tug on the traction on the laryngoscope, and then you connect, and then you can check by clinically whether you have placed it nicely or not, or the positioning is correct or not. And then you can also do scopies to check by passing the scope inside, and yes, and passing as we said, very thin fiberscopes have to be passed inside. You pass inside the tracheal lumen first, and you see that the tube has gone actually to the left side, as it is seen here, and then through the through the bronchial one, and you go and you go through the left side that the tube has gone in, and then we go through the bronchial cuff, and we see that the second carina is seen a little away from the tip of the tube. So it is not abutting on the. You can see that we are going through this blue cuff of the bronchial tube, and now we are coming out, and we should be able to see the next carina. If it is abutting on the carina, then you can pull out the tube a little bit, so you can see the next carina below that. On the right side, you'll have to see that the tube is going to the right side, as we did in the previous one, and then you go down and see through the bronchial tube. This is the middle lobe that you can see, and you come into the cuff area. Usually there is a white line, and you follow that white band, and you can see that you can see the upper lobe bronchus, and then you can adjust this tube so that they are nicely aligned with each other. So that is the placement of the double lumen tubes. Coming to the bronchial blockers. So if we can manage most of the things with a double lumen tube, why have bronchial blockers at all? And the idea is very simple, that when the patient is for thoracotomy and you are trying for one lung ventilation, the patient can be either already intubated, as it happen in an ICU, or not intubated. If the airway is difficult, it's a good idea that we use either a bronchial blocker or a double lumen tube, which is guided by a flexible video endoscope, or you have the AMBU kind of a double lumen tube, which has an inbuilt camera within it. And if the airway is not difficult, you require selective lobar block, then again you need to use a bronchial blocker, because that is the one which will be able to get you selective lobar blockade. If that is not required, and if there is no contraindication to putting in a left-sided double lumen tube, we always choose the left-sided double lumen tube. Only if the left main bronchus is a problem that you usually choose the right-sided double lumen tube. You can read more about the right-sided double lumen tube indications on your own. But if the patient is already intubated, but he can't tolerate of IPPV or of PEEP, then you keep that tube in place and use bronchial blockers alongside. Otherwise, you use the same technique as you use for a non-intubated patient. So the advantage of bronchial blockers is that they are more useful in patients with difficult airways where lobar blockade is required, selective lobar blockade is required. They can be placed through nasal tubes as well. And as I said, in difficult situations and abnormal anatomies, they are better off, but they have their own set of problems. The collapse of lung is slow. You are not able to suck thick secretions through the hollow bronchial blockers as well. They are more prone to dislodgement and cause perforation. And the right side blockade of with a bronchial blocker is more tricky, as we have talked about during the DLT placement. Historically, these were the blockers which we read when I was a resident, but I have never seen any of them. But we have seen an endotracheal tube with a bronchial blocker combination, which was the Macintosh Leatherdale endotracheal tube with a left-sided bronchial blocker. So you could block the left-sided bronchus with this combination of a bronchial blocker and an endotracheal tube. And that blocker also was hollow. So it allowed to give oxygen into this lung to theoretically do a suction of fine secretion, and there was a cuff for the bronchial side and the tracheal side as is needed in all these tubes. The apparatus in current use that we are using is again a combination. The one which is available, the ones which are available are Univent and the Ambu Viva Site endobronchial blocker tube, which is a single lumen tube with the bronchial blocker incorporated. And then the bronchial blockers, which are used through an endotracheal tube already in place. The single lumen tube with an enclosed bronchial blocker or the Univent is I have used it very often, at least 5 to 7 times, and it has an endotracheal tube and has a double lumen inside. One smaller lumen houses the blocker, which is usually pulled inside when we are introducing the Univent tube. And this blocker has its own cuff, and similarly the palate balloon. And then it can be opened. It has a stillet also when you are placing inside, which is pulled out, and then the hollow, the path is available to give oxygen and do a little bit of suctioning from there. So these are the parts, as I said. The blocker part, which can be bent into with the tip can be bent a little so that we can direct it to the right or the left side, and then of course it has its own inflation line and palate balloon. And as I said, it is housed inside the tube itself. And once it is in place, it can be fixed here by a fixator, which is available, which can be slid, and it can be kept in position. This is the kind of the endotracheal tube, and the housing for the blockers are there, and it comes in various sizes. But the external diameter, the smallest one is 7.5 to 8 in sagittal and transverse plane. So if we take 8 as the external diameter, it is very clear that it is similar to like size 6 endotracheal tube or 6.5 endotracheal tube. So that means you cannot use a Univent in a person in a child who is less than 10 or 12 years of age. And the introduction, as I said, is just like a normal endotracheal tube. And once you have placed it like an endotracheal tube, you will now place a fiber scope through the lumen of the endotracheal tube, and you can see that there is a side port available through which you can keep on ventilating the lungs of the patient while the scopy is being done. Now you can see the carina, and under vision, this is now pushed down and placed in the position that you want. You can place it on the left side and you can place it on the right side, depending upon the requirement that is there for the case to case. Going to the right side, here you can see the membranous part. You can see the membranous part slightly tilted image, but going to the left side, going to the right side. And once you are there, you inflate the cuff and see that the placement has been correct. So the independent bronchial blockers which are there, they are the Coop Dick bronchial blocker, which they come with an attachment which will fit into any endotracheal tube. The universal 15 connector, it will get fitted into that, and the ventilation will keep on happening from the side. The important thing about the Coop Dick bronchial blocker is that it is basically manually torqued, and like the blocker with the univent, you can place it by just twisting and using the torque to manually place it on the left and right side. It has a unique feature that it has got a button here. You can keep a cuff inflated, and once you have placed the blocker in place, you don't have to release your hand. You just press this button with your thumb, and this cuff, this pressure or this air goes into and inflates the cuff of the bronchial blocker, and this is the pilot balloon which shows that it has been inflated. Cohen bronchial blocker is available, and which has a turning wheel, which is a unique feature out there, and through which you can twist it to the right or to the left so that you can place it in the correct position. Arndt blocker is a blocker which is the unique feature is the adjustable guide loop. This is hooked onto the flexible scope, and which guides this blocker into the lobe or the lobe that you want to place this blocker into. And it is available in pediatric size as well. I'll come to that a little later. Fuji is another blocker which is available, a torque control. That means you'll have to just twist with your hand. And finally, the easy blocker, which is available in 7 French gauge, and it has got 2 blockers at the end, and it is kind of it is placed in, when you place it inside the tube, you keep these two the two flanges together, and once it is released and sits on the carina, both the side have a blocker each, and now you can inflate the balloon which you want to block. So looking at all the blockers, if you look at all the blockers, let me remove this from here. Yes. So the Coop Deck, the unique button, the Cohen, which has a wheel which is available, Arndt blocker, which has a loop which allows it to be lodged on the fiber scope, Fuji blocker, like the first one without the button, and finally the easy blocker, which has both the blockers incorporated into one. So that, kind of, and out of that, the Arndt blocker and the Fuji blocker are available in size 5 French gauge. So they can go through smaller size endotracheal tube, but most of the other ones go through 7.5 or above number of tubes, are available for adult bronchial blocking only. So that brings us to some indigenous one people have used. We have also used Fogarty catheter as a bronchial blocker, but very difficult to place because it doesn't have facility to twist it to the right or left side, and therefore not of much use. But if nothing is available, you can use this. So the take-home messages, friends, are that the lung isolation is an important skill to learn for every anesthesiologist and intensivist. Left DLT serves most of the lung isolation situations. However, there are specific indications for use of the right DLT and bronchial blockers, and knowledge of these devices and their proper use allows the airway manager to get the best out of the available equipment. Thank you very much, Team Appec, and all my friends who are listening to this, and this.
Thank you, sir. As
Thank you.
usual, a very lucid presentation, sir. This is a very important topic for postgraduates, especially on the table viva. A lot of questions are asked both for the right and left DLTs as well as for the bronchial blockers. And you have covered the things very nicely. I've even shown them the videos how they can use it, because those who don't use it very frequently, they get confused how to check, what to check, all those things. So you have explained it very nicely, sir. So thank you very much, sir.
Thank you.
Ma'am,
Can't hear you, Dr. Nirja. Can't hear you,
Great.
Dr. Nirja.
Hanji, very well explained lecture as always. The basic concepts explained. And I'm sure the students would have really got the basic things as to how to handle it, how to manage it. And Dr. Akhilesh told me that today is one of your busy days, but I sort of took the liberty of requesting you and again involving you even on your last day.
It made my
Sir,
day
and
even more
wishing you
interesting and more fruitful. Thank you.
thank you very much. And sir, wishes from all of us for the next phase of life, because this is a well-earned, well-deserved phase of life. And I'm sure you'll keep touching people's lives through your workshops, through your teachings and your expertise, even further years to come. And you yourself, you will unfold your next few years of life in time to come. We will get to know what you are engaged in, something new.
Thank you. Thanks a lot.
Thank you very much, sir. Happy
Thank you
birthday
very much,
again.
sir.
Thank you. Bye-bye.
Bye. Sir.
Now it's my pleasure to invite Dr. Nidhi Yadav, or rather Professor Nidhi Yadav, who is from ABVIM and Dr. RML Hospital, New Delhi, with an area of interest in neonatal and pediatric anesthesia, simulation in anesthesia, BLS and CCLS. And she'll be talking about non-operating room anesthesia and its challenge. Professor Nidhi.
Good afternoon, sir.
Good afternoon, ma'am.
Good afternoon, everyone. I am Dr. Nidhi Yadav, Professor Anesthesia at ABVIMS and Dr. RML Hospital. Today, we will be discussing about non-operating room anesthesia. The main learning objectives of my presentation are definition of NORA, the places which are covered under NORA, novel characteristics of NORA cases, unusual challenges which are faced during the provision of NORA care, and complications. Definition. As the name itself signifies, non-operating room anesthesia means provision of anesthesia services outside the traditional operation theatre. The environment as well as the procedures, which are often associated with challenges which are not routinely encountered in the OR environment. NORA is also known as anesthesia at remote locations because these locations are far off from the main OR settings. Outpatient anesthesia or office-based anesthesia. The various areas which are covered under NORA include gastroenterology endoscopy suites, interventional radiology including CT, MRI, pulmonology suites, interventional cardiology, electrophysiological lab, psychiatry which include ECT, oncology and nuclear medicine areas, pain management rooms and IVF procedure rooms. A study done in 2017 by Johns Hopkins Hospital shows a 157% growth in NORA cases done over a 10-year span from 2005 to 2015. Growth trends suggest that NORA volumes may one day meet or even exceed surgical case volume, which is the situation at present. The novel characteristics of NORA pertains to three distinct features: the patient, the procedure, and the environment. The challenges which we face in a NORA setting are first related to location. The NORA locations are situated far off from the main operating suites. Skilled assistance of the OT technicians and the OR staff is not readily available in a NORA setting. The environment is unfamiliar for the anesthetist, the monitor, the equipment, the place where medications are kept are highly unfamiliar for him. The support staff, which is mainly trained in the procedures conducted out there but is inexperienced in relation to an anesthetist, he or she can't anticipate the need of an anesthesiologist. The room ergonomics, the layout of the room, the places where the electrical outlets are situated, the places where anesthesia machine is there, the crash cart is there, is highly unfamiliar for anesthetist. So before proceeding for a NORA case, it is pertinent for an anesthetist to get himself familiarized with the NORA setting. The second is related to the operator. The operator or the proceduralist is usually a medical interventionist. The critical points in the procedure cannot be anticipated by anesthetists. Historically, the NORA procedures were performed without anesthesia. So the proceduralist has a communication hurdle which is present both ways. He might not appreciate the need to communicate the critical step with the anesthetist, whereas the anesthetist may not be familiar with the critical step of the procedure and his needs at each step of the procedure, so might not be able to provide adequate level of anesthesia for the patient. Now, third challenge pertains to the procedure itself. Each procedure requires a use of specialized equipment which are bulky and requires a lot of space and cannot be moved from one place to another. So the anesthetist had to do with the limited space which is available to him. The patient, that limited space may allow for a limited access to the patient as well as the anesthesia machine. These NORA cases and the NORA suits are usually kept chilled with a very low temperature, which can lead to hypothermia for our patient. The fluoroscopy and the ultrasound rooms and the pain management room usually have poor lighting for better visualization of the films done out there, but that might hamper with the workflow of an anesthetist. The unpredictable duration of the procedure may be a barrier for anesthetists to provide an adequate level of anesthesia throughout the procedure, and there is no dedicated recovery or a post-procedural room where an anesthetic patient can be monitored after the procedure is over. The pre-procedural evaluation. Each and every patient need to be evaluated before the procedure, and this evaluation should be in line with the evaluation done under OR settings. It is an essential component, and regardless of who is performing the procedure or where the procedure is being performed, the ASA checklist should be followed and ASA guidelines to be followed. Now we have evaluated the patient. Now coming to the monitoring which is required in a NORA setting. Monitoring is same as a standard operating room procedure. The standard ASA monitoring should include a reliable source of oxygen and adequate backup supply, adequate and reliable source of vacuum, adequate and reliable source for scavenging of the gases, adequate anesthetic drugs and equipments, a presence of a self-inflating bag or a ambu bag, adequate monitoring equipments, anesthesia machine, adequate number of electrical outlets to plug in various anesthesia machine and various backup equipments, trained staff for the NS assistance, and adequate illumination. There should be sufficient space to store the equipment when not in use, emergency cart with defibrillator, anesthesia drugs, emergency drugs, and ambu bag. There should be a reliable source of communication in times of need to call for help. There should be all applicable building and safety codes should be available, and post-procedural care unit should be established so that a sedated or anesthetized patient can be monitored there. So to proceed with the procedure, there's a checklist which can be remembered in the form of mnemonic of SOAP me. S for suction, O for oxygen, A for airway, P for pharmacy or the drugs, M for monitors, and E for equipment. These all should be available and should be checked before proceeding for the NORA case. Suction include adequate number and adequate sizes of suction catheters and a functional suction machine with a backup. Oxygen should include a reliable oxygen source, various flow meters, various oxygen delivery devices, and backup of oxygen supply in the form of an oxygen cylinder. For airway maintenance, we should include various sizes of face masks, various sizes of nasopharyngeal and oropharyngeal airways, endotracheal tubes, stellets, and laryngoscopic blade of different sizes, and ambu bag. Pharmacy or the drugs should have basic drugs for resuscitation in the kind need of emergency, which includes epinephrine, atropine, glucose, or naloxone. The monitors should include pulse oximeter, non-invasive blood pressure, ECG, temperature, and capnography. For equipment, we should have equipment for emergency as well as for the routine procedure, which should include defibrillator, gas scavenging system, safe electrical outlet which needs to be earthed, adequate lighting with a torch as a backup part, and a means of reliable communication. Now, when we select a patient for a NORA case, the level of anesthesia may differ for each and every case. A wide range of practices are present out there, but in a general rule, the anesthesia can range from mild sedation, monitored anesthesia care, general anesthesia, regional anesthesia, and neuraxial blocks. The drugs which can be used for sedation of or anesthesia of the patient in a NORA setting include benzodiazepines and opioids. It includes midazolam, fentanyl, propofol, ketamine, or dexmedetomidine in various doses. These drugs have a very short duration, short onset of action as well as a short duration of action, so that helps out in the rapid post-operative recovery for the patient. Now, once the procedure is done or during the procedure, we might encounter various complications, which can be divided under minor and major complication. The most common minor complication is post-operative nausea and vomiting and inadequate post-operative pain control. Others include inadequate sedation or anesthesia, agitation and delirium, hemodynamic instability, minor respiratory complication, need for opioid reversal in the form of naloxone, episodes of desaturation, and due to the chilled environment, hypothermia. The major complications include cardiac arrest or cardiac death of the patient awareness, vomiting and aspiration, anaphylaxis due to the contrast agent which is used, respiratory complication, or a wrong patient or a wrong site. Once the patient has recovered from anesthesia, usually he is monitored in a recovery room. Anesthesia provider should ensure a rapid recovery, as these patients are usually outpatients and the procedures are usually minimally invasive or non-invasive. While discharging these patients from the post-anesthesia care unit, the care should be similar to the care provided in the post-anesthesia care unit, and discharge criteria should be same. So we should follow modified Elder scoring for these patients before we transfer them out of the NORA setting. There are various source complexities in NORA, and what are the proposed solution for them? Space. These NORA settings are mainly designed according to the procedure which is performed, and anesthesia is just an afterthought. So for this solution, the anesthetist should be a part of these NORA settings from the starting, so that his needs can be kept in mind while designing the particular suite. The equipment. Insufficient and outdated equipment are particularly shifted to these areas. So anesthetist should ensure that equipment standards are maintained as in the main OR setting while planning of these settings. The staff. The staff, which are the proceduralists and their teams, are not familiar with the anesthesia setting or the setting in the OR. So the effective communication, team building and clear expectations should be told out to them before proceeding for the procedure. These NORA patients are particularly high risk. While in the OR for the elective cases, usually the patient are ASA 1 and 2, whereas in NORA setting, the patients are usually from ASA grade 3 to grade 5. So you should establish and optimize the pre-evaluation procedure, maintain monitoring standard, develop a formal system for summoning and clearly optimizing these patients for before taking them from the procedure. And for the procedure itself, new, more complex, more invasive and more risky procedures are being carried out. So effective communication, joint conferencing, pre-procedural meeting should be carried out beforehand between the anesthetist, the proceduralist and the care staff. Now coming to a few examples for the NORA setting. One is mainly which is increasing day by day is magnetic resonance imaging, and the need for the presence of anesthesiologist is increasing at a high speed in these settings. MRI suit pose a unique challenge of electromagnetic radiations. Iron and stainless steel, they act as mobile projectiles and they can harm the patient, the caregiver staff, the anesthetist, or the staff are present out there. So ferromagnetic pull may cause injury to the patient and healthcare providers. Even the patches, the pain relief patches or the local anesthetic patches which are applied to the patient for pain relief should be removed before the patient goes into an MRI suite. The equipment should be MRI compatible, whatever we use, anesthesia machine, infusion pump, electronic for the monitors, our laryngoscope, our airway devices, they all should be MRI compatible so that they do not cause any harm to the patient and affect the image quality. There are some functional constraints in the MRI suite. MRI requires specialized equipment with the patient going inside the MRI machine. So when the patient goes into the MRI machine, we don't have access to the patient. To maintain his airway, to maintain his circulation, to maintain his hemodynamics, the monitors, the tubings, the airway circuit should be of particular long length. Long tubings from outside the MRI zone to the patient are out of the reach of the anesthetist. So if a need for resuscitation arises that cannot be done out there, the patient need to be shifted from zone 4 to zone 3 for the resuscitation of patient. MRI machine makes a lot of noise that can lead to auditory fatigue for the patient as well as the anesthetist, and they can also interfere with the monitoring. To manage these risks which are associated with MRI machine, the equipment should be MRI compatible. A checklist should be followed before a patient enter an MRI suite to ensure no contraindication are present for MRI scanner. Ear protection in the form of ear muffs or headphones should be provided to the patient as well as to the anesthetist. Adequate length of monitoring equipment, breathing circuit, intravenous tubing should be made sure before the patient is wheeled into the MRI chamber. Monitoring, nowadays telemetric monitoring is done so that the monitoring can be done outside the MRI room only. And inaccessibility of the airway. Once the patient goes inside the MRI chamber, the airway becomes inaccessible. So if a need for securing the airway is present, the airway should be adequately secured before moving the patient inside the scanner. And ferromagnetic object needs to be removed. Another one is cardiac cath lab. The interventional cardiology is evolving and expanding day by day. Catheter-based procedures are done on a daily basis now, which can range from percutaneous interventions to transcutaneous aortic valve replacements, coronary angiography, cardiac catheterization, coronary angioplasty or stenting, endovascular closure of the intracardiac defect, valvotomy, electrophysiological studies with pathway ablation, and cardiac valves replacement. The special challenges which we face in cardiac cath labs are the patient population. They range from neonates to geriatrics. So complications related to neonatal airway with syndromic children as well as geriatrics They all add up and they make these patients a very high risk for the procedures. Arrhythmias, since they are cardiac procedure, there is high risk of arrhythmias due to the myocardial stimulation. Heparin is routinely used during these procedures, which can increase the risk of bleeding. Interventional catheter which are used, they can have a larger diameter which can cause vascular injuries and cardiac perforation. The position of the patient, the hands are above the chest, so prolonged duration can lead to brachial plexus injury. The anesthetist might need to be experienced in echo support to guide the procedures or to monitor the complications. So all emergency equipments along with the emergency cart and the cardiac medication should be present and should be made sure that they are present before proceeding with this cardiac cath lab procedure. So to conclude, the future of NORA is bright. There's increased need for anesthesiologists for these procedures. So anesthesiologists should involve themselves from starting to the build-up of that particular suit, so that his needs are kept in mind. And we should follow standard policies and procedures before going ahead with the procedure itself. Thank you.
Thank you, Dr. Nidhi. That was a very, very well described topic, and it is one of the most difficult places where an anesthetist has to give anesthesia to the patients. We are not familiar with the places where we are working. So if we are aware about all the pitfalls which can be there and prepare ourselves accordingly, all the complications which can occur because of all the problems which are there, which are not ideal. If we keep all these in mind, it will go a long way in saving the lives of these patients and making our lives comfortable. And it is not only a practical situation that Dr. Nidhi has talked about. She has dealt in detail as far as your theory answer is also concerned. So this is for the postgraduates. If you read this properly, you will be able to answer this question well in your exam. And it is a very frequently asked short question. Thank you, Dr. Nidhi, for a very, very lucid presentation. Thank you.
Thank you, ma'am, for giving me this opportunity, and hope I did justice with the topic.
Yeah, you did full justice. Very well spoken. Thank you so much.
Thank you, ma'am.
Thank you, ma'am. Thank you, Sanjay sir. Now we have case presentation on 38 female with right-sided ICD posted for shoulder dislocation surgery. It will be moderated by Dr. Nitin Harayan sir. Sir is Director Professor in Department of Anesthesia at Lady Hardinge Medical College, and sir's area of interest are acute and chronic pain management. And the PG presenting this case is Dr. Shivam Yadav. Over to you, sir.
Thank you, Dr. Jyoti. So,
Thank you.
So I would like to thank the whole. So my slides are visible.
Yes, sir.
Okay.
They are visible.
Thank you, team Appec, and Dr. Neerja ma'am and Dr. Akhilesh for inviting me for this case presentation. So my PG is Dr. Shivam. I think he's ready.
Yes, sir. Yes, sir. Ready, sir.
Okay. So our case will be anesthetic considerations for patient with intercostal chest drain. So it is so whenever this case is given, it is usually in the form of short case, or sometimes the X-ray that you are getting is having a chest tube, and then again your viva can go to a patient with intercostal chest drain. So in short cases, as you all know, that history examination and the final diagnosis, history and examination in short, and the diagnosis and anesthesia management in detail. So this viva for the patient with chest tube can go anywhere because it is not a straightforward anesthetic management case. So it can go to flail chest, it can go to pneumothorax, it can go to chest drain, it can go to bronchopleural fistula. And in some institutions I have seen that this patient was given as a long case for discussion of one lung anesthesia. So this is the spectrum. The case can go anywhere, so you should be prepared for most of the spectrum. Okay, so let's move on. So please,
shall I begin?
Yeah.
Okay. Good afternoon, everyone. Today I'm going to present a case. 38-year-old female, patient Mrs. Sushma, resident of Tilak Nagar, New Delhi. She is housewife at occupation, presented to the ER after sustaining multiple injuries to trunk and upper limb in a road traffic accident. She presented with two chief complaints. One, cough with difficulty in breathing and chest pain. She had pain and restriction of movement of the right shoulder. History of presenting illness. Patient was apparently all right 5 days ago when she got hit from a four-wheeler while crossing the road. She presented with cough with progressive breathlessness. It was gradual in onset. Tachypnea was present with visible contusions on the right side of the chest. Chest wall movements were decreased on the right side and on percussion. Dull note was present. Auscultation revealed decreased breath sounds on the same side. Pulsus paradoxus was also present. Tracheal deviation with hypotension was seen and distension of neck vein was present.
So this is the usual finding whenever we take a history from a patient who's having a chest trauma. So,
okay, the chest X-ray showed homogeneous opacity on the right side with radiolucent area above it, and EFAST was done, which was suggestive of pneumothorax, and ICD insertion was done, after which patient improved symptomatically. Second, pain and restriction of movement at the right shoulder was present, which was sudden in onset, severe in intensity, and unable to lift arm above the shoulder. The pain was relieved on taking analgesics.
so Dr. Shivam, in your history of the chest pain, you have mentioned about pulsus paradoxus. So pulsus paradoxus is usually there in this pneumothorax, hemopneumothorax, or it is a hallmark of some other condition?
So these are okay, sir. So pulsus paradoxus can be seen in various medical conditions, including cardiac and non-cardiac causes. It is usually seen in cardiac causes like cardiac tamponade, constrictive pericarditis, and non-cardiac conditions like large bilateral pleural effusion, and we have attention pneumothorax, COPD, asthma cases.
So that means that whatever is there, the collection was creating some pressure symptoms. Okay. So what is pulsus paradoxus as such?
Sir, it is actually a decrease in the systolic blood pressure during the inspiration, and the difference between the blood pressure of more than 10 mmHg is considered significant, and then it is called pulsus paradoxus.
Okay. So, okay, you are right. How do you measure? You have already told the difference between the two levels. If it is more than 10, it is called pulsus. So have you heard about the term reverse pulsus paradoxus?
Yes, sir. It is seen in.
There is a reversal of what is there in the pulsus paradoxus.
Sir, it is opposite of the normal pulsus paradoxus. There is an increase in the systolic blood pressure during inspiration.
Okay. So in which condition do you find?
So these are seen in a mechanically ventilated patient on pressure support with left ventricular hyperfailure, sir.
So basically,
left ventricular failure. Yes, sir.
Basically the mechanical ventilation supports the left ventricular outflow. So in the patient with left ventricular failure, they may be they help in the increasing the cardiac output, and that is termed as reverse pulsus paradox. That means there is an increase in the blood pressure by 15 mm at on inspiration. That is considered significant. That means that left ventricular function is too depressed. Okay.
Yes, sir.
Continue.
Coming to the past history, patient is known case of hypothyroid since 5 years on oral medications. There is no history of hypertension, diabetes mellitus, tuberculosis, asthma, jaundice, epilepsy, or any other past history. There is no significant personal and family history.
Okay.
Treatment history for hypothyroidism, she is taking thyroxine 75 microgram OD once 5 years. Examination, patient is sitting on chair with ICD and arm pouch intact, conscious, cooperative, and well-oriented to time, place, and person. She is average built with BMI of 25.7 kg per meter square, afebrile on touch. Her vitals are, pulse rate is 104 per minute with pulsus paradoxus present. BP is normal, measured in left arm and sitting
This is
position.
wrongly written here. Now the pulsus paradoxus it should be improved. Okay.
Okay, sir. Respiratory rate is 22 per minute with regular abdominothoracic pattern. There is no pallor, icterus, clubbing, cyanosis, lymphadenopathy, or pedal edema seen. JVP is not raised. Coming to airway examination, there is no loose tooth or artificial denture. Mouth opening is more than 3-finger breadth. Modified Malampati
Airway examination is within normal limits.
is normal limits, with the normal limits.
Okay. So what is your now provisional diagnosis? So okay, systemic examination.
Systemic is left. So on systemic examination in respiratory system, there is visible contusions on the right side of the chest. Right ICD is in situ. On percussion, there was dull note, but it is significantly improved after putting the ICD. Auscultation revealed decreased breath sounds on the right side. On cardiovascular, CNS and spine, there is no abnormality present. It's normal.
So your provisional diagnosis?
So my patient is 38-year-old female. This is known case of hyperthyroidism on tap thyroxine for 5 years. Presented to the ER with history of RTA and right ICD in situ. So for hemopneumothorax and pain and restriction of the movement of right shoulder. Likely a case of right hemopneumothorax.
Okay.
And she's posted for shoulder dislocation surgery.
Suppose this patient has been posted for the right Bankart's repair. So, as we've already discussed, apart from the anesthesia management, you may be asked about the chest tube. So, do you know about the chest tube? So, what is
Sir, these are basically flexible tubes which are inserted into the pleural space through the chest wall between the ribs.
They help.
Sir, mainly they have their main purpose is to drain the pleural cavity contents like air, fluid, pus, blood, and it also helps in maintaining the negative intrathoracic pressure, which helps in expansion of the lungs.
Normal intrapleural pressure.
So normal. 5 to 20.
कितना है? Minus है, plus है.
It's negative.
If you don't know this, then there will not be of much help in when you have inserted the intercostal chest drain, how it will work. So it varies from
5 to 20.
Minus kitna? Minus 4 to minus 8.
Minus. Okay, minus 4.
So basically it restores the negative pressure. Okay, so use of drainage of any pleural space restore the negative pressure to allow the lung to re-expand. So now the normal pressure, and in the absence of this negative pressure, because of the collection, the pressure becomes positive, and inserting the chest tube will again create after the drainage is there. Okay. So, in general, what are the indications that you know of? When have you seen that ICD has been inserted?
Yes, sir. Primarily, it is inserted to drain in conditions like pneumothorax, hemothorax, chylothorax. In post-thoracotomy patients, a drain is put.
Post-surgical and post-surgical patient, hemo, chylo, effusion, empyema, post-surgical patient, like thoracotomies and other surgeries. So here again, we should be able to understand the various classification of pneumothorax, like primary, secondary, iatrogenic. So the Viva can go to that side also. So pneumothorax, do you know how to classify?
No, sir.
So basically we classify as spontaneous, secondary pneumothorax and iatrogenic cause. So primary, so depending on the volume, how do you know? So let's, I will again ask. So what are the secondary indications?
Sir, basically we can put, it can be used as therapeutically, like putting antifibrinolytic agents or antibiotics, and also
any other indication?
It
was done a lot earlier.
Sclerosant, sir. Sclerosant, pleurodesism, sir. We can use it to inject sclerosants.
Do you know about which is the most common sclerosant used for pleurodesis?
Sir, acrylic. No. Acrylic, sir.
नहीं,
Mhm.
it is the sterile talcum powder, talc, but it has to be sterile. Okay. So sclerosing
Okay, sir.
agent most commonly used is sterile talc. So the talc that we use is a talcum powder. Okay. But it has to be
Okay, sir.
around, the volume is around 50 to 100 ml that they take in a syringe and then they insert it. Okay. So the contraindications for putting a chest tube?
So primarily patient's refusal. Sir, if there is any lung adherent tissue to the pleural space,
Okay.
the
And
history
any
of past thoracic
absolute
surgery.
or relative contraindication? And they're absolute.
Relative, these are absolute. So relative, sir, we have bleeding diastasis, we have infection at the site of putting the tube, and we have any bullous lung disease also.
Okay. Okay. So you already covered most of the things. Okay. So bullous lung disease, local pleural effusion. So that all can be taken care. That is why they are relative contraindications. So what is the usual site where we insert the chest tube? So have you seen
So,
chest tube insertion है ना in ICUs, in OTs?
yes, sir.
कहाँ डालते हैं usually? Where do the surgeons put? Or we can also put.
So, yes, sir. So the preferred site is basically the area of safe triangle of safety, sir. Basically, it is formed by the lateral border of the pectoralis major, laterally by the anterior edge of the latissimus dorsi, and inferiorly it is formed by the fifth intercostal space, and on the apex formed by the base of the axilla. This is
Why?
the triangle of safety, which is
Why it is safe?
sir, it is basically devoid of any neurovascular structures, so it's
और
safe to insert there.
और सिक्स रिब ले लेंगे तो क्या हो जाएगा? सिक्स रिब भी ले सकते हैं हम फिफ्थ रिब क्यों लिया है? So fifth rib, जो lateral border of pectoralis major ends at around anterior axillary line. So can we take it anterior axillary line or mid
Sir,
axillary?
sir, anterior axillary line, sir, anteriorly right.
अच्छा ठीक है, नीचे वाली border बताओ.
Sir, inferiorly it is formed by fifth
Mid
intercostal
axillary line is the usual V2, है ना? So आगे
sir.
कौन सी vessel है, पीछे क्या है? You should know the which muscles do you pierce when you are inserting the chest tube at this level?
So,
अच्छा चलो, let's leave it. It is on the
yes, sir.
serratus anterior.
Sir,
and
the
the
anterior, yes.
Why not at 6 intercostal space? चलो. Anteriorly internal memory artery हो गई, posteriorly बाकी thoracodorsal artery हो गई. बीच में क्या है? बीच में कुछ नहीं है. नीचे क्या है? Why not 6 intercostal space?
Diaphragm, sir.
बहुत ऊपर है. Diaphragm.
Injury to diaphragm can occur.
Injury to diaphragm. What is the level of diaphragm on the right and on the left side? Which is higher? Right वाला ऊपर है कि left वाला ऊपर है?
Left वाला ऊपर होता है, sir.
Right वाला ऊपर होता है. ठीक है, तो right diaphragm is a little
Liver,
bit more.
sorry, right side, yes, sir. Due to liver. Yes,
So
sir.
usually this is corresponds to the diaphragm. So sixth intercostal space corresponds to the level of insertion of upper dome of diaphragm. That is why we don't go there. Okay. So that is your triangle of safety. This is your anterior edge of the pectoralis, base of axilla. This is your latissimus dorsi, and at the nipple level we have the fifth intercostal space. Okay.
Yes.
So where do we insert, from the upper border or from the lower border?
Sir, we insert at the upper border of the rib to avoid any injury
To
the
the
nerves, to the nerve and vessels.
nerve bundle.
Yes.
So have you seen chest tube, है ना? डलते हुए
Yes,
देखा.
sir.
So which
Yes,
is
sir.
the most common chest tube size that you have seen in your ICU?
So, right. So range, so 20
range बहुत है.
to 28. Yes, sir.
Which size have you seen mostly in your ICU or OT?
So 24.
Very good, 24. So it can be polyvinyl chloride, polyethylene silicon,
straight. These are all things. So it range क्या होता है इसका?
So it ranges from 60 to 40 French, and in French we can use from 6 to 24 French.
Very good. So there is a classification about small bore chest tube and large bore chest tube.
Large.
Can you classify depending on the size?
So any tube which is less than 14 French is called small bore chest tube, and more than 20 French is referred as large bore.
So depending on the classification, so this was the British Thoracic Society. They have advocated 14, but some of the societies have advocated as 20. है ना? So less than 20 and more than 20. So okay, so there is a variation in depending on the society that is giving the guideline in classification. So is it so that always we put 24, or depending on the collection, what is there inside the chest, we chose the size?
So on basis of diagnosis, sir, like in pneumothorax, we can use relatively shorter bore chest tubes like 24 to 28.
Good.
And in hemothorax and pus-filled cavities will require a larger bore tube to avoid any clogging. So
Right.
we use 36 to 40 French. And in pleural effusions, we can go for 32 to 34 French.
Okay. So depending on the collection, the viscosity of the collection, we choose the size. So as already mentioned by Dr. Shivam, for pneumothorax we can use a smaller size, and for the blood and the pulse we can use a larger size. And in between, depending on the we go for the pleural effusion. So like I have discussed about pneumothorax. Here again, the question can be asked about the types of effusion, pleural effusion. Do you know about types of pleural effusion? How do you classify pleural effusion?
So not much, but there is a loculated pleural effusion.
It's a usual day-to-day practice of our.
So there's
exudative.
Not
and
exactly, I don't. Exudative and transudative, yes.
That is, you should, for all those who are also listening, you should be able to classify the pneumothorax and effusion. So the examiner can go anywhere. So just to know which are the transudative and which are the exudative. Please read this thing, है ना?
Yes.
So it's easy to, but just एक simple question का आंसर नहीं देंगे तो otherwise वो वाइवा फिर basics पे चला जाता है. So try to cover these basic things also. So which is the normal positioning in which we do the insertion?
So basically we go for semi-recumbent position.
Please.
So we go for semi-recumbent position. We ask the patient to lie down with head and shoulder about 30 degrees above the bed surface. And the ipsilateral arm is to be held behind the head to expose the axilla and increase the distance between the ribs for easier insertion.
And we do a little bit head up tilt so that the diaphragm falls down. Okay. So these are the three postures in which the chest tube can be inserted. This is the most commonly inserted in the semi-recumbent position, the sitting position, and the lateral position. The advantages and disadvantages are usually straightforward. So idea is to open up the space and move the intra-abdominal viscera to a lower side.
Okay.
So preparation for any other procedure is the same. So do you know about the various placement techniques?
Yes, sir. So we go for either a Seldinger technique, which is guide wire approach, and there is another one which is called blunt technique, and there is a trocar technique also.
So which is the most commonly used technique?
So standard technique is the blunt dissection technique, and most commonly, I think now we are using Seldinger.
No, Seldinger is basically we use in the ICU, but surgically, and even the most recommended is the blunt dissection technique. So blunt surgical method, Seldinger technique. And what about the trocar technique?
So basically, with the aid of a trocar, we put the chest tube.
Nowadays, or is it? It is preferred over Seldinger, or it is equivalent to Seldinger?
Sir, it is easier to place, less painful. So
No. So it is more dangerous with more complications and no extra benefit is there. That is why currently the trocar method is not used in practice, and most of the studies have not recommended to use it any further. So it leaves us with only two techniques, either Seldinger technique or blunt surgical method. So for the sake of completion, I will just touch upon the Seldinger technique. So it is like what we do in our CVP line or any other. So we the method is the same. So sometimes the set may be available in the on the table Viva. So you should be able to identify the components and the set also. So this is the chest ring that is there, and it has a three-way stopcock to release the air. So that is the basic of the Seldinger technique. So so it is so is it so okay this has to be directed upward or downward depending on the either it is pneumothorax or the effusion, or it can be directed anywhere?
sir, basically the fluid collects in the diaphragmatic recess.
Recent
So
guidelines, what they say, chest tube should be directed cranial caudal, or it can be directed anywhere, even it doesn't correlate with the type of collection.
can go through the direction.
The conventional dictum was that for the pneumothorax it was directed
Apically.
apically, and for effusion distally. But even if it is not such, then also it will work similarly, even if it is going in the center, because the basic aim is to have a negative intrathoracic pressure, so intrapleural pressure. So that is the basic dictum. So that is why it is we still do, surgeons still do, but it is not at all required. So this was the earlier trocar method, and that causes a lot of trauma to the lung parenchyma. That is why it is not now commonly used. The blunt dissection technique, just a little bit about that. So it is a standard technique, incision on the skin and subcutaneous just above the rib. With the artery or the cali, we bluntly dissect the intercostal tissue. And introduction, we introduce the finger and just break the pleuropulmonary adhesions and insert the chest tube with the sentinel hole about 2 centimeters beyond the rib margin. So can you tell what is the sentinel hole in this? मतलब इसमें लिखा है sentinel hole.
Sir, basically the main hole which helps in detecting the position inside the pleural space, most anteriorly.
So if you say patient has the distal and outside of the chest is proximal, the most proximal hole of the chest tube, so that is determined by a break in the radio-opaque line. So there is a radio-opaque line in the chest tube, and the last breakage in the radio-opaque line denotes the sentinel hole. It should be inside the rib margin. Okay, so that is the most important aspect of. So we will discuss why. So now the chest tube has been inserted. How do you confirm the placement of ICD?
Sir, we can get a post after that. We can get an X-ray. We should get X-ray done.
इसमें कितनी देर लगती है?
Sir, first, sir, visualization of the bubbling in the water seal chambers as well. Movement with respiration.
क्या movement देखना है?
Water fluid in the water seal chambers. During inspiration, the water level will increase. So we'll check.
Movement of the water. So visualization of the column movement. इसको क्या बोलते हैं और? Is there any term? Is there a term
Yes, sir. Sorry.
It is called tideling also.
I'm not remembering. Yes, sir. Tideling, yes.
Drainage of pleural fluid or air via the tube. And if the patient coughs, there is a bubbling at the seal level, and obtain a chest X-ray immediately and regular period subsequently. Okay. Okay. So that is about the confirmation. So after you have inserted the tube, you connect this tube to a certain system. So do you know the components of the drainage system? So that will
Sir,
drain
but
the whatever there is there in the interpleural cavity in outside the chest.
yes, sir.
बताइए.
So basically, there are three types of drainage system: one bottle, two bottle, and three.
Components. What are the
Yes,
components
sir.
of drainage system?
Sir, first of all, the drainage tube, so which is connected to the pleural space, chest drainage tube, and
Chest.
sir, uske baad, yes, sir.
That is the drainage
And
tube, chest tube.
yes.
Okay. Okay.
So then we have a collection chamber which collects the fluid and air, and the third part is the underwater seal, which acts as a one-way valve.
Okay. So, so drainage tube is we have already seen, है ना? So it has a radio fixed mass. The most proximal drainage will be a sentinel hole. So collection chamber it should be kept 100 centimeter below the level of patient to maintain a gradient from pleural space. So why 100 centimeter?
So because it maintains a sufficient negative pressure and does not allow the fluid to reflux back inside the patient's lung.
So if we keep it at around, suppose आपके पास ICU का बेड है जो कि ऊपर हो जाता है ना? आपने खूब ऊपर कर दिया और वो नीचे का नीचे रह गया बैग. So suppose that now the distance of around 150 centimeter, है ना? तो क्या हो जाएगा 150 centimeter पे?
So it might help in draining more effectively since due to gravity.
और अगर आपने जैसे ही डाला और आपने सीधे 150 पे रख दिया तो क्या होगा? आपने as soon as you have inserted the chest tube and now you connected a chest drain that is around 150 centimeter below. क्या करता है ये 100 सेंटीमीटर क्या करता है ये?
Sir, pressure gradient create करता है sir.
Creates a negative pressure gradient.
Negative pressure.
ज्यादा नेगेटिव हो जाएगा तो क्या होगा? सडनली ज्यादा नेगेटिव हो गया तो क्या होगा?
The expansion pulmonary edema can cause it.
ठीक है? So that is one of the important things to remember. So if you suddenly create a lot of negative pressure, और क्या हो सकता है? So अगर हमारा pneumothorax है, there is some pleural injury, है ना? Some alveolar injury also. So it will increase the leak. So it may increase the capillary, the air leak, है ना? और कम कर दिया तो क्या होगा? 50 centimeter कर दिया, क्या कर दिया?
Sir, it might not help in draining. Then, sir, the pressure gradient will decrease, so the fluid or air will find it difficult to drain.
50 centimeter कर दिया, height ऊपर कर दिया. अभी 100
The chances of reflux.
Very
fluid
good.
can
Accidental reflux of the fluid or the air back into the fluid back into the chest, है ना? If it is still accidentally elevated. So now the underwater seal, we will discuss it later. है ना?
Okay, sir.
Now, so drainage device basically allows the air and fluid to leave the chest, and it contains a one-way valve that prevent air and fluid entering to the chest, restore negative pressure into the pleural space to re-expand the lung. So do you know the types of the drainage system?
Yes, sir. There are basically three systems: one bottle, two bottle, and three bottle system. Yes, mainly this, and today we have a combined in which we have all the three chambers in one unit.
So which type of this is? Which is
So this is one bottle. This is one bottle drainage system, sir.
Can you tell the components of this?
Yes, sir. Sir, it is a flexible tube which is inserted in the bag, and it is kept around 2 centimeters below the level of the water which is filled inside this bag.
This is the level?
Yes, sir. We keep it 2 centimeters below it, and it is the upper portion. The tube is connected to the chest tube, which is in connection with the pleural space. And we have another vent through which the air can be drained out, or we can attach suction also if needed.
You need to. So why centimeter? The use of this 2 centimeter.
So basically,
What does this do? It is
acts as a one-way valve, sir.
a wave bond.
Does not
So
allow the
why 2
air to-
centimeter? Why not 3 centimeter? What will happen if it is more than 2 centimeter?
So it will increase basically the depth of the water. Depth will increase. So the air or the fluid which is coming out of the pleural cavity will have to, the force will increase. So they have to fight a greater resistance.
Okay. So we have to increase your intrathoracic pressure to counter this increase in the pressure because of the increase in the volume of the
volume of
water. Okay. If it is less than 2 centimeter, there is a risk of air entry into
air
the
and fluid. Yes,
Okay.
yes, sir.
So okay. So you already covered. So this is open to the atmosphere. So what are the advantages of this single?
So it is inexpensive. It is a simple drainage system.
And what are the
Basically, these are-
disadvantages?
So disadvantages is it cannot be used. It is basically used for only air, uncomplicated pneumothorax. If any fluid is present, like you told, if the collection of fluid will increase the depth and thus will increase the work of breathing, and it will hamper the.
We need to
excretion of
again
the-
check the. So it is best suited for mostly the pneumothorax, and if the fluid is draining, it will increase in the water seal level, and it becomes harder to push through the higher level of water. That means the resistance of the work of breathing increases.
Increases.
So what is the next thing that can be helpful?
So
can
then
we-
we move to two bottle drainage system, sir.
How will it help?
So basically, it was only one bottle drainage was useful in one bottle. Pneumothorax mein, sir, one bottle drainage system was used, but the fluid drainage was not effective. So we used two bottle drainage system.
Okay.
The first bottle is connected to the chest tube, which collects only the fluid. The air from the first bottle then escapes inside the second, which acts as a one-way valve. And from there, the air can be removed. So the fluid in the first chamber will not affect draining of air also, and work of breathing will not increase. So that is why we use.
So that is the advantage of the two bottle drainage. So okay, I think you have already done. So with the help of gravity, we collected the fluid in the effusion, and the air was there in the underwater seal. Okay. So what are the advantages? I think we have already covered the advantages.
Advantages, yes, sir.
Okay. Okay. So so I think disadvantage is there because the air first is collected in this chamber and then
Yes, sir.
goes to this chamber, so that it gets compressed here. So air evacuation may not be that efficient as in the single chamber when we compare the two chambers. So air expelled from the pleural cavity must compress this gas volume enough to overcome the underwater seal. More effort than single chamber. So if large leak into the pleural space, gravity drainage is not sufficient. So how do we circumvent this problem of the
So
dual
we
chamber?
put a wide, sir, two bottle drainage system, sir. We can add another bag to it.
Okay.
In which we can collect the fluid, and we can add another bag through which we can create a suction pressure, which will drain the air from the pocket and help.
We want to have a negative pressure. Okay.
Negative pressure.
Put it into the intra-pleural cavity also. So that is how we circumvent the problem of the double chamber and the single chamber drain. So can you explain this?
Yes, basically the first bottle is the drainage chamber which collects the fluid or blood. The second chamber acts as a one-way valve through which the air then goes in the third bag, which are interconnected. The third chamber basically is connected to a wall mount suction cap, which maintains a negative pressure through which we can suction air.
Okay.
And, this is our
So what is this this tubing doing?
So
इसका क्या रोल है?
what is
ये वाला ये तो अंडर वाटर सील हो गया ना?
yes sir, yes sir.
ये कलेक्शन हो गया, ये ट्यूबिंग क्या कर रहा है? ये पानी में क्यों है?
सर due to मतलब सर suctioning की वजह से सर
ये देखा तुमने? ये कम, दिस इज अराउंड 2 सेंटीमीटर है ना? And
Yes,
this
sir.
is I think very much deep inside. Why is it so?
Sir, to know air might so not exactly.
Okay. So it helps in determination of the negative pressure, है ना? तो अगर आप 20 डाल, 20 रहेगा. So third bottle consists of vent and suction tube connected to the wall suction, maintains continuous suction, air and fluid efficiently drained. ठीक है? So if suction अगर हमने 20 सेंटीमीटर अंदर डाला है और 20 पे किया तो it will create a negative pressure of 20. ठीक है? अगर हमने 5 डाला है, 5 रखा है तो it will create a negative pressure of 5 in the chamber. जितना नेगेटिव प्रेशर रखना है उतना ही हम अंदर डालते हैं इसको. ठीक है? It is connected to the vent, water seal bottle. 2 bottles are interconnected. So any advantages of this? We have already discussed the
So
advantages.
yes. So with the level of the fluid in the third chamber, we can regulate the suction pressure.
Okay.
And effective for both pneumothorax and pleural fluid, sir. And main advantages, sir.
ठीक है. So basically adjustable pressure of the suction that will help in the that can be maintained from the third bottle, and it is effective for both pneumothorax and pleural fluid. No likelihood of fluid refluxing back into the patient. Any disadvantage do you know of?
So it can, due to suction, it can cause excessive bubbling, sir, and the complexity of the assembly, sir, it is difficult to handle.
In which case there is excessive bubbling?
Sir, in cases like there is large leak present, like bronchopleural fistula, large injury leak in the airway or lungs.
So basically, when the cause of your insertion is pneumothorax due to injury, alveolo-pleural injury or bronchopleural fistula or bronchopleural injury, so in that it may further aggravate the air leakage because of the negative pressure. Okay. So, and this is the current multifunction chest tube drain that is available, and it has the same 3-chamber function, and all the 3 are there in a compact manner. Okay. So complications.
Yes, sir. So it can cause trauma, malpositioning of the tube, trauma to lung.
Common
yes, sir.
are trauma to any of the organ, intrathoracic viscera, abdominal viscera, malposition, intra-abdominal, or anywhere else, and the vascular injuries. Okay.
Injuries, yes. Sir, air leaks.
Air
Air leak might be present, sir.
So bubbles in the water seal chamber and is present within the chest or leak in the drainage system. So intermittent air leak typically at end inspiration, that tells. So how do you classify? So intermittent air leak हो रही है typically at end inspiration, that denotes injury to the lung. And continuous air leak, so air
There's
should
a
be.
large injury.
So what is normal air leak? ये तो abnormal हो गया है ना? Injury to the
Yes, sir.
lungs and airway में end inspiration में हो रहा है और continuous हो रहा है, तो there is a large injury to the airway. What is a normal thing? Air should not come out.
Sir, if there is no injury.
What is normal air?
बबलिंग होती है ना नॉर्मल चेस्ट ट्यूब में भी, इंजरी नहीं हो तो भी कब होती है यूजली बबलिंग, किस फेज ऑफ रेस्पिरेशन में होती है? At the end expiration, okay, or when the patient has coughed out. So that is a that is a normal bubbling, and when it is abnormal, when it is an intermittent or continuous early. So another complication is re-expansion pulmonary edema. So we have discussed a little bit in the so it is a sudden expansion of the lung. So can you tell me more about what is re-expansion pulmonary edema?
Yes, sir. Basically, it is a sudden expansion of the lung, which is collapsed since more than 3 days. Patient basically will present with hypoxia, dyspnea, and cough, and we give supportive therapy basically, sir, and IV diuretics.
So is there any method to prevent it apart
Yes,
from
sir. Yes,
that
sir.
it has to be around 100?
Yes, sir. So we can limit the drainage, sir. We can drain only 1.5 liters or less in one sitting, and in children less than 20 ml per kg.
Okay,
to
very good.
avoid.
Very good. So basically, Dr. Shivam has covered. So it is the expansion of collapsed lung when there is a large effusion or collection, and so that was why we say कि it should not be drained in one go, not more than 1.5 liter or 20 cc per kg in children, and the symptoms and signs are as pulmonary edema. So now this patient is posted for Bankart repair. We have already done. So we have discussed about the chest drain. So now, what preoperative evaluation? What are apart from the general physical examination, system examination, history, and other things, and the basic investigations? What are the important pertinent preoperative evaluation points that you should look when you are seeing this?
Yes, sir. Sir, we'll ask for an X-ray. We'll ask for the indication why the chest tube was put, sir.
So
And
just
we'll ask the size of the tube. Yes, sir.
hold on. In X-ray, do you want to see any other thing?
Yes, sir. Flail chest, any pneumothorax, or
Patient
pulmonary
had
contusions.
had a blunt and patient had pneumo and hemothorax. So air comes from inside, and hemo is basically the intercostal vessel damage or other reasons why because of which the blood is accumulated inside the pleural cavity. So that may be because of some injury, and it may have implication. So you should always rule out the rib fracture. And here you may be asked about what is flail chest, how do you manage flail chest? And similarly, if you can see on the contusion, so what do you know about pulmonary contusion?
Basically, sir, injury to the lung parenchyma. I seen the patient will present with pain, difficulty in breathing. Yes, sir.
How do you basically diagnose pulmonary contusion? How is the pulmonary contusion diagnosed? कितना टाइम लगता है उसको मैनिफेस्ट होने में? The gold standard test for diagnosing pulmonary contusion. What are the problems of pulmonary contusion and how to manage? So this may also be asked in your the ICD. So the gold standard is chest CT. In X-ray, there are no changes within the 6 to 7 hours, and they are manifested only after 6 to 7 hours, and it will show as an infiltrate at the site of the blunt trauma. Okay. So now you told about indications for ICD. What all things you want to know?
Sir, indications, sir, what was the primary indication why it was put? Hemothorax or chylothorax, pleural effusion. And
Okay.
apart from that, sir, we'll see if all the connections are secured and taped. And sir, we'll see the drainage system, the amount output of the drainage, if the drainage
I want
is
to see
functioning or not.
something more in X-ray. X-ray में कुछ और देखना है इस पेशेंट को तो
It's the positioning of the tube, sir. Positioning of the tube, sir. If it is
again we have already discussed how to see the positioning of the tube. How do you see?
so with the radiopaque line which is present on the sentinel dome.
again. You have to check the sentinel hole, whether it is in the intrathoracic cavity or it is in the subcutaneous tissue, because of the drag of the drainage system, it can pull out. So you have to again reconfirm whether it is inside or not. Okay.
Yes, sir.
So then your size of it. So that is important for you to know which size has been put, which intercostal space and position of the tube. The position of the tube can be confirmed with the help of again the X-ray can confirm the position of the tube. और कुछ देखना है?
So output thickness, sir, we have to see if the column is moving or not, bubbling is
देखो
there
always
or not.
suppose हम क्या suppose एक rise in the intrathoracic. I'm just moving out from this context. So suppose you have been given a case scenario that there is an increase in the intra peak inspiratory pressure in a patient who is being operated.
Yes, sir.
ठीक है? तो कहाँ से चालू करोगे? Whether you will start from the patient or you will start from the machine end.
So we'll start from the patient.
So wherever you start, you will not do कि पहले patient end देखा, machine end देखा, बीच में circuit देखा ही नहीं हमने. So always start from one end and go till the other end and seeing the things in between. So if you have checked the position of the tube, तो second चीज क्या देखना है?
It's a leak, if there is a leak present or not.
Connections.
Connections like this.
ठीक है? सीधे fluid नहीं देखना है हमको. So if you started the chest tube, patient से हमने start किया, तो patient is the first thing. We have seen that chest tube is inside. Position कहाँ है? Cranial गई है, caudal गई है. Okay? Lung has expanded. Collection है कि नहीं? Okay. Then comes the second thing. All the connection. So first connection is between the chest tube and your drainage system. So that connection is sealed or not? The dressing is okay or not?
Yes, sir.
That is the important thing. Then comes your drainage system. So drainage system में क्या देखना है हमको?
Sir, the column movement with respiration is present or not, bubbling has stopped or not.
So column movement, पहले तो type of drainage पता होना चाहिए, single bottle, double bottle, triple bottle, and whether this has been properly connected and the interconnection between the bottles is okay or not. Okay, then the drainage volume. So your first thing then you told about the movement of the column. So movement of the column, अगर नहीं है तो क्या होगा? क्या possible differential diagnosis?
So either the tube is kinked or clamped. The patient might be lying on the tube.
Okay.
There could be lung tissue, there could be blood clot, and thick pleural secretions which can block the tube.
Okay.
And also, sir, if the lung is fully expanded, there won't be bubbling present.
Very good. Bubbling means tightly.
Oh,
Tightling
sir,
will be.
yes, sir.
Okay. So,
Yes, sir.
how do you assess any leak?
Sir, we start from the patient end. We clamp the tube and see if bubbling is still present or not. If the bubbling
How do you
is,
assess the site of the leak?
yes, sir.
Yes, tell. आप बता रहे थे, बताओ.
So we clamp on the patient end and we see if the bubbling has stopped or not. If the bubbling has stopped, it means the leak was coming from the patient end. And we move towards the drainage system from the patient side, and we keep on clamping and see if the bubbling is present or not, sir. With help of it, detect the site of.
So bubbling can be there because of any leaks in the system, okay, or excessive air in the pleural cavity. So if there is excessive collection in the pleural cavity, that will lead to bubbling. If the sentinel hole is outside the chest tube, that will lead to bubbling. If the connection between the chest drain and the drainage tube is little bit loose, that will lead to bubbling. Okay, so that all the things you need to know कि bubbling क्यों हो सकती है, excessive bubbling can why. So अगर ये lung expand हो गया है तो क्या हम इसको remove कर दें? कल surgery है इसकी.
So we should not remove the tube before induction, before the mechanical ventilation.
So whenever, so the recommendation is there, if the patient is being posted for surgery within 40 to 72 hours, we should not remove any chest tube before the surgery. Okay.
Yes.
So, क्या preoperative orders दोगे आप? Apart from what all preoperative orders will you give for this patient?
So we'll ask for the routine examinations, which will include CBC, LFT, KFT, serum electrolytes, chest X-ray.
Sir, this is pre-operative order. So,
Oh, yes, sir.
so
So we'll give the NPO advice. We'll ask for written informed consent, anti-aspiration, and anxiolysis. Apart from that, sir, we need to sir, ये देखेंगे, and we'll ask while shifting the patient, precaution has to be
what all things
taken.
you will ask the sister in charge of the what all things you will write in your PAC so that the surgical colleagues know that they tell their sister of the ward कि ऐसे ऐसे patient shift होगा क्या क्या करना होता है.
So while shifting the patient, first of all, the drainage system has to be emptied and fresh water has to be put. Second, while shifting the drainage system should be below the chest level at all times, and should not be the chest tube should not be clamped, especially if it is for pneumothorax, as it might complicate.
So that is very important thing, and that is the most common complication that we even after so much of this discussion, still we are facing these things. So always, like we have discussed, the chest drain should be below the chest level, around 100 centimeter or 45 centimeter. Chest shift the patient with unclamped chest drain, especially if it's set for pneumothorax. And again, we have to have a fresh water seal so that it is not more than 2 or not less than 2 centimeter. Okay. So again, retention checklist.
Yes, sir. So same, we go for if the connection. Yes, sir.
So we have to see again, recheck whatever you have ordered in the preoperative evaluation and whatever you have given in the preoperative orders. So what is the plan of anesthesia for this patient?
So my plan of anesthesia would be general anesthesia with endotracheal intubation with or without any regional anesthesia for pain
Why
management.
not only renal anesthesia?
Sir, the patient has
Surgery हो सकती है कि नहीं?
pneumothorax.
Pneumothorax, so there is not a तो repair हो गया.
Yes, sir. So we can go for regional anesthesia.
There should be some why not regional anesthesia? किस पोजीशन में होता है बैकहार्ट रिपेयर?
Sir,
तो
lateral liquid.
अच्छा, okay. In regional anesthesia, what anesthesia technique you are going to use?
So we can for shoulder surgery we can go for scaling, interscaling, supraclavicular approach, little places doctor secting, and interscaling approach.
Supraclavicular better or interscaling better?
Interscaling is better.
Why interscaling is better? Why not supraclavicular?
Sir, it blocks the C5 and C6 routes. So
C5, C6 रूट तो सब में हो जाएगा. C5, C6 से ही तो बनेगा ना, अपर ट्रंक से ही बनेगा, डिवीजन ही बनाएगा. सुप्राक्लेविकुलर तो वही है. क्यों इंटरस्केलिंग करना है? क्यों नहीं सुप्राक्लेविकुलर में हो सकता है? पहले तो ये बताओ ब्लॉक में हो. चलो तुमने बोला ब्लॉक में हो सकता है, तो कौन सा ब्लॉक देंगे? सुप्राक्लेविकुलर इंटरस्केलिंग?
So interscaling block. Interscaling block is
नर्व इस निकल जाती है उससे पहले. ठीक है.
So
Can this case be done under interscaling?
Sir, the anatomy might be distorted, so it will be difficult, I think.
No. That is not the reason. So you should know the positioning of the patient. The interscalene block usually gives analgesia for only the shoulder. What about the chest injury, the chest contusion, the positioning of the patient, the chest tube that is there, that will also cause pain to the patient. That may hamper your intraoperative experience of the patient, the experience of the surgeon. The patient will not be comfortable intraoperatively. So ideally, in this patient, always you have to go with GA with renal anesthesia. Okay. So you should know why and why not. Okay. The choice of anesthesia will be renal anesthesia without any analgesia technique. You can go for interscaling, you can go for supra upper trunk block or pan block. Any other block can be
So intercostal brachial nerve block and
intercostal
for
brachial.
pain relief. It's a pain relief के लिए.
पेन तो शोल्डर का है भाई, शोल्डर के लिए और क्या दे सकते हैं?
शोल्डर के लिए सर
सर्जरी से
brachial
शोल्डर
plexus block कर सकते हैं.
brachial plexus, these are all brachial plexus.
Pleural plexus.
Scalene is
Yes,
C5,
sir.
C6. This is superficial cervical and upper trunk block. This is pericapsular nerve group block for the shoulder joint. और कुछ दे सकते हैं? You can go for the suprascapular nerve also, है ना? So और पता होना चाहिए the anesthesia technique, analgesia technique that can be used in this sort of surgeries. So apart from this, GA दे दिया, straightforward GA हो गया. Any other
Yes,
thing you want to avoid in the intraoperative period? So basically, always whenever whether it is chest tube there or not, you should avoid nitrous, especially in the patient with chest tube. There is no issues, but then also there can be some loculated collection. So we are not going to avoid nitrous oxide. Avoid clumping of chest tube.
Yes.
So any other what ventilation strategies we will use? So this patient is having a blunt trauma chest.
Yes, sir.
Pneumothorax. We are not sure of the chest X-ray में ribs हमने देखा नहीं और pulmonary contusion पता नहीं हमको.
Yes, sir.
Chest trauma patients को हम कैसे ventilate करते हैं?
Sir, to prevent further trauma, chest injury, we use low tidal volume settings.
Very
And
good.
peak inspiratory pressure should not exceed more than 30 centimeters of water.
Very
We can
good.
use pressure control mode, sir, and where we have better control of the peak inspiratory pressures. Apart from that, sir, we can use PEEP, but at low PEEP has to be used. Again, to
So
not cause any injury.
depending on the how much is the leak, है ना? So if you are giving excessive PEEP, it will increase the air leak from the fistula or from the pleural from the alveolar or pleural injury area. Okay, if I have to, you titrate to SpO2 of 92% or 94%. So similarly, suppose this patient was not having an ICD and was being after chest trauma, this patient might have come for shoulder surgery. So you should be able to understand what are the signs and symptoms of pneumothorax in a ventilated patient. So they are very straightforward. Increase in the pleural pressure, increase in the, basically we will have a peak increase in the peak pressure, decrease in the expiratory volume secondary to the air leak into the pleural space, increase in PEEP even after discontinuation of increasing and expiratory pressure even after discontinuation of PEEP, and apart from that tachycardia, hypotension and hypercardia. Okay. So post-op care is straightforward with analgesia and breathing exercises. So I think we have covered most of the part of the chest tube. So a little bit we will touch on the another important thing that is usually we can come across. So suppose this patient initial Bankart repair failed, and now the surgeons have thought of doing another procedure that is called lethargic procedure. That is again for the shoulder dislocation. In the meantime, in the postoperative period, patient had a purulent discharge from the chest tube, and after some days, the bubbling has increased in the chest drain. There was a progressively increase in the rate and falling saturation. What are the possible causes?
The mainly this could be pleural fistula.
So bubbling increased हुआ पर क्यों हुआ increase इसमें? What is the probable cause of bubbling?
Sir, air leak, sir. There could be large air leak.
Time why the bubbling happened?
Sir, could be rupture of any villi or sir.
So usually the any pleural infection, so in the infection in this cavity may lead to a secondary injury to the alveolar to the alveoli, and that may lead to increase in the leak.
Air leak. Yes.
So diagnosis is basically done by either X-ray, CT, or by the FOB. If it is a bronchopleural fistula, then we have to go for a foreign fiber optic bronchoscopy for diagnosis. So this was the classification I thought we should discuss earlier, but we can discuss here also. So the same thing. So if the patient is, this is called when there is a forced expiration only, there is an air leak that is normal. When the patient asking the patient to cough at expiration, inspiration, and continuous bubbling in both the phases of inspiration and expiration, that is grade 4C. It is called Serfolio classification for air leak for quantification of the the amount
Sorry
of.
to interrupt you, but we are running out of time. If you
Sure,
can
sure.
like
Bas we
wind
just
up. Yes, yes. Thank you.
So I think I will just wrap it up. So conservative measures, usually it heals by itself, and so we can estimate the volume loss with the help of difference between inhaled and exhaled tidal volume. And for intubated as well as for non-intubated patient, and the basic idea in management of BPF will be the lung isolation and the ventilation of the open airway. So goals will be to maintain adequate oxygenation ventilation. How? If possible, if it is feasible, try to maintain the spontaneous ventilation as much as possible during the surgery. If it is not possible, we have to paralyze, reduce the inspiratory pressure, tidal volumes to decrease the leak from the fistula. Or you can go for high frequency ventilation, oscillation, differential lung ventilation through TLT. And adequate pain relief is the most important aspect of the BPF management. So criteria for removal, though our guidelines say 300 ml, but Indian practice is about 100 ml. Air leak should be around 50 ml per minute for 12 hours. Chest X-ray should be fully expanded, and removal is also straightforward. Thank you.
Thank you, sir.
Thank you, sir. It was a very nice discussion of ICD. And thank you, Dr. Shivam. Thank you, sir. Now we have next lecture on ASA physical status, which will be taken by Dr. Sheetal Singh. Dr. Sheetal Singh, she's Assistant Professor in Department of Anesthesia at ABBIMS and Dr. RML Hospital. Her achievements are that she is a IRC certified ACLS and BLS instructor. Awards in paper presentation in national conference. She also received an award in cultural and art literary competitions in ISA Yuvacon in 2023. Her area of interest is obstetric anesthesia and pediatric anesthesia. Dr. Sheetal will be taking the live lecture on ASA physical status. Over to you, Dr. Sheetal.
Thank you, ma'am. So today I'll be discussing ASA physical status with you all. Why we need to study about this? What is the purpose of studying ASA physical status? The purpose is so that we can assess the degree of patient sickness and physical status prior to selecting any patient for anesthesia or surgery. It also helps in record keeping and better communication in between the colleagues. Beside this, it also creates a uniform system for statistical analysis. Now, let's deep dive into the history of ASA physical classification. Originally, it was introduced in 1941 by Satchad et al. The functional status was subsequently omitted from the classification. It was revised in 1961 and officially adopted by ASA in 1962. Till 1980, there were only 5 ASA grades. In 1980, a class 6 was added that was brain dead for organ harvesting. The last revision of this was done in year 2020. Now, what are the different grades in ASA classification? ASA 1 is a normal healthy patient. ASA 2 is a patient with mild systemic disease. ASA 3 is a patient with moderate systemic disease. ASA 4 is a patient with severe systemic disease that is constant threat to life. A moribund patient who is not expected to survive without an operation is classified as ASA 5. ASA 6 include declared brain dead patient whose organs are to be harvested for donation purposes. E can be added to any of these ASA classes if it is an emergency surgery. Now let us understand it further by some examples. In ASA grade 1, a healthy non-smoker adult who has no or minimal use of alcohol is considered as ASA 1. In pediatric, a healthy child with no acute or chronic disease and with a normal BMI for age percentile is a ASA 1 child. In obstetric, there are no patients who fall in ASA 1 category. In ASA 2, in adult patient, a patient who is current smoker or social alcohol drinker are ASA 2 patients. Patients having BMI between 30 to 40 are also ASA 2 patients. Patients who are having well-controlled diabetes and hypertension or mild lung disease are ASA 2 patients. Let's see some pediatric example. A child who is asymptomatic congenital cardiac disease or child having well-controlled dysarrhythmias or asthma without exacerbation, well-controlled epilepsy, all fall under ASA 2 category. Beside this, a child who is having abnormal BMI for the age or having oncological state in remission, autistic child with mild limitation are also ASA 2 patients. Now, a normal pregnancy is considered as ASA 2. Beside normal pregnancy in obstetric patient, a patient who has well-controlled gestational hypertension, diet-controlled gestational diabetes, and controlled preeclampsia without severe feature is also considered as ASA 2 patients. Let's see some example for ASA 3 physical status in adults who are poorly controlled diabetic, poorly controlled hypertensive, or having COPD, or having a BMI of more than 40 are considered as ASA 3. Beside this, adult having acute hepatitis, alcohol dependence, drug abuse, moderate reduction in ejection fraction, or having end-stage renal disease but undergoing regular scheduled dialysis are also ASA 3. Beside the adult having a history of more than 3 months old MI, CAD, or stroke are also ASA 3 patients. In pediatric patient, a child with uncorrected stable congenital cardiac anomaly is considered as ASA 3 patient. Beside this, a child with asthma with exacerbation, poorly controlled epilepsy, morbid obese child, a child with malnutrition, or severe OSA, these all are ASA 3 childs. Beside this, a child having renal failure, muscle dystrophy, cystic fibrosis, a history of organ transplantation, or a premature infant with post-conception age of less than 60 weeks is considered as ASA 3. A point to be noted here is that a full-term infant less than 6 weeks of age is also considered as ASA 3 patients. Now let us see some obstetric example of obstetric patient with preeclampsia with severe features are considered as ASA 3 patients. Beside this, gestational diabetes with complication requiring high insulin are also considered as ASA 3 patients. Beside this, obstetric patient having thrombophilia requiring anticoagulation are also considered as ASA 3 patients. Now, ASA 4 patients, in adult patients who have recent history, that is less than 3 months old history of MI, coronary artery disease, stent, or stroke are considered as ASA 4 patients. Adult who are undergoing cardiac ischemia or severe valvular dysfunction are also ASA 4 patients. Beside this, a severe reduction in ejection fraction is also considered as ASA 4. Adults who are in shock, sepsis, or DIC are also ASA 4 patients. Besides this, end-stage renal disease patients who are not undergoing scheduled dialysis are also ASA 4 patients. In pediatric patient, a child who is symptomatic congenital cardiac abnormality is considered as ASA 4. A child having congestive heart failure or active sequelae of prematurity, acute hypoxic ischemic encephalopathy, a child having shock, sepsis, DIC, all are ASA 4 patients. Beside this, a child with severe respiratory distress, and advanced oncological state is also considered as ASA4 patient. In obstetric patient with preeclampsia with severe feature complicated by HELP and other adverse event are considered as ASA4 patient. Beside this, peripartum cardiomyopathy with ejection fraction less than 40% are also ASA4. An obstetric patient who is having uncorrected decompensated heart disease is also ASA4 patient. Now let's see some example for ASA5. In adult having ruptured abdominal or thoracic aneurysm is considered as ASA5. Beside this, adult having massive trauma, intracranial bleed with mass effect, ischemic bowel with multi-organ dysfunction is also ASA5. In pediatric examples, similar to adult, a child having massive trauma with or having intracranial hemorrhage with mass effect are also considered as ASA5. Beside this, a child requiring ECMO or having a history of cardiac failure or respiratory failure or arrest, they are also considered as ASA5 patients. Beside this, a child having hepatic encephalopathy or ischemic bowel with multi-organ dysfunction is also considered as ASA5. In obstetric example, ASA5 include a obstetric patient having uterine rupture. Now, after reading this, we need to also know what are the limitations of our ASA status classification. The first and foremost is that it does not take into consideration the type of surgery that the patient is undergoing. And there are sometimes inconsistency in assessing the patient. It is also subjective. It may vary from one person to another. It does not include age and sex of the patient. And sometimes it is incorrectly used in certain places where it should not have been used, like in triage and in decision-making regarding inpatient and ambulatory care, and insurancer also may use it as a billing modifier, which is wrong. Now, let us understand this with the example. A patient who has not systemic disease is a ASA1 according to ASA classification, but he or she is having severe post-burn neck contracture. Then is there no risk for anesthesia? That is not so. This patient is a high-risk patient for us, but according to ASA, he or she is a ASA1 patient. Let's see another example. A 64-year-old male who is supposed to undergo laparotomy with gastrojejunostomy. The reason for this surgery could be malignant or non-malignant. Will the ASA status be same for malignant and non-malignant? No, it will not be. So ASA status is still lacking in some aspect. So what are the implications after, what do you understand after listening to whole the lecture? There are two implications. One is if we overestimate a physical status, then it will increase the number of deaths that patient will undergo, and this will inadvertently increase the expenses on already overworked healthcare system. If we underestimate the ASA physical status, it might compromise the patient safety. Now, to conclude it all, ASA physical status is of prime importance in preoperative patient assessment and is a good predictor of perioperative morbidity and mortality, but it is still evolving and better standards can be formed in the future by adding further examples which may help anesthetists and even non-anesthesia personals. Thank you.
Thank you, Dr. It was a very, very nicely explained. Thank you so much. Now we will move to our next session, which is a case discussion on a 55-year male with CA lung posted for pneumonectomy. The moderator is Dr. Akhilesh Gupta, sir. Sir is Director Professor in Department of Anesthesia. And sir at ABB IMS and Dr. RML Hospital. And the PG who's presenting the case is Dr. Vaishali. She is third year PG in our department. And Dr. Nitin Thakur is the senior resident who will summarize the case. Over to you, sir.
Thank you, Jyoti, for the introduction.
Vaishali, can we start?
Yes, sir. Good afternoon,
Yeah, please start.
everyone. I'll be presenting the case of a 55-year-old male with carcinoma lung posted for pneumonectomy. My patient, Mr. Badrinath, is a 55-year-old male, Hindu by religion, rickshaw puller by occupation, and is a resident of Motinagar, New Delhi. He presented to the hospital with the chief complaints of cough with expectoration for 2 years, breathlessness for 5 months, and coughing of blood that is on and off for 2 months. The patient was apparently well 2 years back when he started having cough, which was insidious in onset, gradually progressive, increased with exertion, and was relieved on taking cough syrup. The cough was associated with a scanty, that is around teaspoonful mucoid expectoration, which was initially white in color but now has occasionally turned blood stained since past 2 months. The sputum is not foul smelling, and cough is not associated with any diurnal, postural, or seasonal variation. The patient also gives a history of breathlessness on exertion since 5 months, which is insidious onset, gradually progressive, and was initially present only while pulling the rickshaw, which was hampering his livelihood, and now has increased to breathlessness while hurrying on a leveled ground. The shortness of breath is relieved on rest. There's no diurnal or seasonal variation, no history of breathlessness on lying down, and no history of nighttime awakening due to breathlessness. 2 months back, patient noticed on and off coughing of blood, which was insidious in onset and around 2 to 3 ml per episode, which increases with exertion and is bright red in color. It was not associated with nasal bleeding, nausea, vomiting, blood in stools, or presence of black tarry stools. There is no postural variation. The patient also gives a history of appetite since last 6 months and weight loss of around 5 kg or nighttime sweating, no known tuberculosis patient, or any history of joint pain or bone pain. There's no history of facial puffiness, lower limb swelling, or decreased urine output. Past history, there's no history suggestive of any chronic illness in past. There's no history of anesthesia exposure and surgery in past. No history of blood transfusion, any chemotherapy or radiotherapy, and the patient does not have any known allergies. Personal history. He is a smoker for past 40 years and smokes around 20 BDs per day, which makes up to a pack years of 40, and the smoking index comes out to be 800. The patient had last smoked around 1 month back. He is a rickshaw puller by occupation and has been doing this work for 30 years. His livelihood has been impaired due to breathlessness and has normal bowel and bladder habits. Family history. There's no history of similar complaints in parents or siblings, and no history of tuberculosis in family. The patient belongs to a lower socioeconomic status. On examination,
Vaishali, what are the positive findings in your history?
so my patient is a 55-year-old male who is a chronic smoker, and he has a pack years of 40 and smoking index of 800, and he has a
What
history
do you
of
mean by pack years? What do you mean by pack years?
so pack years refers to the number of pack of cigarettes smoked per day multiplied by the number of years of smoking.
And what is smoking index?
Smoking index refers to the numbers of cigarettes smoked per day multiplied by the year of smoking, number of years of smoking.
Okay. What else are the positive findings?
The patient gives a history of cough with expectoration, which was scanty and now has become blood tinged. He also has a history of breathlessness, which was initially present only on exertion, but now the grade has increased, and he is breathless even on hurrying on the leveled ground. And there's also history of blood in sputum, sir. So these uh, uh, these are the positive history findings.
So what is the provisional diagnosis on the basis of history?
On the basis of history, the probable diagnosis may be tuberculosis due to its high prevalence in India, and it can be chronic obstructive pulmonary disease or bronchiectasis, or it may be a lung malignancy as well.
Can it be a cardiac cause? How can you distinguish it on the basis of history that this is not a cardiac cause of cough, and this is a respiratory cause of cough?
The cardiac cough generally is a dry cough which is persistent in nature. But in my patient, the cough is expectorant and is associated with the mucoid expectoration as well. And there's in cardiac cough, the cough will be a later symptom. Dyspnea will be presenting first. The first symptom of presentation will be breathlessness. While in respiratory cough or respiratory dyspnea, cough will present first, which will further present with dyspnea. So difference of presenting symptoms is there as well. Cardiac cough will be associated with the breathlessness on lying down and breathlessness during night times, which is orthopnea and paroxysmal nocturnal dyspnea, which is not present generally in respiratory with respiratory cough.
So rightly said that when we talk about the cough because of cardiac origin, it is the dyspnea first, which later progress to cough, and the dyspnea is more on lying supine, orthopnea, and paroxysmal nocturnal dyspnea. So you said that based on this history, less likely that the cause is a cardiac origin.
Yes, sir.
Why tuberculosis?
Sir, because there's cough, chronic cough with expectoration, which is associated with breathlessness, and with generalized weakness, loss of weight, and loss of appetite. And also, hemopsis may be present in tuberculosis as well, sir. And also,
These
in a
features
country like, yes, sir.
Yeah, so these features will be there in a tuberculosis, and these features can be there in the malignancy also. So you keep a provisional diagnosis of tuberculosis or malignancy. Okay. Let's proceed on your examination.
Okay, sir. On examination, on general physical examination, the patient was conscious and oriented to time, place, and person, was sitting comfortably on his bed. He is thin built with a weight of 50 kg, height 160 centimeter, which makes up to a BMI of 19.5 kg per meter square. Pallor present and clubbing of grade 2 was present. There was no icterus, cyanosis, pedal edema, or lymphadenopathy. JVP was not elevated, and IV intravenous excess was present as veins were seen on the dorsum of hand. Pulse rate was 70 beats per minute, palpated in right radial artery, regular and good in volume and character with no radioradial or radiofemoral delay. All peripheral pulses were palpable. BP was 130 by 82 millimeters of mercury, measured in right upper arm in sitting position with an adequate size cuff. Respiratory rate was 14 per minute, which was regular and abdominothoracic in nature. There was no use of accessory muscles of respiration. Room air saturation was 94% and the patient was afebrile. On airway examination, there was no visible maxillofacial deformity or any apparent deformity of nose and cheeks. Both nostrils are patent. The patient had a poor oral hygiene. There was no loose tooth or artificial dentures. Mouth opening was more than 5 centimeters. Hyomental, thyromental, and sternomental distances were within normal limit. Temporomandible joint was admitted 1 finger. The neck extension was adequate, and the modified Mallapati class 2 was present. On respiratory system examination, upper respiratory tract examination revealed no deviated nasal septum, nasal polyp, or sinus tenderness, and normal nasal alley. On inspection, the chest was normal, symmetrical in shape. Chest wall appeared normal. Trachea appeared to be in midline. Chest movement were reduced on the right side. There was no intercostal retraction, flattening, or bulging. There was no drooping of shoulders, no visible pulsations, dilated veins, sinuses, or scars. On palpation, the trachea was in midline, chest extension was reduced on the right side, and there was no local rise of temperature or tenderness. On percussion, a dull note was heard over right, middle, and lower lung fields, while all other lung areas were resonant on percussion. On auscultation, there was a reduced air entry over right, middle, and lower lung zones, and vesicular breath sounds were heard all over the other zones. On bedside pulmonary function tests, Sebrus's breath holding time was 20 seconds, single breath count was 25, post expiratory time was 5 seconds, and cough test came out to be positive. On cardiovascular system examination, on inspection,
Any significant finding in cardiovascular system?
So on palpation, apex beat was felt at left fifth intercostal space, and on auscultation, S1 and S2 were normal, and there was no murmur.
Okay.
On abdominal examination, on inspection,
No
the shape of
significant finding?
no, sir. Abdominal examination was within normal limits,
Okay.
and central nervous system examination was also within normal limits, sir. And the spine was normal in curvature with no deformities.
So now based on your history and examinations, what are the probable diagnoses?
So based on the history and examination, the probable diagnosis will be as the examination reveals a dull percussion note on percussion in the right, middle, and lower zones, and reduced air entry in the same regions. There may be a consolidation present in the right, middle, and lower zones. So my probable diagnosis will be firstly tuberculosis or and lung malignancy, sir, maybe. But I would like to confirm the diagnosis with the help of investigations.
Can you distinguish between tuberculosis and lung metastasis on the basis of your history and examination?
So, according to the history of my patient, the patient had no history of any tuberculosis contact or fever or nighttime sweating, which rules out the diagnosis of tuberculosis on the basis of history. But we can go with the sputum culture sensitivity and sputum ZN staining for confirming the diagnosis. But probably it is not tuberculosis based on the history.
So you get the CT chest and it came out to be the lung carcinoma of right middle and lower zone. Okay. So the patient comes to you with for pneumonectomy and suggest time for pneumonectomy and what all investigations you will ask for in this patient.
So I will go. I will classify the investigations as the routine investigations and special investigations. In this case, routine investigations will be a complete blood function test, blood sugars, and while special investigations will include a 2D echo.
May want to the basic investigations. Why you want to get hemoglobin in this patient?
So, as it is a major surgery, hemoglobin will give an idea of baseline hemoglobin, as well as the patient is a chronic smoker, which may lead to polycythemia, and the hemoglobin may be the baseline hemoglobin may be raised. However, the patient also has a history of loss of weight and loss of appetite, which may indicate a nutritional deficiency and anemia may also be present. An idea regarding the major surgery, so we can arrange blood accordingly. And
Yeah, because it's a major surgery, so you need to have a
it
pre-op
will
idea
give
of
an idea
hemoglobin.
regarding.
Also, because poor nutritional status, poor reserve of a patient, and history of weight loss, and so hemoglobin can be less. Furthermore, the patient was a chronic smoker, so can have polycythemia also. Besides hemoglobin, what all investigations? What next?
CBC will further include the total leukocyte count, and it may show the total leukocyte count may be raised if there is an infection or as the patient has expectoration. So the infected, it may indicate towards infection as well.
Also, you have not yet ruled out the tuberculosis also.
Yes.
So you need to get a total leukocyte count and a differential leukocyte count. You can find the lymphocytosis also. Okay, then next.
And platelet count may also be increased due to chronic hypoxia status. There will be raised platelet count and increased platelet activity. And so further, I'll like to get the liver function test, which will be affected with the total proteins as well, and serum albumin. Liver function test may be affected if there is a metastasis to the liver. And also, serum albumin and total protein will give an idea regarding the nutritional status of the patient.
Good. Besides the liver function test.
So, blood sugar, as a patient is a 55-year-old male, I'll like to get blood sugar as well, and renal function test, in which specifically I want to know serum creatinine and blood urea nitrogen.
Why you want to get renal function test in this patient?
So, as it is a case of carcinoma lung, initially it was renal dysfunction was associated. It was thought that the renal dysfunction was associated with the increased mortality in the post-thoracotomy patients. However, there is this school of thought is like these days not followed, but the renal dysfunction may occur in post-op period as well, in cases of open thoracotomies. So I'll like to get a baseline renal function test done so that I can compare.
Yeah, because of deranged renal function, we have an increased risk of post complications, and renal functions may deranged after post thoracotomy also. So it's good to get a renal function test. Anything else?
Sir, a 12-lead ECG and a chest
Any?
X-ray PLD. And sputum culture
You want to
sensitivity.
get a chest X-ray, or what will you look in chest X-ray?
Sir, as the patient is a chronic smoker, the chest X-ray may show the features suggestive of COPD, which are like flattening of the diaphragm, straightened ribs, hyperinflated lung fields, reduced heart shadow with reduced bronchovascular markings, and the lesion can also be seen like right, middle, and lower zones are affected. So we can see the area of consolidation as well on the X-ray. Apart from this, we can get an idea of tracheal diameter as well.
Yeah, very good, very good. So chest X-ray, we can get the changes of COPD, we can get the idea of consolidation, where is the growth, and we can get the idea of the tracheal diameter and the diameter of left mainstem bronchus. Why we want to know the diameter of trachea and left mainstem bronchus?
This is to plan the to decide the plan of anesthesia, as if I want to go for one lung ventilation, so I'll need to put a DLT for which the size can be determined by measuring the diameter of trachea using a chest X-ray and the diameter of the left main bronchus as well.
Yeah, so to get an idea of the size of DLT, which needs to be put in the patient. Okay. Then what next investigation? Why you want to get ECG in this patient?
Sir, as these patients are chronic smokers, so are more vulnerable to developing coronary artery disease due to atherosclerosis. So there may be presence of some underlying cardiac comorbidity. Also, there may be right ventricular dysfunction, which may the changes may be present in ECG. So we can make out the rule out other comorbidities as well. And also, however, my patient is a 55-year-old, but patients generally with carcinoma may be of old age, so there may be some other changes as well, which can be.
So anything else? In the ECG, one thing is that because of COPD, patient may have right ventricular dysfunction, right ventricular hypertrophy. So we can find changes of those. Then in ECG, because of nicotine, there are chances of patient having CAD. And if the patient has underlying CAD, the chances of complications and the mortality and the morbidity associated with the thoracotomy increases drastically. And also you need to know about the basic rhythm in the ECG arrhythmias, the perioperative period. So what all arrhythmias are more prone for in the perioperative period?
So these patients are prone for atrial fibrillation, so
These
mainly.
patients are
These are the
prone for atrial fibrillation, so you need to have a baseline ECG. And these patients have increased pulmonary vascular resistance also, and increased PA pressures also. So for all those things, you need to have a ECG. Okay, besides ECG, any other test?
So special investigations, I'll go for sputum culture sensitivity and routine microscopy, and also sputum for ZN staining. And I'll like to get an ABG done, spirometry, and diffusion lung capacity of carbon monoxide, and cardiopulmonary exercise testing.
So why you want to get this spirometry done in this patient? Can we predict the mortality or morbidity of a patient by doing spirometry, or is there an approach on which we can predict that how much morbidity the patient of going under pneumonectomy will have?
Yes, sir. For the patients undergoing the thoracotomies, there is a assessment tool that is described as a three-legged stool for preoperative assessment of patients undergoing thoracotomy, which includes spirometry, diffusion lung capacity of carbon monoxide, and cardiopulmonary exercise testing. With the use of spirometry, we predict predictive post-operative percentage FEV1.
Basically, it is about the prediction of respiratory mechanics and lung parenchymal functions and the cardiopulmonary interactions. So when we know about respiratory the spirometry and get, because DLCO you also get by the spirometry only by doing pulmonary function test. So you say that there's a three-leg stool approach. One is to look about the respiratory mechanics. The second is to look about the lung parenchymal functions. And the third is to know about the cardiopulmonary interactions. Okay. So how do you know about respiratory mechanics?
On the basis of spirometry, we will calculate the percentage predicted post-operative FEV1, which if more than 40% indicates a low risk of post-operative pulmonary complications. However, if it is less than 40%, it indicates an increased but lower risk of post-operative pulmonary complications. And if the value is less than 30%, the risk is higher. So based on the predictive post-operative FEV1%, we can
So what are the factors on
plan
which the
accordingly.
post-operative FEV1, predicted post-operative FEV1 depends? Because these patients are COPD patients. They will be having a decreased FEV1 by FVC because by virtue of they being COPD patients. So is there a formula by which we can say that how much will be the predicted post-operative FEV1?
Yes, sir. There's a formula which, on the basis of number of sub-segments to be removed, predicts the post-operative FEV1%. That is, predictive post-operative FEV1% is equals to pre-operative FEV1 multiplied by 1 minus percentage of the subsegments removed divided by 100.
Can you just show me the slide?
Yes, sir.
Yeah. So these are the total lung segments. Total subsegments is 42. So suppose we want to get the right lower lobectomy. So that have 12 segments and total segments are 42. So percentage of lung segment removed is 12 by 42, that is 29%. So predicted post-operative FEV1 is pre-operative FEV1 multiplied by 1 minus percentage of lung segment removed. So that is 1 minus 29%. So that is 71%. So predicted post-operative FEV1 will be 0.71 of the pre-operative FEV1. Okay.
Yes, sir.
So how do we know about now we know about the mechanical function, respiratory mechanics by knowing the predictive post-operative FEV1. And as you had rightly said that if it is less than 30%, then they have a very high risk of post-operative morbidity. Then how do we know about lung parenchymal function?
So the lung parenchymal function is assessed by the predictive post-operative diffusion lung capacity of carbon monoxide, which has values. If the value is more than 40%, there is a lower risk. We can go with the surgery. If the value comes out to be less than 40%, then there is a low risk of post-operative pulmonary complication. And similarly, if it is less than 30%, there is a high risk of post-operative mortality and morbidity.
So again, the predicted post-operative diffusion capacity of carbon monoxide is done in the same way as we had done about the FEV1%, that is predicted post-op, which is equal to pre-op into 1 minus lung segment removed. And the thing which I like to emphasize here is that why we say that diffusion capacity of carbon monoxide, because that tells about the functioning of surface area between the alveolo-capillary interface. So if there is a problem in the alveolo-capillary interface, it tells about the problem in the lung parenchyma. So diffusion capacity of carbon monoxide, that is also done through spirometry only. And this test tells about the lung parenchymatous functions. Okay, what next? What is the third test?
Cardiopulmonary exercise test.
Good.
Cardiopulmonary can be simple or sir, it can be simple test or the formal testing. Simple tests include assessing the metabolic equivalence of task as oximetry, and
What
formal
is
exercise.
metabolic equivalent? What is one metabolic equivalent?
The one consumed at rest by a person, which is equivalent to 3.5 ml per kg per minute.
And that is, suppose a patient can climb one flight of stairs. So we can say that how many metabolic equivalents person can be having?
Around 4 meds the patient.
Yeah. So when a person can climb one flight of stairs, so we can say that patient is having 4 metabolic equivalents, and it says that if patient can climb chances of morbidity of thoracotomy is much less. And can you just tell me what is the height of flight of stair? Any idea? When we talk about the
Sir, one flight of stairs is around 10 feet height, that is 3 meters.
Yeah, that's very good. It's 3 meter. And suppose patient cannot walk on the stairs. A patient may have osteoarthritis, knee, and patient cannot climb stairs. So is there any other way by which we can know about cardiopulmonary function of a
Yes, sir,
patient?
we can go for 6-minute walk test or shuttle walking test, which are a simpler test of exercise testing. So in
What is
6-minute walk
6-minute walk
test, we
test?
ask the patient to walk for 6 minutes on a level ground, and the distance walked in 6 minutes in meters will give an idea regarding the VO2 max of the patient.
So how much should be the distance a person should walk in meters? When we can say that, yes, this is
Sir, around around 450
around-
meters at least the patient should be able to walk, which will indicate a VO2 max of 20 ml per kg per minute.
Yeah, so when we talk about VO2 max, it is the distance which a person can walk in 6 minutes divided by 30. So if a person can walk 450 meters, so divided by 30, that comes out to be 15 ml per kg per minute. And the normal VO2 max is around 30 to 40 ml per kg per minute. So if the patient is having VO2 max less than 15 or 10 to 15, then these patients come under the very high risk stratification. So now we have talked about various tests to risk to do the risk stratification of these patients going for thoracotomy. So now, how will you like to optimize this patient?
So, firstly, I would like to stop this smoking. Uh, Firstly, smoking cessation. Then lung recruitment maneuvers like chest physiotherapy, incentive spirometry, and deep breathing exercises I will advise. I'll start antibiotic prophylaxis, and I'll go about with bronchodilation.
Very good. So we'll start with bronchodilator. You want to ask the patient to stop smoking. Can you tell me how much time before a person should stop smoking, and how it is relevant to the risk during surgery?
There's no fixed time limit decided. However, the smoking should be stopped as early as possible from the day of surgery. And depending on the number of hours or number of days the patient has stopped smoking, the respiratory function of the body improves. For example, if patient has stopped like 12 to 24 hours before the surgery, there will be a decrease in carbon monoxide levels, and there will be decrease in nicotine levels. And if the patient has stopped for 48 to 72 hours before the surgery, carboxy hemoglobin levels will be reduced. And further, for 1 to 2 weeks, if the patient has abstained from the smoking, then there will be improved mucociliary, decreased sputum production, and further as to there will be the mucociliary function will be normalized, and at 3 to 4 weeks before smoking, the wound healing will be normalized, and around 4 to 6 weeks before the surgery, the PFTs will improve. So depending on
Yeah, perfect. So Vishali, why are we so much worried about COPD when we talk about the patient undergoing thoracotomy? Why are we so much concerned? Any idea?
Sir, because this also predicts the as the patient with COPD will have a reactive airway, and we are manipulating the airway will be putting a double lumen tube or a bronchial blocker. So there is increased risk of complications in the perioperative period, like bronchospasm, atelectasis can occur, and there may be increase. There may be sudden bronchospasm if we stimulate the patient in a lighter plane of anesthesia. So we have to plan accordingly. The drugs for anesthesia will also depend on this concentration.
Yeah, so very good. Because these COPD patients are already hypoxemic. So when during one lung ventilation, there are more chances of hypoxemia. So hypoxemia may be aggravated in these COPD patients, and also they have a decreased FEV1 by FVC preoperatively. They have they desaturate fast. Furthermore, they have right ventricular dysfunction. Another important thing is that the COPD patients can have a bulle on them lungs. So when we do the one lung ventilation and when we ventilate in that one lung ventilation, so these patients who have COPD and they have bulle, we have to be extra careful because they have more chances of going into pneumothorax. And one more thing that these COPD patients have auto PEEP, they develop auto PEEP in them. So when we talk about application of PEEP in case of when we talk about one lung ventilation and application of PEEP to the ventilated lung, so we have to take care of this auto PEEP which is generated because of COPD. Okay, fine. Good. So you have done the preoperative optimization. So what will be your preoperative instructions in this patient? The surgeon is planning to
Preoperative
post up
instructions will
a
be
case of right pneumonectomy, and the surgeon says that okay, you want to optimize the patient, you optimize the patient. I'll post it 2 weeks from now, and give me the preoperative instructions. Okay.
Firstly, I will ask for smoking cessation and will instruct the patient and counsel regarding the lung recruitment maneuvers. Incentive spirometry will be, I'll ask him to conduct incentive spirometry, chest and deep breathing exercises, bronchodilators as per the will educate and patient regarding rehabilitation in the post-op period. Also,
So preoperative instructions will be NPO.
yes, is nil per oral status as per ASA fasting guidelines, that is 6 hours for solid, 4 hours and 2 hours for clear liquids. And I'll get a high risk consent in view of uh, major
Decrease
surgery,
post-operative
risk of
pulmonary
post-operative
complications and post-op requirement of post-operative ventilation. Okay.
and I'll ask for a blood group cross match and arranging blood and blood products.
Okay.
And I'll get a ABG on the morning of surgery to be done.
Well, we'll get the ABG of the morning of surgery and continue bronchodilators till the morning of surgery. Will you like to give any anxiolysis in a patient prior to surgery?
I'll like to avoid the anxiolysis in the pre-op period. However, I can give, if needed, like patient is very anxious, anxiolysis is to
Because
be
it is
given
debatable.
under monitored care.
Yeah, you have to assess on case basis and protocols, because if you find a patient is anxious, patient is not having too much of hypoxemia and there is a good pulmonary reserve in the patient. So you can give preoperative anxiolysis. Whereas if you find that the patient is in a bad situation and patient is having a poor reserve, poor lung mechanics, and poor lung parenchymal function, and poor cardiorespiratory function. So you like to avoid giving preoperative anxiolysis. Okay. So you given your preoperative instructions, and now the patient is wheeled in the OT. Okay. So how will you prepare your OT and how will you proceed with the case?
For OT preparation, I'll first ensure the ambient OT temperature. I'll check my anesthesia machine and the suction equipment. I'll prepare a difficult airway cart ready with uh, all the emergency drugs and anesthetic drugs. Apart from this, I'll keep a fiber optic bronchoscope in the OT ready, and uh, all the other necessary monitoring equipments.
So let me ask you, what is your plan of anesthesia before you shift the patient inside the OT? So what will be your plan of anesthesia?
My plan of anesthesia is balanced journal anesthesia the double lumen tube endotracheal intubation epidural for post-op angina.
So you said that general anesthesia with double lumen tube. Which side? Right side, left side?
The left side.
Left side double lumen tube and with the thoracic epidural. Fine.
Yes.
That's the plan of anesthesia. Okay. So in the airway cart, you said that you will keep endotracheal tube and you will keep the double lumen tube. And it's always good to keep double lumen tube of size one small and one big in case you require. So keep different sizes of double lumen tube. And which size of fiber optic bronchoscope you will prefer? Will you keep a normal adult size fiber optic bronchoscope or something different?
The pediatric fiber optic bronchoscope,
Yeah.
depending on.
So for checking the adequate placement of the double lumen tube, because they are the two tubes which are connected together. So using a adult fiber optic bronchoscope becomes difficult. What is the age of your patient and the weight and height of your patient? Vishali, what's the
So my
age?
patient is a 55-year-old male. He is 50 kgs. Yes, sir.
Weight and height
With the
of a
weight
patient?
of 50 kgs and height 160 centimeters height.
So 160 centimeter. Okay. So what size of double lumen tube you are expecting that you will use in this patient?
I'll use the 39 French double lumen tube in this patient.
French double lumen tube. French double lumen tube. So you will be needing pediatric bronchoscope also. Pediatric bronchoscope. Anything else you like to keep in a difficult airway car?
The other equipments for lung isolation like bronchial blockers, I'll also keep, and the single lumen tubes and the video laryngoscope as well if I encounter a difficult airway.
So whenever you are planning to go for a double lumen intubation with a double lumen tube, always keep a single lumen tube also on a backup side, because sometimes it becomes difficult to negotiate a double lumen tube. And if you are trained in using a video laryngoscope, you prefer to use a video laryngoscope, it will give you a better view. Okay. So you have prepared your OT, you have built in the patient, you have made your plan. Know what all monitors you will attach and what all monitoring you are planning to do in this case.
Sir, after taking the patient inside, and I like to attach all the standard ASA monitors, which will include the 6-lead ECG with the non-invasive blood pressure, pulse oximetry, temperature, and after securing the in the later stages, I will get the end-tidal carbon dioxide monitor, capnograph. And apart from this, as this is a major surgery, I would like to secure a arterial line for beat-to-beat
Why
monitoring.
you want to secure
And
arterial line in this case?
sir, as this is a major surgery with the risk of blood loss, and I'll also need to get frequent ABG samples during the surgery to know the levels of PaCO2. So I'll like to secure an arterial line.
Because one thing is that you need repeated ABG and there's a chances of blood loss, and sometimes when the surgeon holds on to the major vessels, there is a sudden hypotension. So there can be sudden fluctuation in the BP. So for that you need a arterial line. Okay. Then central venous line. Why you want to put central venous line?
Sir, central venous line catheter for initiating vasopressor or inotrope therapy, and it will be beneficial in post-op as well to improve the nutritional status. and also will be helpful for guiding the fluid therapy in the post-operative period, sir.
Yeah, though not a very reliable indicator when in a patient with an open chest, but yes, you can use it as a marker to guide fluid therapy, but primarily it is used for fluid administration and giving of inotropes and providing nutrition in the post-operative period. Okay. And okay. So now you plan for, you have attached all the monitors, then proceed. Now what will you do?
After securing the monitors and securing the whiteboard IV access, I'll go about with the induction of general anesthesia. I'll first pre-oxygenate the patient with
Something you like
100%
to do
oxygen for
before
3 minutes.
inducing general anesthesia as per your plan?
Sir, after I will I like to secure a thoracic epidural, sir,
Yeah, you will secure
before
thoracic
induction of anesthesia.
before induction of anesthesia. So at what level you will secure thoracic epidural?
Sir, at T4, T5 level, and I'll try to secure.
Okay. So you will secure thoracic epidural. Okay, now proceed with general anesthesia.
Uh, Sir, after this, I'll go with the induction of general anesthesia. I'll first pre-oxygenate my patient with 100% oxygen for 3 minutes using tidal volume technique. Then I'll give injection midazolam 1 mg IV and
Yeah. So
injection
when you
fentanyl.
pre-oxygenate, why you want to pre-oxygenate these patients?
Sir, as these patients will require airway manipulation, like we are inserting a double lumen tube, and if not a double lumen tube, maybe we will need to insert a bronchial blocker, which takes time, more time as compared to our routine endotracheal intubation. So I want to increase my apnea time by adequately pre-oxygenating my patient.
So what is the endpoint of adequate pre-oxygenation?
Sir, the endpoint of adequate pre-oxygenation is end tidal oxygen concentration of more than 90%.
Very good. So you pre-oxygenated the patient then?
Then I'll start with the medications. First, I'll administer injection midazolam 1 milligram intravenous. Then injection fentanyl 100 microgram intravenous slowly. Then I'll go with the induction agent. I'll choose propofol, injection propofol, 100 milligram intravenous. And after checking for if I'm able to ventilate after giving, after the loss of verbal response of propofol, I'll check ventilate my patient. If I'm able to ventilate, I'll administer a intermediate acting muscle relaxant. Injection dextronium, 5 milligram intravenous. Giving bag mask ventilation for about 3 minutes. I'll then go according to my plan. I'll insert under direct laryngoscopy, insert a left-sided 39 French double lumen tube, and
Vishali, why you
after
choose left-sided double
securing the
lumen tube? You said that the patient has to go for right pneumonectomy, na?
yes, sir.
Yeah. So why you choose left-sided double lumen
Sir,
tube?
This is based on the anatomy of the tracheobronchial tree. The left-sided main stem bronchus is comparatively longer and narrower than the right-sided main stem bronchus. The left side main stem bronchus is around 5 centimeters in length, while the right-sided is around 2 to 3 centimeters in length, and also gives away the right upper lobe bronchus after around 2.5 centimeters. So with left-sided double lumen tube, we get a we have a margin of safety and we can there is better ease of insertion due to this reason in left-sided tubes.
So there is a better ease of insertion when we use a double lumen tube of left side, and we can use left side double lumen tube even if we have to go for right thoracotomy or left thoracotomy. We can get thoracotomy of either size using left side double lumen tube, because the chances of malposition in case of alignment of a right upper lobe bronchus with the right sided DLT is difficult. So it becomes difficult to align the right upper lobe bronchus with the right side DLT. So it's actually, how will you introduce DLT in a patient?
Sir, can you please pardon? The voice is breaking.
Yeah, how will you put DLT in a patient?
Yes, sir. Under laryngoscopy, I'll take the left-sided double lumen tube with the bronchial lumen concavity facing upwards and the stillet inserted in the bronchial lumen, sir, with both the cuffs fully deflated. Under direct laryngoscopy, I'll insert the bronchial lumen inside, and after the bronchial cuff has crossed the level of vocal cords, I will then remove the stillet and turn my tube anti-clockwise and will further pass it until a resistance is met, sir.
So is this a blind technique of putting a DLT, or is it a technique of putting DLT under patient?
This one is the blind technique. However, we also have a direct vision technique which uses fiber optic bronchoscopy.
Yeah, this is a blind technique. And when we talk about the technique under vision, then we put in a bronchoscope in a DLT, and we guide the double lumen tube with the help of a bronchoscope. But it was found that the chances and the positioning of double lumen tube is much difficult when we use the guided technique. So it's always good to use a blind technique to put in a double lumen tube, and then we can check. So how can we check the correct positioning of a double lumen tube using auscultation and using fiber optic bronchoscopy?
Sir, on auscultation, firstly, after inserting a double lumen tube, I'll inflate the tracheal lumen cuff, and on ventilation, I'll check for bilateral air entry. So, once the bilateral air entry is checked, I will clamp the tracheal lumen and open the port distal to it. And after inflating the bronchial cuff, I will check for unilateral air entry according to the side of the bronchial lumen. And post this, I will remove the clamp, and after removing the clamp and connecting the circuit again, there should be bilateral air entry present.
Perfect. So can you please change the slide? Next slide.
Yes, sir.
So yeah, this is how we place it. This is the left-sided double lumen tube, and we check the bilateral air entry. Then we clamp the tracheal lumen and ventilate to the bronchial lumen. And with how much volume should we inflate the bronchial cuff?
Sir, around 2 to 3 ml.
Yeah, it said that whenever you are planning for putting a double lumen tube, never keep a 10 ml syringe for inflating a bronchial cuff. They say that you should have a 3 ml syringe, and if not 3 ml syringe, always keep a size of syringe not more than 5 ml for inflating the bronchial cuff. Okay, so then you inflate the bronchial cuff. Once you inflate the bronchial cuff, the chances of air leaking from the cuff will be reduced, and there will be ventilation on the left side. And then you remove the clamp, and then again fiber optic bronchoscopy to check the correct position.
So using a fiber optic bronchoscope, I'll first pass the fiber optic bronchoscope through the tracheal lumen, and to confirm the tip of the tracheal lumen, it should lie just a few centimeters above the carina. And on then through the tracheal lumen, I'll go and see for the bronchial cuff. Bronchial cuff should not herniate out of the main stem bronchus. It should lie a few centimeters below the carina. And also through the tracheal lumen only, I'll go in the right main stem bronchus and will see for the right upper lobe, right middle lobe, and lower lobe bronchi. Then
Yeah, when you insert through the tracheal lumen, you see that one thing is that the left side portion of the tube is going to the left side and take off of the right bronchus. And when you go through the right bronchus, you will see the three orifice. And if you see a three orifice, then you are sure that this is the right bronchus, because three orifices are seen only in the right bronchus. And then next, after going through the tracheal lumen, what next you will do?
Then I'll go through the bronchial lumen and would ensure in case of a left-sided, so I'll ensure regarding the tip of the bronchial lumen. However, if it is a right-sided DLT, after going through bronchial lumen, I'll see if the port for right upper lobe coincides, is in line with the right upper lobe bronchus or not, as it is ventilating
You
properly.
have gone through the bronchial lumen in the left-sided DLT, na?
Yes. So, sir, when going through bronchial lumen in left-sided DLT, I'll further check the uh, the for left upper lobe and left
Yeah, once you
the
go
main
through the
stem
bronchial
division.
lumen, you will see the two openings once you come out of the bronchial lumen. So, and you see a blue cuff around the bronchial part of the double lumen. Okay. So you said that you will choose the left-sided DLT, whether the case is of left thoracotomy or right thoracotomy, because that is easy to insert and you don't have to align the right upper lobe bronchus with the right-sided DLT. Are there some specific indications in which we have to put a right-sided DLT?
Yes, sir. Uh, uh, there are specific indications for putting a right-sided DLT, which include uh, uh, pathologies involving left mainstem bronchus. That is, there may be intra or extraluminal tumors of the left mainstem bronchus, or a descending aortic aneurysm, which may be present upon the left mainstem bronchus, or in the surgeries which involve the left mainstem bronchus itself, like left side pneumonectomy, left-sided sleeve left-sided sleeve resection, and
Lung transplantation.
surgeries of the left-sided lung transplant. Yes.
Left-sided lung transplantation. Yes, in those cases, because you can't put in the left mainstem bronchus into the left bronchial lumen. But they say that suppose you are still not able to position the right DLT, you put in a left DLT, and at the time of clamping, you pull out the double lumen tube. But yes, these are the few conditions where you will prefer the right-sided double lumen tube. What are the conditions in which you said that the other method of using lung isolation is a bronchial blocker? So, any special condition which I use or is there any advantage of using bronchial blockers over double lumen tube?
Yes, bronchial blockers have several advantages. Firstly, they can be put in the
Can you tell me
cases.
what are bronchial blockers? They differ from double lumen tube?
Sir, can you please repeat the question?
Yeah, what are bronchial blockers and how they differ from a double lumen tube and how they isolate a lung or a lobe? How bronchial blockers are used?
So bronchial blockers are equipment used for the lung isolation technique, which isolate a particular lobe or a particular side lung uh, by uh, uh, by preventing the air entry in that lung, by blocking the ventilation of that particular side lobe or the lung. The bronchial blocker the uh, is different from a double lumen tube as it can be used in the conditions where double lumen tube cannot be used, as in cases of anticipated difficult airway, patients with the distorted the tracheobronchial anatomy, with the, in children as is of tracheostomized patient as well, we can use bronchial blockers.
Yeah, so bronchial blockers thing is that you can put in a bronchial blocker inside the endotracheal tube also, and you can put in a bronchial blocker outside the endotracheal tube. Can you tell me one of the bronchial blocker in which it is put inside the endotracheal tube?
Sir, inside the
In
univent
tubes, they are put inside the endotracheal tube. So you put in an endotracheal tube and then position the bronchial blocker to whichever side or whichever lobe you want to put. And in case of Arndt's blocker and different other types of bronchial blockers, you put in a bronchial blocker along the side of the endotracheal tube. And as you had rightly said that bronchial blockers can be used and they are easily to put in case of a difficult airway, and in case of a difficult airway, and when there is a case which has patient in which there were prior surgery of airway and previous contralateral lung resection, or in case of a tracheostomy, you prefer to use a bronchial blocker because they are easy to put. And another advantage of using bronchial blocker is that you need not have to change the double lumen tube to the single lumen tube prior to extubation, or if you are planning to ventilate a patient post-operatively. You can just remove the bronchial blocker and the person, it will be like tracheal tube on which patient can be ventilated post-operatively. Are there any disadvantages of using any bronchial blockers?
Yes, sir. The disadvantages include there is different to the other side. Also, the deflation of the lung, non-ventilated lung is not possible and is difficult. And also, the insertion of the bronchial blocker takes longer time as compared to double lumen tube. So.
Yeah, so they have deflation time. They have a slow deflation time. To deflate a lung through a bronchial blocker becomes difficult. Deflate a lung through a bronchial blocker becomes difficult, and though they are useful in difficult airway, but they become difficult to manipulate, and there are more chances of dislocation in case of a bronchial blocker. Besides a double lumen tube and a bronchial blocker, is there something else which can be used for lung isolation?
Yes, sir. There are endobronchi will insert in a particular mainstem bronchus and will ventilate that lung only.
Yeah. So you can use endotracheal tubes endobronchially, and you can ventilate that part of a lung. They are more useful in children when you want to use lung isolation. And we can use Fogarty catheter also. They used to use in case of the lung isolation in children. Okay, but now we have got a good number of good quality and good type of bronchial blockers. Regarding double lumen tube, how can we identify that double lumen tube is to be fixed at which level?
So depending on the height of the patient, there is a formula which determines the depth of insertion and fixation. The depth of insertion is equals to 12 plus height in centimeters divided by 10.
And now there are new type of double lumen tubes also which have a camera fixed on the tip of a tracheal lumen. What are the name of that tube?
So it is a Viva side double lumen tube which has a camera.
Any other modification of tube? Any other new type of double lumen tube?
The ECOM tubes are also available, which help in cardiac output monitoring by impedance signals, and a newer tube, silicobronchial tube, is also available, which is
Which
a
have a
silicone.
silicone cuff, a silicone tip. And one thing important, another new thing is that there is a different type of DLT tube which can be used in a tracheostomy patient? Any idea, any name of that tube?
That it is a shorter size tube, which is a
There's a
Nutec.
specific name of a tube, Naruke tube.
No, okay.
Naruke double lumen tube, which can be used in case of a tracheostomy. So now you have inserted the double lumen tube, you have fixed the double lumen tube, you have continued with two lung ventilation. You have to continue with two lung ventilation as much as possible. And which inhalational agent you will use?
So I'll use sevoflurane.
We'll use sevoflurane. And how much which fluid you will use and how much fluid you will use?
So I'll give a Palin salt solution, and according to the patient's maintenance requirement, I'll give the and the deficit. I'll avoid you adding the third space losses, sir. So I'll just give according to the maintenance and the deficit, and to fulfill the deficit.
And you will target how much urine output you will target?
So not more than 0.5 ml per
You will
kg per
target
hour.
not more than 0.5 ml per kg per hour. And your total positive balance should not be more than?
Sir, in the first 24 hours perioperatively, it should not be more than 20 ml per kg.
20 ml per kg. Okay. So now they have done a lateral position to a patient to do the thoracotomy. So what are the concerns in a lateral position when they give a lateral position?
The concerns are firstly, there is a change in the vent, ventilation and perfusion. Lateral position hampers the lung, it changes the lung mechanics. So there is change in ventilation and perfusion. Also, lateral position may be associated with neurovascular injuries. And
what happens to ventilation and perfusion in a lateral position?
So when in lateral position, the ventilation, the perfusion to the dependent lung increases, and ventilation is also better in the lateral dependent lung when the patient is spontaneously breathing.
Can you show me the next slide?
Yes, sir.
So this is the pressure volume loop and this is the compliance. So this is in a patient who is awake and who is not anesthetized. This is the non-dependent lung and this is the dependent lung. So as we can see that in this case, the non-dependent lung is in the less compliant area, vis-a-vis the dependent lung is in the more compliant area. Okay. So whenever we then anesthetize a patient, now the non-dependent lung is in the more compliant area and the dependent lung is in the less compliant area. Okay. Next slide.
Yes, sir.
So coming on to this is the situation when we are using two lung ventilation. We have not yet started with one lung ventilation. So in this, the pulmonary blood flow is 40% to the non-dependent lung and it is 60% to the dependent lung. But when we start with one lung ventilation, there is a concept of hypoxic pulmonary vasoconstriction, which decreases the pulmonary blood flow by 50% to 20%. So that the pulmonary blood flow increases to 80%. So that decreases the shunt fraction. Also, there is more pulmonary blood flow in the dependent lung and more ventilation in the dependent lung. So that decreases the shunt. Because otherwise, when we do the two lung ventilation, there will be more shunting. So when we do when the chest is open and we do a one lung ventilation, it improves the shunt. Okay. So the patient was done in lateral position. You made a proper position. You checked that there is you ensured that there is no nerve injury. You looked out for ventilation perfusion mismatch, and you do bilateral lung ventilation as much as time possible. And now surgeon has asked you to deflate one lung. So what will your plan of anesthesia after you deflate a lung? And one thing more, whenever you change a position from a supine to a lateral position, always make sure that you check the position of the adequate placement of a double lumen tube or a bronchial blocker, because there is the chances of dislodgement when you change a position. So before you give a patient for one lung anesthesia, always make sure that the position is checked again. So yes, now the patient is planned for one lung ventilation. So what will be your ventilation strategies and how will you plan it?
So before switching on to one lung ventilation, I'll provide 100% FiO2 to the patient. As it facilitates in the faster deflation of the non-ventilated lung, and then I'll depending on the dependent and non-dependent side, I will clamp after I'll clamp the lumen and open the port distal to the clamping to deflate the lung, and to fasten the deflation, I can also insert a suction catheter to deflate. And once switching on to one lung ventilation, I'll change my ventilatory parameters as well. I'll reduce my tidal.
So before you start with the plan of anesthesia, when we go for one lung ventilation, is that we have to provide maximum atelectasis to the non-dependent lung so that surgeon can operate comfortably, and minimum atelectasis in the dependent lung. And you have to denitrogenate the lung, as you had rightly said, the denitrogenate the non-dependent lung, and do the recruitment maneuver in the dependent lung. They say that you can use an expiratory pressure 20 centimeter of water for 15 to 20 seconds to recruit the non-dependent immediately after doing the clamping. So then how will you ventilate this patient now?
I'll use low tidal volume. That is around 4 to 6 ml per kg body. Ices are not more than 35 centimeters of water, and the plateau pressures remain below 25 centimeters of water. I'll go for a respiratory rate of around 12 to 14 breaths per minute. And depending on the pre-op status of the lung, I'll add the PEEP of around 5 centimeters of water. Depending on the affected lung, part of the affected lung. Like, for example, in case of a COPD patient, I'll provide lower external PEEP as they have itself. Also, I will ventilation mode.
Yet speak.
Uh, 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 there's no it is the choice of the anesthetist whether to go for a volume control ventilation or a pressure control ventilation. However, I would like to go with pressure control ventilation because it will prevent the excessive rise of pressures during the ventilation.
Yeah, you can go for volume control ventilation as well, but you have to make sure that you should have to be avoid barotrauma, and in case there are better to go for a pressure control ventilation in those cases. And one thing more that when we talk about the end-tidal CO2 and which happens is that CO2 and PaCO2 difference has to be maintained, because normally P increases and end-tidal CO2 decrease. PaCO2 decreases and end-tidal CO2 increases. So the margin increases between the PaCO2 and end-tidal CO2. So that difference has to be maintained, and you have to make sure that you are not hyperventilating or hypoventilating. You have to maintain the normal ventilation with the rate of 4 to 5 or 5 to 6 ml per kg of minute ventilation with the rate of 12 to 14. What is hypoxic pulmonary vasoconstriction?
So hypoxic pulmonary vasoconstriction is a protective mechanism in lungs, which in response to lower partial pressure of oxygen in alveoli, the pulmonary vasculature constricts and diverts the blood flow to the better ventilated alveoli. It is a biphasic responser. The initial phase the early phase starts immediately and lasts up to around 20 minutes. And the slow pace, which starts at around 30 to 40 minutes, will last to about 2 hours.
Very good. And what are the factors which inhibit HPV, and what are the factors which help in HPV?
The factors affecting HPV, which inhibit HPV, is the use of vasodilators like nitroglycerin and inhalational agents when used at a MAC of more than 1, and hypothermia and alkalosis also inhibits HPV.
Yeah, so that's very important to maintain. When we talked about the what all monitoring you will do, so the temperature monitoring becomes very important, because you have to make sure that the patient doesn't go into hypothermia, because hypothermia will inhibit HPV. Okay, and as you rightly said that the respiratory acidosis this is HPV, but that doesn't mean that you have to go for ventilation to cause respiratory acidosis. You have to go for normal ventilation. So now the surgeon says that the surgeon is doing the surgery, and you find that the patient is going into hypoxemia. So how will you treat hypoxemia in one ventilation?
So depending on the whether the hypoxemia is sudden and life-threatening or it is a slow and gradual hypoxemia, I will proceed further. If it is a sudden and life-threatening hypoxemia, I'll switch to two-lung ventilation. However, if it is a slow and gradual hypoxemia,
Yeah, it's a slow and gradual hypoxemia. Yes.
first switch off the FiO2 to 100%, the FiO2 to 100%. Then I will use of optic bronchoscope. I'll check the position of the tube if there is any dislodgement or malpositioning. And after ensuring the correct cardiac output, if there is a sudden change in hemodynamics from the surgeon's end or due to uh, after that, I'll movement to if it still persists, then I'll apply a CPAP to the non-ventilated lung. So, and if still the hypoxemia continues, then we can go for pharmacological modifications, which include the discontinuation of any drugs which may be affecting HPV. And or the use of vasopressors or inotropes. And if still there is no improvement, then we can switch to two-lung ventilation and then again switch to one-lung ventilation as the HPV is
Perfect.
is
So what are the just winding up, what are the intraoperative, what could be the intraoperative complications in a thoracotomy?
the intraoperative complications can be hypoxemia, sudden rising feet pressures due to bronchospasm, massive hemorrhage, sudden hypotension due to surgical manipulation, and arrhythmias or hypothermia can also be there due
So
to
in arrhythmias, you have talked that it will be more or less the most common arrhythmia is atrial fibrillation. And in hypotension, we'll have to make sure that we will not give too much of fluid to treat hypotension. We can start with inotropes to take care of hypotension instead of giving too much of fluids. We have to be little restrictive to fluids, because these patients can have post pneumonectomy pulmonary edema also. So we have to take care in delivering too much of fluid. So fluid management become very important. And hypoxemia, you had told that how to manage the hypoxemia. So now coming on to the surgery is done. So will you like to extubate a patient or send a patient for elective ventilation?
So my plan of extubation will depend on the predictive post-operative FEV1%, as well as on the patient, the intra-op course of the surgery and the patient condition at the end of the surgery. If the predicted post-operative FEV1% is more than 40% and the patient is awake, warm, and comfortable, I'll plan extubation. But if the predicted post-operative FEV1% is uh, uh, more than 30%, and the patient then the patient will be assessed for the other comorbidities and hemodynamic status, and I'll plan the extubation on the OT table accordingly. And if the patient does not meet these criteria, then I'll plan elective post-operative ventilation and will slowly plan the extubation.
So what are the post-operative complications which patient can have?
The patient can have a respiratory failure, pulmonary edema, rupture of the bullae, and there may
Patient
be
can have
cardiac.
post-operative lung injury, post-pneumoctomy, pulmonary edema, respiratory failure. Patient can have ARDS. Patient can have arrhythmias in the post-operative. So in these patients, the important thing that have to provide good in these patients because that will help in improving the recovery of these patients. So what will be the post-operative analgesia and how will you plan your post-operative analgesia in this patient?
So the post-operative analgesia for the thoracotomy patients include the opioids and anti-inflammatory drugs and the
Because
use of
opioids,
local.
you are little worried because in case you are extubating a patient, you are little skeptical about usage of too much of opioids because so whenever you are asked about this, you always say that I'll go for a multimodal analgesia. So
Yes.
when you talk about multimodal analgesia, you will use opioids in a dose, then you can use acetaminophen. You can use up to 4 gram of acetaminophen per day. You can give 1 gram paracetamol every 6 hourly. Then you can use 2 infusions. Which all infusions? You can use ketamine infusion in a dose of 0.1 to 0.15 milligram per kg per hour. You can now, what all nerve blocks you can put in these patients in case you
So
had
we can
not put thoracic epidural?
So we can give a intercostal nerve block, paravertebral nerve blocks, and serratus anterior plane block or a erector spinal plane block.
So once you are planning to go for intercostal nerve block and you plan to give bupivacaine, what is the maximum dose of bupivacaine you can use when you are using intercostal nerve block?
So 1 mg per kg will be the maximum dose.
Yeah. So what is the normal dose of bupivacaine you use for giving nerve blocks?
So the maximum, we do not exceed the toxic dose, which ranges from 2 to 3 milligram per
So
kg.
normally we use 2 mg per kg when we use bupivacaine for giving nerve blocks. So why we restricted ourselves to 1 milligram per kg in case of intercostal nerve block? Because intercostal nerve block, that's a site of a maximum bupivacaine absorption. So there are high chances of patient going into bupivacaine toxicity. So whenever you are using intercostal nerve block, always give bupivacaine in half the concentration and half the dose you give in the other side. Fine. And once last thing that if you are giving thoracic epidural for post-thoracotomy pain relief, then you should know about the PCE also, that how to give patient control analgesia in thoracic epidural. Okay. So very well done, Vaishali. You
Thank
have
you, sir.
answered all the questions and I'm sure you will do definitely well in the exam. This is a case you can get in the exam and this is a scoring case. And the textbook you can read is Miller's anesthesia. It's beautifully given there. And if you have used a double lumen tube and if you answer yourself very well in double lumen tube, You can pick up double lumen tube as a equipment for Viva also on a table Viva, because there are not much questions that will be other than defined questions which can be asked in double lumen tube, but provided you have to be well read on this. So thank you, Vaishali, and all the best to all the students. Okay. So Nitin will be summarizing the thing. Coming on to Nitin.
Nitin, unmute yourself. Nitin, unmute yourself. We cannot hear you.
Unmute them.
Yes.
Hello. Am I audible?
Yes, Nitin, you are audible.
Oh, okay, ma'am. Thank you. Good evening, everyone. My name is Dr. Nitin, and I'll be summarizing this case of one lung ventilation and pneumonectomy. Our moderator is Dr. Akhilesh Gupta. So the objectives of this presentation are understanding the physiology and indication of one lung ventilation, discussing perioperative anesthetic management for pneumonectomy, and reviewing lung isolation techniques. First, the physiology. The goal is to isolate and collapse one lung. Collapse of one lung improves surgical exposure. Here, the primary risk is hypoxemia due to intrapulmonary shunt. Intrapulmonary shunt is perfusion. Blood is perfused through the poorly ventilated area, thus reduced gaseous exchange. Another major concern is VQ mismatch due to perfusion of non-ventilating lung, thus increasing intrapulmonary shunt up to 20 to 30%. So nature has given us this counterpart, hypoxic pulmonary vasoconstriction, which helps mitigate shunt. Now VQ mismatch during one lung ventilation. In two lung ventilation, there is balanced VQ across both lungs. In one lung ventilation, in lateral decubitus position, the dependent lung, that is the lower lung, is ventilated and perfused, while the non-dependent lung, the upper one, is perfused only, leading to intrapulmonary shunt. As the shunt fraction increases, there is decrease in PaO2. Severity depends on shunt flow and HPV effectiveness. Now, hypoxic pulmonary vasoconstriction is a reflex vasoconstriction hypoxic alveoli, which diverts blood to ventilated lung. It reduces shunt by 40 to 50%. As you can see in this diagram, the upper ventilation, the non-dependent lung has pulmonary blood percent, the ventilated or the dependent lung. Thus, it is clinically important to preserve HPV during one lung ventilation. It is blunted by volatile anesthetics if the MAC is more than 1, excessive PEEP, hypocapnia, and vasodilators. Indications for one lung ventilation: thoracic surgeries, lobectomy, pneumonectomy, video-assisted thoracoscopic surgeries, bronchopleural fistula, pulmonary hemorrhage, lung abscess, contamination or massive hemoptysis. Now, this is important for exam point of view, anesthetic management for pneumonectomy in preoperative, interop, and postop period. In pre-op period, there is initial pre-anesthetic checkup where all the patients are assessed for function capacity, spirometry. Post-op analgesia is discussed and patients are advised to discontinue smoking. Patients with PPO-FE1 or DLCO less than 60%, exercise tests are advised. You'll see these in next slides. In cancer patients, consider 4 M's. Mass effect includes obstructive pneumonia, lung abscess, syndrome. Metabolic effects include Lambert-Eaton syndrome, hypercalcemia, hyponatremia, bones. Medications include chemotherapy agents, which are pulmotoxic and renal toxic. In COPD patients, advise ABG physiotherapy and bronchodilators. If there is increased renal risk, measure creatinine and blood urea nitrogen. Here in pre-op assessment, respiratory function is assessed by three-legged stool. Here, each limb of this tool represent assessment of respiratory mechanics, cardiopulmonary reserve, and lung parenchymal function. So this is the diagram of three-legged stool where the first respiratory mechanics is assessed by FEV1, maximum voluntary ventilation, and FVC. So FEV1, that is predictive post-operative FEV1, is the most valid test. If it is more than 40%, there is low respiratory risk. Second is cardiopulmonary reserve, which is assessed by cardiopulmonary exercise testing, in which we assess maximum volume consumption, maximum oxygen consumption. If it is more than 15 ml per kg per minute, patient has low risk. Alternatives to CP, stair climb test, 6-minute walk test. Third is lung parenchymal function, which is assessed by diffusion lung capacity of carbon monoxide, where the PPO of more than 40%, there is low cardio and respiratory risk. Other tests are PaO2 and PaCO2. Key points to remember to how to calculate PPO FEV1. PPO FEV1 equals preoperative FEV1 into 1 minus percentage of functional lung tissue removed divided by 100. For example, if the right lobe is removed, 12 divided by 42 gives to a 29% of value, which we'll insert here, percentage functional lung tissue removed. If PPO FEV1 is less than 30 to 40%, there is elevated respiratory risk. If PPO DLCO less than 30 to 40%, there is increased combined respiratory and cardiac complications. If VO2 max is less than 50 ml per kg per minute or inability to climb stairs, there is high perioperative risk. So before listing the patient, there is final pre-anesthetic checkup in which we review initial assessment and test results. We assess difficulty of lung ventilation. We'll examine chest X-ray and CT scan. We'll assess risk of hypoxemia during one lung ventilation. Now the pre-op orders: advise stop smoking for 4 to 8 weeks, start bronchodilator, chest physiotherapy, pulmonary rehabilitation, continue meds for comorbidities, informed consent, blood type and screen, ABG analysis, antibiotic prophylaxis, and NP orders. Now inter-op consideration. The plan of anesthesia is general anesthesia with controlled ventilation combined with thoracic epidural for analgesia. Maintain 2-lung ventilation as long as possible. Monitoring attached are ECG, pulse oximetry, capnometry, invasive hemodynamics, including IVP, CVP, pulmonary artery catheterization. In ventilation, fiber optic bronchoscopy is kept for placing and reconfirming DLTs. Continuous spirometry is also advised. Transesophageal echocardiography is done to monitor real-time myocardial function and cardiac preload. Now the induction of anesthesia. Anxiolytic can be given and patient can be induced with IV fentanyl, IV induction agent of choice, non-depolarizing neuromuscular blocker, and choice of inhalational agent. And keep the MAC less than 1 because 20% inhibition of HPV will cause 4% increase in shunt. Nitrous oxide is avoided because there is higher incidence of post-thoracotomy atelectasis, increased pulmonary artery pressure, which inhibits. It also inhibits HPV, and it is contraindicated in patients with blebs and bullae. After induction, lung isolation is done. Maintain normothermia during the surgery, adequate hydration, and prevention of bronchospasm. Now the position of patient. Patient is kept in lateral decubitus position with both arms abducted and the dependent parts are padded like dependent eye, dependent ear pinna. Cervical spine should be in line with thoracic spine. Now the techniques of lung isolation. In lung isolation, double lumen tubes are used, left-sided or right-sided. Example, Carlin's tube with hook, Robertshaw tube. Bronchial blockers are used to block the specific same side of lung, like Arndt, Cohen, Fuji, or Easy blocker. Single lumen ET with a built-in bronchial blocker like Univent tube. Single lumen endotracheal tubes are used. Endotracheal tube are also advanced into the bronchus. Fiber optic bronchoscopy is essential for confirmation. So this is a diagram of left-sided DLT, where you can see the proximal or the bronchial cuff is in the bronchus and the tracheal cuff. Both are inflated. If both are inflated, then the right side is ventilated by tracheal cuff and left side inflated by bronchial cuff. So we'll clamp the tracheal side and see only the left side is ventilated due to bronchial cuff. Now, double lumen tube sizing. If the female has a height of less than 160 centimeter, 35 is used. height of more than 160 centimeter, 37 size is used. In male less than 170, 39 is used, and in male more than 170, 41 size is used. In pediatric sizes, bronchial blockers are preferred. Always confirm placement with fiber optic bronchoscopy. Now, this is a diagram of bronchial blockers, where the bronchial blocker is placed on the same lumen of ET tube. It is inserted in the bronchus and inflated. So this side will not be ventilated. Now the comparison, DLT offers superior suction and deflation capabilities. Bronchial blockers preferred in small, difficult or pediatric airways. DLT requires exchange post-op if continued ventilation needed. Bronchial blocker allows continued use of single lumen endotracheal tube. Ventilation strategy, maintain two-lung ventilation as long as possible, tidal volume 5 to 6 ml per kg of ideal body weight, peak pressure less than 35, plateau pressure less than 25, PEEP of 5 to 10 centimeter of water. Aim for normal PaCO2 and respiratory rate of 12 per minute. Controlled mode ventilation is used, and always avoid hyperoxia, titrating FiO2 to maintain oxygen saturation of 94 to 98%. Hypoxic pulmonary vasoconstriction, there is rapid onset over 30 minutes, then peak at 2 hours. It is decreased by NTZ, nitroprusside, and inhalational agents. Aim is try to maintain HPV, avoid factors decreasing hypoxic pulmonary vasoconstriction. Now, the fluid management, total positive fluid balance in first 24 hours should not exceed 20 ml per kg. In average adult patient, it should be less than 3 liter in first 24 hours. No fluid for third space losses. Urine output greater than 0.5 ml per kg per hour is unnecessary. To increase tissue perfusion post-operatively, use invasive monitoring and ionotropes. Intraop complications. Hypoxemia due to intrapulmonary shunt. Sudden hypotension is due to surgical compression of great vessels. Sudden changes in ventilating pressure or volume. Arrhythmias, bronchospasm, massive hemorrhage, hypothermia, and neurovascular injuries. Managing hypoxia. Ensure that delivered FiO2 is 100%. Resume two-lung ventilation, intermittent reinflation of the non-ventilated lung. Check position of double lumen tube or blocker with fiber optic bronchoscopy. Ensure that cardiac output is optimal. Decrease volatile anesthetics to less than 1 Mach. Apply a recruitment maneuver to the ventilated lung. This will transiently make the hypoxia worsen. Try to give a continuous positive airway pressure of 1 to 2 centimeter of water to non-ventilated lung. Partial ventilation techniques of non-ventilated lung include oxygen insufflations of 3 liter per minute to non-ventilated lung, high frequency ventilation, lobar collapse using a bronchial blocker. Pharmacological manipulations eliminating the known vasodilators, mechanical restriction of the blood flow to the non-ventilated lung, veno-venous ECMO, and last resort is bypass. In the post-op consideration, extubation is dependent on predictive post-operative FE1 value. If the FE1 value is more than 40%, extubate in operating room if patient is awake, alert, warm, and comfortable. Second, if the value is 30 to 40%, consider extubation based on exercise tolerance, DLCO, BQ scan, associated diseases. If it is less than 30%, there should be staged weaning from mechanical ventilation. Consider extubation if it is if FEV1 is more than 20% plus thoracic epidural analgesia. Before resuming both lung ventilation, do suction and fully inflate lungs. Post-operative X-ray is advised to rule out pneumothorax, hemothorax, collapse, misplaced drains. Adequate pain relief, ability to cough, moisture air, oxygen therapy, breathing exercise, physiotherapy are essentially appropriate to prevent complications. And judicious fluid therapy should be given, and fluid should be kept below 20 ml per kg. Post-op analgesia can be given by systemic analgesia, including opioids, NSAIDs, ketamine, dexmedetomidine. Local anesthetics or nerve blocks can be given via intercostal nerve blocks, epidural analgesia, paravertebral blocks, erector spiny plane blocks, serratus anterior plane block. Post-op complications incidence is 2 to 4% recovery or protocol in thoracic surgery. It is a multidisciplinary collaboration which includes patient involvement. pre-operative post-op, patient education, counseling, pre-op ventilation strategies are done. Post-op phase effective anesthesia, ambulation, early oral nutrition, early chest removal are done. Now takeaways. One lung ventilation reduces complications. Pneumonectomy carries high risk, requires thorough planning. Thank you.
Thank you, Nitin. You summarized it very well. Thank you,
Thank you, ma'am.
Akhilesh. Thank you, Vaishali. Now we will move on to our next presentation. It will be chaired by Dr. Namita Arora, ma'am. Ma'am is consultant and professor in Department of Anesthesia at Dr. Ramanohar Lohia Hospital. And over to you, ma'am.
Thank you, Jyoti. Am I audible?
Yes, ma'am. You are audible, ma'am.
Yes. Thank you, Jyoti. Good evening, students. This session is related to the equipment viva that you have in your exam. And the session will include two equipments. One is a laryngoscope and a video laryngoscope. So can we have the CV slide of the speaker, please, Jyoti?
Can we have the CV slide of Dr. Sunaina?
Yes, so this session will be taken by Dr. Sunana Gupta. She's additional professor and HOD at AIMS Jammu. She has several achievements, which include she's Associate Dean of Academics, more than 30 publications in different journals. She's a AHA certified BLS, ACLS instructor, and a faculty in various conferences. She has special interest in difficult airway, urological anesthesia, palliative care, quality and safety in healthcare. Welcome, Dr. Sunana Gupta. Over to you. Dr. Sunana Gupta, are you there?
Welcome, dear student, to this anesthesia postgraduate pre-examination course. I am Dr. Sunana Gupta. I am additional professor in HOD, Department of Anesthesiology, AIMS Jammu. And I'm thankful to the organizer for giving me this opportunity to speak on this very important topic, that is laryngoscopes and video laryngoscopes. A little bit about history. Airway management is one of the core skills of anesthetists, and various techniques of airway management have developed over many years. Initially, the only view of the glottis that was obtained was indirect view, but in the 19th century, a direct view of the glottis was obtained via various direct laryngoscopes. Now, early 21st century, like nowadays, we have again shifted to the indirect laryngoscope, that is the video laryngoscopes. Larynx was first visualized with Manuel Gracia, who used an indirect mirror to visualize the chord movement during singing in 1854. Many mirrors-based instruments were invented after that to visualize the larynx, but it was in 1943 that Sir Robert McIntosh introduced his chord plate, that is the McIntosh plate, and still it is being used. A little bit about direct laryngoscopy and indirect laryngoscopy. Direct laryngoscopy involves inserting a laryngoscope into the mouth to directly visualize the larynx. Indirect laryngoscopy, it uses a mirror or a flexible endoscope to visualize the larynx through reflected light or video image. So it involves the video laryngoscope and flexible fiber optic laryngoscope. It is less invasive than direct laryngoscopy. Laryngoscope is a device used to view the larynx and adjacent structures, either by displacing the soft tissue away from the line of vision or by optical aids. So most frequently used for endotracheal intubation. So can be used for insertion of nasogastric tube, oral suctioning, throat packing, or removal of oral foreign body. Parts of laryngoscope. Laryngoscope has a handle and a blade. You can see this is a handle and this is a blade. Handle is held in hand during use and it provides the power for light bulb. It either has batteries or a halogen bulb to provide the light source, and it accepts the blade that has a light bulb to make metallic contact, which complete the circle when the handle or blade are in working position. So available in several sizes and have a rough surface for a good grip. So these are the type of laryngoscope handles, large, medium, or small. And as you can see, this is rough surface is there so that we can have a good grip. This is a Pytel Syracuse handle. This is the blade. Its blade can be locked in 4 positions, so making different angles with the handle. So you can lock it in whatever position you want the intubation to do the intubation or laryngoscopy. This is the blade. So blade has a different parts of the blade. So blade has a tip, it has a base, it has a flange, it has a web, and it has a tongue and a source of light, that is a bun. So base, it attaches to the handle. So this is base, it attaches to the handle, and there is a slot for engaging the hinge pin of the handle. So handle has a hinge pin. So there is a slot here which engages this slot pin, and this circuit gets completed. Now tongue means it is the main shaft. As you can see, this is a tongue. It is used to swipe the tongue aside. So and depresses lower jaw for visualization of the larynx. And this is flange. It projects off the side. So upper this side projection is the flange, and it is connected to the tongue by web. So what is the importance of this flange? It guides the instrumentation and it deflects tissue from the line of vision. So it provides the space for putting the tube or any other instrumentation. And then there is a tip. You can see the tip contacts either the epiglottis or the vallecula and directly or indirectly elevates the epiglottis. Now tip is thick and transversely beaded to minimize mucosal damage. Direct laryngoscope and indirect laryngoscopes. Direct laryngoscope can have straight plate, for example, Miller, Goodall, Wisconsin, or with a curved plate, or special purpose like polio or Oxford. So curved blade is a Macintosh blade. Indirect laryngoscope, there is some mechanism to view the larynx indirectly. That is, it could either be prism type like Proview or Bell scope, optical like Bullard's or Ustroscope, or optical stellar type or video laryngoscopes. So you students, you all are familiar with this laryngoscope. It is a Macintosh laryngoscope and it has a curved blade and different sizes they are available. Most popular, the tongue has gentle curve that extends to the tip in cross section. Tongue, web, and flange. They forms the reverse Z. Sizes available are 1, 2, 3, and 4. Macintosh plate, what are the benefits of this plate is the tip of the plate is kept in vallecula. So there is indirect lifting of epiglottis and it is versatile and effective for most adult intubation. So we have a better familiarity with this type of blade, and curved plate offers better mechanical leverage and potentially easier tube insertion. Indirect lifting can pressure the tongue and require more tissue displacement. So it is less effective in infant or obese patients. May sometimes need external laryngeal manipulation, and visualization may be poor in anterior or high glottic anatomy. These are some of the modification of Macintosh blade. This is a polio blade used for difficult intubation. So blade is offset from the handle at an obtuse angle. This is oxyport Macintosh blade with oxygen. It is with oxygen can be added to this blade. This is the McCoy plate, has a lever, and the tip can be, the direction of the tip changes along when you press the lever. And so less lifting force is required, useful again in difficult intubation. Miller plate, the tongue is straight with slight upward curve, and the flange, web, and tongue, they form C with the top flattened. Pillar's plate, the tip, it is just at that position posterior to epiglottis. So you can lift the epiglottis along with this tip. So available in sizes 000, 1, 2, 3, 4. So this is the Miller plate, straight plate. And directly lifts the epiglottis is a gold standard for neonates and infants less than 3 years due to large floppy epiglottis. So if we use the Macintosh blade in like neonates and infants, so this epiglottis is long, so it will obstruct the view. So what we can do with along with the Miller blade, we just lift that epiglottis along with. So less tongue displacement, reduced tissue manipulation. So mostly can be used in children and can be used in adults also. But again, there is a learning curve for Miller blade also. This is the occiput Miller blade, has a built-in tube that allows delivery of oxygen during intubation. This is a Wisconsin blade, has tongue has no curve. So these are different types of blades. Tull Miller blade, it has suction port attached. And now come the indirect laryngoscopes. These are the prism type laryngoscope. So prism refract light to bring the laryngeal view in the line of vision. So this is a cycle laryngoscope, Huffman's prism, telescope. These all are type of prism type laryngoscope. Then rigid indirect fiber optic laryngoscope. So bullet laryngoscope is an example of this. So it has an anatomical curved blade. As you can see, this is an anatomical curved blade. There are 3 channels. 2 fiber optic channels are there for light and image bundle. And there is one working channel through which oxygen or any instrumentation can be done. Now, if we come to direct laryngoscopy procedure, the procedure involves both key steps: positioning and preparation, identification of epiglottis, laryngeal exposure, and delivery of the tube. So positioning, as you all know, during direct laryngoscopy, there is sniffing position is there. So this is extension at the atlant of occipital joint and flexion of cervical spine, cervical joint. So how it is achieved? By placing a pillow under the shoulder and the head. So at least 7 to 10 centimeter of elevation. So how it helps, as you see in this neutral position, oral, pharyngeal, laryngeal axis, they are not aligned. So putting the patient in the sniffing position, we have aligned these axes. So direct line of sight is easy. When we put a direct laryngoscope, it is easy for us to visualize the blood. This is a health position. This is used for morbidly obese or pregnant patients. So in these patients, what we do, external artery meters should be in line with the sternal notch. So how it is achieved? By placing these pillows under the shoulder and the head. So this position also helps in improving pre-oxygenation and decreases aspiration risk. Now, direct laryngoscopy, the height of the operator should be at the level of patient airway. The patient should not be above the xiphoid process of the anesthesiologist. So this is how the height is optimized. The laryngoscope handle should be gripped as low down as possible. An elbow should be kept close to the body. Open the mouth as wide as possible using a scissor technique. Use a first and third digit for maximum mechanical advantage. Now, this is important that you need to hold the laryngoscope in left hand and insert the laryngoscope into the mouth from the right side and sweeping the tongue to the left. So then again insert the blade with the laryngoscope handle pointing to the right. Once in the mouth, the laryngoscope blade can be rotated to the middle. Then move progressively down the tongue with the laryngoscope blade. So along the tongue with the laryngoscoping blade, then identify epiglottis. Then the epiglottis are identified, the blade tip is placed in the pellicula, that is just above the epiglottis. And the angle of lifting, it changes to 40 degrees from the horizontal, and you are able to view this structure, this glottic field, that is epiglottis, vocal cords. So this view you should be able to visualize by direct laryngoscopy. Now, tracheal tube should always be inserted from below the line of sight, because if your tube is in the line of sight, you will not be able to see anything. So it should be below the line of sight, and you use your right hand for inserting the tube. Always keep the tube below the line of vision and watch it travel upward to the larynx. Ensure that the tip passes anterior to the interarachnoid notch. So this is how, like, operator back should be straight and head far enough away to have binocular vision. Arm straight, not bent, head elevated to 10 centimeter to flex neck. So this is like the position in which the laryngoscopy should be done. Okay, that was regarding the direct laryngoscope. Now comes the video laryngoscope. Nowadays it is the era of video laryngoscopes. So video laryngoscopy is a relatively recent development, and a video laryngoscope contains miniature video cameras, enabling the operator to visualize the glottis indirectly. So most of the difficult airway guidelines, they have laid stress on the role of video laryngoscope in the management of both anticipated and unanticipated airway. So ASA 202 practice guidelines, they have found the intubation success rate for video laryngoscope ranges from
Tech team at the back end, please mute yourself.
Video laryngoscopes are very helpful in anticipated as well as unanticipated difficult airways. So if we see a video laryngoscope, they have a handle and a blade. Handle provides a grip for the user and may contain the battery compartment and on-off switch. Blade, the part that is inserted into the patient's mouth to visualize the vocal cord and glottis. It can be disposable or reusable, and like the shape of blades, it could be curved or angled. Then there is a light source, LED light source, display screen. Now the screens may vary, they can be small because there are different type of video laryngoscope available, and the screens, they can vary. But the screen provides a real-time view of the airway, allowing the user to guide the endotracheal tube into the trachea. A miniature camera is integrated in the blade, capturing images or videos of the airways. So non-channeled and channel video laryngoscope. Non-channel, we have GlideScope, McGrath, Storrs, Kingvision. Channeled, we have AirTrack, Pentax, and Kingvision. CMAC video laryngoscope, most commonly used. So a unique feature is that its ability to provide the two options of direct and video laryngoscope. So the blade is curved just like Macintosh blade, and if we can either use it as a direct laryngoscope or an indirect laryngoscope. So it has a monitor attached with it. All type Macintosh, Miller, and hyperanculated D blade are available, and hyperanculated D blade is especially used in difficult airway. So, but the thing is, it has an unchanneled blade. So mostly the stillet is required when you are intubating with this CMAC video laryngoscope. It provides a very clear image without fogging and records still images and videos on SD memory card.
ये म्यूट मैंने
So then this is
जैसे हुई
Kingvision
वैसे
has
म्यूट करा
channeled and
मैंने
unchanneled blades.
म्यूट हुआ था
Unchanneled blades are slim, faster glottic view, and but disadvantage require pre-shaped stiller. Channel plate, they potentially faster overall intubation. Disadvantage is that bulkier designs are there. This is Torrent video laryngoscope, AirTrack channeled. Now the advantages are of the video laryngoscope is because we need not to align all the axes. So we need not to achieve line of sight. So improved glottic visualization, especially in scenarios with limited mouth opening or neck mobility. Higher endotracheal intubation success. So there are many studies, they have found the higher endotracheal first pass success rate. And we can allow others can also view or see what we are doing. So effective tool for teaching, less cervical manipulation. And there are many case reports and studies regarding awake intubation with this video laryngoscope. And we can record the laryngoscopy. Disadvantage, difficulty in passing ETT despite improved glottic visualization sometimes, because good glottic view does not mean that we should be able to put the tube. So it requires a good hand-eye coordination, and learning curve is different for different laryngoscopes. So there is a variable learning curve. A person who is doing good, who is best in direct laryngoscopy, that doesn't mean he will be good in video laryngoscopy also, because this skill we have to achieve and it has a learning curve. And there is two-dimensional view with loss of depth perception. Sometimes the view can be obscured by fogging and it is expensive. So video laryngoscope is inserted in the midline, sniffing position not required. So look in the mouth here to insert the video laryngoscope, look at the screen to visualize the epiglottis, look in the mouth again as you insert the endotracheal tube, and look at the screen as you pass the tube through the larynx. Advance the tube slowly until the tip comes into view. Adjust your insertion angle direction as needed for insertion of tube into the larynx. And there might requirement of stillet might be required for negotiating the tube into the larynx. So there is video versus direct laryngoscopy for intubation. So many reviews and many articles are there. They have confirmed that video laryngoscopy has a higher success rate for first pass intubation than direct laryngoscopy. Thank you.
Thank you, Dr. Sunana. That was really an exhaustive and a wonderful lecture. And I would, in fact, urge the students to not get worried seeing so many types of laryngoscopes. And it's important that they understand the broad categories of laryngoscopes that are available and the principles on which they are working, and also their specific indications where you would pick up a particular one for difficult airway cases. Thank you again, Dr. Sunana. Are there, Dr. Jyoti, are there any questions in the chat box?
No, ma'am, not yet, ma'am.
Okay, okay. So can we go on to the next speaker?
Yes, ma'am.
Jyoti, I request you, please, you request all the systems that are logged in to be muted. There is too much noise at the time of the lecture.
Can we have the CV slide of next speaker, Dr. Michelle?
It's my pleasure to now invite Dr. Michelle Gulabani. She was our student here and is now Associate Professor Anesthesiology and Critical Care at UCMS GTB Hospital. Her achievements include 34 publications in index journals. She's also involved in 4 book chapters. She's a ATLS, BLS, ACLS instructor. Her areas of interest include difficult airway, obstetric anesthesia, and trauma. She would be talking about fiber optic. Can you hear me?
Yes, ma'am. Yes, ma'am.
She will be talking about fiber optic bronchoscope. Over to you, Dr. Michelle.
Thank you so much, ma'am. Thank you, ma'am.
Warm greetings to all faculties, students, and my dear friends.
The
Today I'm
wrong
going to
video
talk
has been
about pulse
displayed,
oximetry,
ma'am.
which is a simple yet a vital device that we use in our day-to-day practice. It is also called as the fifth vital sign. It is a
Can we have
non-invasive
the
method
video
of
of Dr.
monitoring
Michelle?
hemoglobin saturation. In 1986,
The technician
ASA
team,
standards
the
for
technical team,
Jyoti, what's happening? Please check. It's a different
take the
lecture they
video,
have
please.
put.
Yes.
Shall I share my screen, ma'am? I have the presentation. Shall I share it if there are issues in the technical side?
Yes, Michelle, you start sharing your
Minute, ma'am.
presentation. Meanwhile, we will look at the
But
matter.
somebody else is sharing, so I can't start. One participant can only share at a time, it's saying.
Okay, I will see into the matter.
You can share now, ma'am, if you want.
Me, okay. Okay, just a second. I sent it. So yeah, I'm sharing. Is my screen visible?
Yes.
Fiber optic bronchoscopes. The
Yes.
first fiber optic bronchoscope was given on the basis of specifications provided by Shikida in the year 1966. Was designed started being used for fiber optic bronchoscopy. And this has been one of the most revolutionary interventions for difficult airway management. It consists of the following parts: the handle, which houses the eyepiece with the diopter ring, and the control lever, which controls the movement of the tip. So when the lever is pushed up, the tip moves down and vice versa. Therefore, the movement happens in one plane. The side-to-side movement is accomplished by the operator's wrist movement of the handle. Now, also we have the suction port here and the working channel. And in between, you have the venting connector, which houses the ETO sterilization cap and the leakage tester. This cap is kept on during the ETO sterilization process so that it vents the pressures in the interior and equalizes with the pressures of the exterior. Otherwise, when it's in use, the bronchoscope, or during disinfectant solution when it is placed, the cap is left open. Then you have the insertion cord, which is the flexible portion inserted over which the endotracheal tube is passed. It has both light and image transmission bundles.
Dr. Michelle, it is not audible. The video is not audible at present.
This is the video which I had mailed also. Dr. Jyoti?
Dr. Michelle, I can see your screen.
Okay.
Yes.
Shall I share it? The video which I had mailed, that's not working. So I'll try it again by this.
Okay.
Is it fine now?
Yes, it is fine. It was
Bronchoscope.
going fine only,
The
but in
first fiber optic
between the
bronchoscope
voice
was
stopped
given
coming.
on the basis of specifications provided by Shikida in
Should
the
I-
year
Should I forward
1966.
it or let
And
it
this
be?
was designed
Let it be.
in which in 1972,
Now it is going
both
fine.
oral and nasal routes
Okay.
started being used for fiber optic bronchoscopy. And this has been one of the most revolutionary interventions for difficult airway
Michelle, again, the voice is not coming. Now it stopped coming. If it is possible, can you go live?
I think, Dr. Michelle, I think you go live because there's some problem with the recording. Only the initial part has the voice. After that, it's not coming.
Yes, ma'am. I'll share
If
it,
you,
the live presentation.
yeah, if you have it in your mail, you can
Yes, ma'am.
open it in your mail and then
Yes, sure, ma'am.
start live.
Yeah, I'll start live. Am I audible, ma'am? Shall I start?
Yes, yes, please do.
Yes, ma'am.
Please
Thank
do.
you, ma'am.
Thank you.
This is the presentation of fiber optic bronchoscopy. The first fiber optic bronchoscope was given on the specifications based by Ikeda in the year 1966, and Murphy in the year 1967 used it for the first time in patients with rheumatoid arthritis for nasotracheal intubations. It was only in the year 1972 that fiber optic bronchoscopes were used both for oral and nasal intubation by Stills and their colleagues. So it has various parts, the equipment. The first is the handle. Then we have the insertion cord, then the universal cord and a light source. So the handle further has very important parts like the eyepiece with the diopter ring, as we can see in this. And then you have a port for the suction button and the working channel. Also, you have the control lever here, which controls the movement of the tip. You can see here the tip is moving upward. That's because the lever is pressed down. So as the lever is pressed down, the tip moves up and vice versa. However, this movement is only in one plane. Now, if you have to move the handle, it is by the operator's wrist. So that movement happens only by the operator's wrist. Then you have a venting connector that is between the suction button and the working channel. So this is otherwise kept open, but when ETO sterilization happens to equalize the pressures in the interior and exterior of the bronchoscope, this cap is attached. Next, we move on to the insertion cord. Now, this is the flexible portion inserted into the patient over which the endotracheal tube is passed. It has both light and image transmission bundles, the suction tip, and the suction channel. Here we see the various fiber optic bundles and the working channel in the center. So the light is transmitted through one or two of the light transmission bundles at the tip of the FOB. Here we see the cut section of the tip. The largest opening here is of the working channel. There are two angulation wires above and below and a fiber optic light bundle in the middle. So the outer diameter is the most critical part of the insertion cord. That determines the smallest size of the endotracheal tube that can be used. So the internal diameter of the tube should be at least 1 mm wider than the outer diameter of the insertion cord. Next, you have the universal cord. This contains the light transmission fiber bundles, and this is plugged on to the light source. We see this is the universal cord. So this gets plugged into the light source before putting the fiber optic bronchoscope in use. Then you have the light source, which can be a halogen or incandescent light, and these days also an LED. The various specifications of the bronchoscope are based on its diameter, length of the insertion cord, diameter of the working channel, degree of bending of the tip. So the standard sizes in adults vary from 7 to 9 millimeters outer diameter and the length of 40 to 50 centimeters. However, the working channels range from 2 to 3.2 millimeters. There are also smaller sizes available from 6 to 6.5 mm diameter with 30 to 35 centimeters in length. For pediatric bronchoscopes, for very small infants, you have sizes from 2.2 to 2.8 millimeters. The 2.21 does not have a working channel. For older infants and children, the sizes range from 3.2 to 3.5 and 4.5 to 4.9 millimeters internal diameter. Also, the fiber optic pediatric version is used to confirm the position of the DLT, as we have discussed in the previous case presentation. So the estimated size of the endotracheal tube is based on the formula of H upon 4 plus 4, and the maximum scope size is endotracheal tube size minus 1. The general indications can range from diagnostic to therapeutic ones. So these indications pertain not only to anesthesiologists, but also to pulmonologists and critical care physicians. So it can be used to diagnose the etiology of pneumonia in immunocompromised patients and in immunocompetent patients with recurrent or unresolving disease. Also, patients with persistent atelectasis, persistent unexplained cough, hemoptysis, and lung cancer staging. Therapeutic ones for aspiration of retained secretions, bronchopulmonary lavage, management of bronchopleural fistulas, removal of foreign bodies, mucus plugging, and atelectasis. In the OR, we are all well versed with the indications, a known difficult intubation or a history of previous awake fiber optic intubation, an anticipated difficult intubation, or even after a failed intubation in an unanticipated difficult airway. Unstable cervical spine, abnormal anatomy of the airway for placement and evaluation of the position of DLT and bronchial blockers, also to evaluate, locate, and remove secretions. In the ICU, the indications range from visualizing and checking the patency of the trachea and main bronchi, managing hemoptysis as a therapeutic approach for airway obstruction or alveolar hemorrhage. In community-acquired pneumonia, fiber optic bronchoscopy with bronchoalveolar lavage is considered when standard antibiotic therapy fails or an alternate diagnosis is suspected, not as a routine indication. Contraindication, the most important absolute contraindication is patient refusal or an inability for the patient to cooperate. The relative contraindications being lack of trained personnel, risk of impending airway obstruction, coagulopathy or bleeding, allergy to the local anesthetic itself, and base of a skull fracture in which the nasal route of FOB is contraindicated. So preparation is very important before you go ahead with the procedure. The fiber optic bronchoscope is placed on a cart necessary for easy transport, having stable shelves. It has various components, and all of this can be also integrated into the difficult airway cart. The choice of tube is another important factor. Spiral embedded tubes are likely to pass than a tube with a preformed curve. Also, warming of the tube may facilitate its passage over the bronchoscope. Now, these are very expensive equipments and delicate too. Hence, they should be handled with care. Forceful bending is avoided, and minor breaks can also disturb the fiber optic bundle. The light source should be checked before use. The focusing rings should be adjusted by viewing small print at a distance of 2 to 3 centimeters. The insertion portion can be coated with a lubricating gel, but it should not contact the lens. So tubing for suction and oxygen insufflation should be checked. Ensure optimal positioning prior to performing the laryngoscopy. Also, the proximal control section is held in one hand with the index finger on the suction port and the thumb on the lever that controls the angulation. So all this should be checked prior to performing the procedure. Various troubleshooting points are there. Firstly, the fiber optic cables are not strong enough to lift or dislodge the tissues. It is important to have an air space at the end of the tip. Secondly, visualization at times becomes impossible unless some means is used to expand the pharynx. Therefore, a jaw thrust maneuver or elevating the larynx can help to visualize the entire route. Also, sometimes what happens, there is disorientation while you're doing the bronchoscopy. There's no need to panic at that time. You just withdraw the tip, examine the area with a gentle up and down deflection, rotate the scope as a unit, and then advance it slightly. Then you can have desaturation during the procedure, which can be dealt by oxygen insufflation or by jet ventilation through the working channel. Then what happens at times, the view becomes foggy or hazy. At that time, you can irrigate and suction. That will usually resolve the problem. However, if the secretions are adherent, it may require that instrument to be withdrawn and the tip to be cleaned with a moist gauze. Resistance is often encountered when you're passing the tracheal tube over the fibroscope. So what you do in that case, rotate the tracheal tube at 90 degrees or counterclockwise. Otherwise, you can use maneuvers like jaw thrust and external pressure on the larynx. Now, a rare problem what happens is that the fibroscope tip protrudes through the Murphy's eye of the endotracheal tube. So in that case, unfortunately, sometimes the fibroscope and the tracheal tube may need to be withdrawn as a unit. Some points to ponder upon to avoid these complications. The tracheal tube should be threaded onto the fibroscope before endoscopy, or the fibroscope advance through the tube under direct vision, taking care that the fibroscope passes through the distal opening of the tube, avoiding the problem of it passing through the Murphy's eye. Then the endoscope tip should always be in neutral position as the tracheal tube is advanced and the fibroscope is withdrawn. Then this the tip of the standard tube is always on the right side. Therefore, it happens that it will impact on the right side of the vocal cords, preventing it from entering the larynx. So what you can do, turn the tube 90 degrees, which will often align the tip in between the space of the vocal cords. So various intubation techniques have been described by fiber optic bronchoscopy. The first is to thread the ETT or the DLT with the lumen lubricated over the cord until it abuts the handle. Advance the flexible tip until it reaches the trachea or the bronchus in the case of a DLT, and then thread the tube over the endoscope. The second technique is first to advance the ETT till the level of the pharynx. So that acts as a guide to bring the endoscope tip close to the laryngeal entrance. Once the fibroscope is passed through the tube and then into the trachea, and then it is threaded over it. The third technique, the fibroscope is used to place a guide wire or stellate. This is especially used in pediatric patients. So the fibroscope is withdrawn and the tracheal tube is passed over the guide wire into the trachea. After saying this, let's see the images through the commonly used approaches, the oral and the nasal route. The oral route requires an intubating airway like the ovosapien airway. You can see this is the ovosapien airway. As the fiber optic bronchoscope advances, first you see the posterior wall of the pharynx, then the base of the tongue. Then if you give a jaw thrust, what do you see? The larynx comes into view. The nasal route, these are the images of the person standing in front. Either you go below the inferior turbinate or you go in the space between the middle and the inferior turbinate. So you follow this black horizontal path. What you see is the posterior nasal wall. Advance a little further, you see the uvula, and then follow this path, apply a jaw thrust. The larynx comes into view. But what do you see? It's slightly anterior. Can you pass your tube through this? No. What you can do is you flex the scope. This will help you to reach the cords. However, once you're at the cords, you have to retroflex the scope to enter into the trachea to avoid hitting at the anterior tracheal wall. So advantages of either routes. The oral route has advantage of a larger ETT can be inserted. It is a shorter route and there's no risk of epistaxis. However, it is a less direct pathway. It is easier to stray from the midline and topicalization must be optimal. The nasal route allows surgical access to the mouth, possible if there is limited mouth opening, and it is a direct pathway to the vocal cords. However, the disadvantage of endotracheal size limitation, damage to the turbinates and epistaxis, and it is not suitable if nasal pathology is present. Complications can range from mechanical to systemic. Mechanical means trauma to the airway structures, bronchospasm, laryngospasm, atelectasis, hemorrhage and infection. Systemic could be procedure-related, a vasovagal syncope, nausea, vomiting, aspiration. Medication-related being sedation. Comorbid illness patients can have arrhythmias at this point of time. Advantages, very clear. It is a reliable technique, complete visualization of the airway before intubation, avoids esophageal and endobronchial intubation, and it can be used both orally and nasally when the access to the airway is difficult or limited. Very useful in patients with a high risk of dental damage. As we can see in this image, the mouth opening is limited. There are dental wires placed, so a nasal FOB is ideal. Also in cases which patients cannot lie supine, like a huge thyroid mask sitting on the neck in this way. So a sitting position also can be used for doing a fiber optic bronchoscopy in this. It is well tolerated in patients who are awake with less pressure response in the terms of less tachycardia and hypertension. The disadvantages are it is expensive and fragile, difficult to use and clean, requires more time. The vision at times can get obscured with blood secretions or antacids. And in patients with laryngeal trauma, there may be difficulty in advancing the tracheal tube over the fibroscope. So let's come on to the cleaning and disinfection guidelines. These have been given by the Thoracic Society of Chest Physicians. So they say that these equipment require high level of disinfection. And high level of disinfection means that in which all the viable microbes except some spores are removed. So they should be washed immediately and the working channel flushed with clear water to remove secretions. Cleaning can be done by non-enzymatic or multi-enzymatic detergents. Also, commercially available bronchoscopes are available. For disinfection, it is important first to perform a leak test after every procedure, as leaks can cause transmission of infection, resulting in outbreaks. Also, bronchoscope disinfection can be carried out either manually or using automated endoscope reprocessors. The automated endoscope processors save from the toxic fumes and vapors of the disinfectants, but they are costly and they require a reverse osmosis water supply. Commonly used alkylating agents are glutaraldehyde or glutaraldehyde with isopropyl alcohol, which requires a contact time of 20 minutes. Peracetic acid is recommended with a contact time of 5 minutes. Disinfection also involves use of a 70% alcohol purge to reduce the contamination rate and a final rinse with RO water or sterile water. But lastly, must remember the manufacturer's recommendations are important to follow and they should always be observed. Now, sterilization at times is required if the patient has a transmissible disease like tuberculosis or if the next patient has immune deficiencies. So complete sterilization can be accomplished with ETO, which may take 3 to 5 hours, involves exposing the bronchoscope to the ETO under controlled conditions of time, temperature, humidity. As the bronchoscopes are heat-sensitive equipments, ETO is recommended. However, a crucial step of ETO exposure is aeration, which removes the residual gas, and this can take more than 12 hours. Newer methods have come up like hydrogen peroxide gas plasma, and these are being explored as possible alternatives to ETO. After cleaning, disinfection, and sterilization, the FOB should be hung vertically without any valves. Also, ventilated drying cabinets have been suggested for storing. This may reduce the contamination rates. So these are my references. Thank you and all the best for your exams.
Thank you, Dr. Michelle. It was very, very enlightening, and I'm sure students found it very useful.
Thank you so much,
it's
ma'am.
an equipment which I think every student should know, because with time we are getting so many difficult airways, and it is something which should be definitely in their armamentarium, in their skills.
Yes, ma'am.
Students should remember disinfection, sterilization. It's also very important. Whenever you go for an equipment viva, this is something which will be asked from you. So that section you should go through, whether it is circuits or tubes or fiber optic bronchoscopes, go through the sterilization process. Dr. Jyoti, any questions? The chat box.
Ma'am, no questions. Thank you,
Okay,
ma'am.
so can we close this session?
Yes, ma'am. Thank you so
Okay,
much,
over
ma'am.
to you, Dr.
Doctor.
Jyoti.
Thank you, ma'am. Thank you, Dr.
Ma'am. Thank you, Dr. Jyoti.
Now we will move on to our next session, which will be chaired by Dr. Surinder Arora sir and Dr. Vinodwala ma'am. Due to some personal reasons, Dr. Vinodwala ma'am will not be able to join us. Ma'am is professor at ESIC Medical College and Hospital, Faridabad, and she was ex-professor at ABVIMS at Dr. RML Hospital. Ma'am has various achievements. An area of interest is difficult airway and obstetric anesthesia. And the other chairperson for the session is Dr. Surinder Arora, sir. Sir is assistant professor and head of onco anesthesia at Delhi State Cancer Institute, and sir has 22 publications in national and international journals, and sir has various chapters in various books, and sir received the Appreciation Award for teaching and training in anesthesia by ISA Delhi. Now, sir, over to you, sir. Surinder sir, have you joined the meeting?
Yes, I am here. Am I audible?
Yes, sir, you are audible. Over to you,
Thank
sir.
you so much, thank you so much, madam.
Thank you, sir.
And first of all, I extend my gratitude to Dr. Nirja Banerjee and Team Appec for having given me the opportunity. And this is a wonderful, going to be a wonderful academic feast for the students. May I have the slide of the first speaker, please? Okay, in this session, we have with us Dr. Jyoti Sharma, who is an associate professor at All India Institute of Medical Sciences, Bathinda, and she has numerous achievements, including I've been co-chairperson of workshop coordinator for RSS CPCon 25. She has been the instructor of IRCF certified BCLS, ACLS, FCCS, SCM USA award. She has been given many congratulations and she has various publications. And she will be speaking on crystalloids and colloids, I think. So, which is a very important topic and it should be helpful to the students. Over to you, Dr. Jyoti, please.
Good evening, sir. Good evening, everyone. So, good evening, everyone. Myself, Dr. Jyoti Sharma, Associate Professor at All India Institute of Medical Sciences, Bathinda. I'll discuss a little bit about crystalloids and colloids. So, we'll learn about fluid physiology in a brief. Then what is osmotic and oncotic forces? What are the types of crystalloids, the types of colloids, a few clinical scenarios, and a little bit about the guidelines. So, let's come to the physiology of the body water compartments. So, the total body water is around 55 to 60% of the body weight. That is approximately around 45 liters in a 70 kg adult. So, from this, around 2/3 of the total body water is in the intracellular compartment. That is around 30 liters. And 1/3 of the total body water is in extracellular fluid. That is around 15 liters. The extracellular fluid is a combination of the interstitial fluid and the intravascular fluid. That is the plasma. So the interstitial fluid is around 12 liters and the plasma volume is around 3 liters. So what are the barriers in the transport of the fluid? That is the cell membrane, which is selectively permeable, the capillary membrane, which are permeable to small molecules and impermeable to plasma proteins. So this diagram also shows that the 2/3 of the total body water is the intracellular fluid and 1/3 of the total body water is the extracellular fluid. That is a combination of interstitial fluid and plasma. Now there is a concept of osmosis, all of you must be knowing. That is the passive movement of the solvent, that is usually water, through a selectively permeable membrane from an area of higher solvent concentration to an area of lower solvent concentration, aiming to balance the solute concentrations. So what are osmoles? Osmole is a unit measuring concentration of osmotically active particles, and osmolality is the osmotically active solute per kilogram of solvent, and osmolarity is osmotically active solute per liter of the solution. What is plasma osmolarity? It is approximately 290 milliosmoles per kilogram. Now, a little bit about the osmotic pressure. Osmotic pressure. The osmotic pressure is the minimum pressure that is needed to prevent the flow of solvent molecules through a semi-permeable membrane. So the solvent flows across membrane to equalize the concentration. What is tonicity? Tonicity refers to the ability of a solution to cause a cell to gain or lose weight. So it is determined by a relative concentration of the solutes in the solution separated by a semi-permeable membrane like a cell membrane. Based on the tonicity, the solutions can be divided into isotonic, hypertonic or hypotonic. Now, what is an isotonic solution? There is a solution which has the same solute concentration as the other solution. For example, a cell. So when there is the concentration is equal on both sides, there is no net movement and the cell's volume remains stable. What happens when we give an hypotonic solution? In a hypotonic solution, there is a lower solute concentration than the another solution. For example, the cell. So while giving a hypotonic solution, the water moves inside the cell and the cell swells. What happens in hypertonic solution? In a hypertonic solution, there is a higher solute concentration outside and higher water concentration inside. So the water moves out and the cells shrink. Now let's see an example why we are talking about the fluids, which fluid to give and which not to give. For consider a vessel where the blood is flowing with a normal osmolarity, and from outside you give a pure water. What will happen? What is in pure water? pure water has zero osmolarity. So what will happen while adding pure water to the plasma? The total extracellular osmolarity will become low. It will get diluted. And considering the red cells. So what the water will flow from the diluted fluid, that is the plasma, and will enter into the cells, and the cells will keep on swelling up. So they will swell to a level that it will lead to hemolysis. Now coming on to the types of fluids, that is the crystalloids and the colloids. That is the main topic of today. So what are crystalloids? Crystalloids is a solution that is of water basically with electrolytes or sugar in it. And colloids, they have larger molecules or proteins in it. Now the crystalloids can cross the vessels while the colloids remain inside the vessels. The fluid classifications, now we'll come to the fluid classifications for clinical use, starting with the crystalloids. Now we have already listened to what about the division according to the tonicity. So the crystalloids can be divided into isotonic solutions, hypotonic or hypertonic solutions. The examples of isotonic solution is 0.9% sodium chloride, lactate ringer solution, the 5% dextrose in water, which is initially isotonic, but after metabolism it becomes hypotonic. We'll discuss it at a later stage again. The hypotonic solutions include 0.45% sodium chloride, 0.3% sodium chloride, 0.2% sodium chloride, and 2.5% dextrose in water. So a few of the hypertonic solutions: 3% sodium chloride, 5% sodium chloride, 3 or 5% sodium chloride combined with dextrose in water, and 10% dextrose or higher, and mannitol. Fluid classifications for clinical use from the colloids. The colloids can be divided into naturally derived colloids, that is the albumin, which is present in the manufactured as 5% and 20%, and synthetically prepared, which are the gelatins, the HES, and the dextran. So now there are so many fluids available. So now there is a confusion which fluid to give in which patients. So let's consider at the individual level. So now the IV fluids, what happens? They primarily expand the extracellular fluid. Now only 25% remain in the intravascular after the crystalloid solution infusion. However, the colloids and albumin, they exert an oncotic pressure to retain the plasma volume. And fluid shifts depend on the tonicity and oncotic pressures. These are a few principles which will be kept in mind while giving the fluids. So this is a chart showing different types of crystalloid solution, their composition and properties. This you can remember by heart. We'll go in the next slides on the individual fluids. So coming on to 0.9% normal saline. The 0.9% normal saline contains sodium in 154 millimoles per liter and chloride in 154 millimoles per liter. So combining both these, the total osmolarity of normal saline is 308 milliosmoles per liter with a pH of 6. Now, considering the name, the normal saline, it is actually not normal because the plasma, it is a little bit higher from the plasma osmolarity, which we discussed in the beginning, that is around 285 to 295. So calling it as a normal saline is a little bit of misnomer. So what are the indications of 0.9% normal saline? It is basically used for intravascular resuscitation and salt loss replacement. For example, in cases of diarrhea and vomiting. It is the fluid of choice in diabetic ketoacidosis. It can be used in hyponatremia. And there is, for dilution of packed RBCs before transfusion and dilution of drugs. And whenever there is an increased osmolarity in the body or a hyperviscosity state, we go with this normal saline and give hydration. Now, after coming on to the indications, So it is mostly it remains in the extracellular space. If we give around 1 liter of normal saline, the around 750 ml will go into the extravascular fluid, and only 250 ml is retained in the intravascular fluid. So what does that mean? That if we have to give give it as a fluid replacement, then we have to give around 3 to 4 times the calculated loss. So what can be the complications? If we infuse large volumes, it can lead to hyperchloremic metabolic acidosis due to high sodium and chloride content. And being it a complication, it is also a relative contraindication in cases of hyper. We can after infusing sodium chloride at a higher rate, if we should take care and we should avoid. If this condition occurs, hyperchloremic metabolic acidosis, we should stop the infusion. And what are the contraindications? In cases of congestive heart failure and renal failure. Now coming on to Ringer's lactate. The Ringer's lactate is the most physiological intravenous solution with the electrolyte composition that closely matches the extracellular fluid. It contains per liter, it contains sodium 130 millimoles per liter, chloride 109 millimoles, potassium 4 millimoles, a little bit of calcium 1.5 millimoles, and most importantly, it also contains lactate around 28 millimoles. The osmolarity is around 273 and the pH is 6.5. So now what happens is the lactate that is present in Ringer's lactate, it is converted into bicarbonate in the liver. What are the indications of use? It is almost the same as deficit and intraoperative fluid losses, severe hypovolemia. But we should take care while giving Ringer lactates that because the lactate is converted into bicarbonate in the liver. So it should be avoided in cases of, liver dysfunction. It should be avoided in severe metabolic acidosis due to impaired lactate conversion, and it should not be administered with blood products because the calcium present, it binds with the citrate and it reduces the anticoagulant effect. Now the balanced salt solution. The balanced salt solution, they mimic the electrolyte concentrations and pH of human plasma, making it a suitable replacement for lost fluids and electrolytes. It is available in various formulations for different clinical needs. It contains electrolytes like sodium, potassium, magnesium, chloride, acetate, gluconate, which is almost similar to those found in human plasma. These solutions aim to restore and maintain the body's fluid and electrolyte balance, addressing the imbalances that can occur due to various conditions. Now, what are the indications? They are used to treat dehydration, electrolyte imbalance, and metabolic acidosis. It is often used in situations like burns, head injury, fractures, infections, and during surgery. The recent guidelines also suggest the use of balanced salt solution in sepsis because it leads to fewer acid-base and electrolyte imbalances or disturbances as compared to normal saline. Many studies have been conducted comparing normal saline with a balanced salt solution. However, we should be cautious that it can cause infusion site reactions like phlebitis or thrombosis. It is also important to be aware of potential drug interactions with some medications with which they may not be compatible, so it should not be used to dilute the drugs. Now, Isolite P. Isolite P is a pediatric maintenance fluid. It contains multiple electrolyte and dextrose solutions. The concentrations include sodium 26 milliequivalent per liter, potassium 20, magnesium 3, chloride 21, acetate 23, and phosphate 3. Now we'll discuss about the dextrose solutions. First of all, the 5% dextrose. What does 5% dextrose mean? 5% dextrose contains 50 gram per liter of glucose. That means it contains 5 gram of dextrose that is present in 100 ml. That is equivalent to 50 gram of dextrose in 1 liter. So if we consider it as, what will be the calories that will be given by 5% dextrose? It will be around 170 kilocalories from 50 gram, that is in the 1 liter. So what is the osmolarity? It is around 252 milliosmoles per liter and it has a pH of 4.5. It is considered electrolyte free. There is no sodium, potassium chloride or calcium or any other electrolyte present. So it maintains hydration when patients can't drink. Post-surgery, it can be used with saline to retain salt, and it can be used in hypernatremia to treat high sodium levels. So now, as it is a free water, less than 10% of fluid remains in the intravascular space, limiting its effectiveness in fluid resuscitation. The side effects include iatrogenic hyponatremia in surgical patients, hyperglycemia. It can cause incompatibility with blood, causing hemolysis. And the contraindications, they are cerebral edema, and it should be used with caution in diabetic patients after checking the blood glucose levels. The other formulations of dextrose, they are the formulations are 5% concentration. It has an osmolarity of 252 milliosmoles per liter. Then 10% concentration 505, 20% is 1010, 25% concentration is 1262 milliosmoles per liter, and you can compare it with the plasma osmolarity, that is the 290 milliosmoles per liter. Now 3% saline. 3% saline is a hypertonic saline solution. It contains 513 millimoles of per liter of sodium and 513 millimoles of chloride each. So the total osmolality is 1026. It has a pH of 5. So what are the indications of such an high hypertonic solution? It can be used to treat severe symptomatic hyponatremia, but with caution. For example, in cases of coma and seizures, but with caution, the rate should be kept in mind. It can be used for resuscitation in hypovolemic shock, but again, we have to take care that we are infusing a hypertonic solution, and we should calculate the dosing and the rate properly. So it should be administered slowly, preferably by a central venous line. Why? Because if we give it from a peripheral venous line, it will cause thrombolysis. And there is a risk of phlebitis, necrosis, and hemolysis. It should be used with caution in patients with congestive heart failure, and it should be avoided in severe renal insufficiency and edema due to sodium retention. This we have already covered. Now 5% dextrose. Sorry. Now, a few of the clinical uses and side effects of crystalloid, just a repetition. Normal saline can cause hyperchloremic metabolic acidosis risk. Ringer lactate, it should be avoided in severe liver failure. It should do not mix with blood products in the same IV line. Hypotonic solutions risk hyponatremia and cerebral edema, and hypertonic saline only in severe hyponatremia with slow correction should be given. Again, a repetition, infusing 1 liter of isotonic crystalloid results in only 250 ml of intravascular retention. To expand plasma volume by 1 liter, it will require 4 liters of isotonic crystalloid. And 5% dextrose distributes freely across all fluid compartments. It is a poor plasma volume expander. Now we'll go to the hypertonic crystalloids. The 3% and 5% normal saline are reserved for only life-threatening hyponatremia. There is a risk of central pontine myelinosis if sodium correction is done too quickly. So the sodium correction should be limited to less than 8 to 10 millimoles per liter over 24 hours. Now, what are colloids? Colloids are large molecules that remain mostly in vasculature, around more than 70%. They exert an oncotic pressure, pulling water into the plasma. What are the types of colloids? They are albumin, FFP, hydroxyethyl starch, dextrans, gelatins. These are a few examples. They should be used selectively in hypovolemia, liver disease, burns, and critical illness. So these are the molecular and the clinical properties. These you should know. Now, again a repetition, these are large macromolecules. They remain mostly intravascular by oncotic pressure. This you should remember. Smaller infused volumes compared to crystalloids are needed for volume expansion because they remain in the intravascular compartment. And the colloids are mostly reserved for selected indications. They should never be used as a first line fluid therapy. Now, most important is leakage occurs from the intravascular space when capillary permeability increases, such as in severe trauma or sepsis. Gelatinous properties of these substances, they can cause platelet dysfunction and disrupt fibrinolysis and coagulation factors, notably factor 8, leading to significant coagulopathy in large volumes. So the albumin, 4 to 5%, it can be used in cirrhosis, spontaneous bacterial peritonitis, and burns. 20% or 25% albumin, these are used after large volume paracentesis or severe hypoalbuminemia. Fresh frozen plasma, it corrects coagulopathy during bleeding. And the side effects of colloids can be anaphylaxis, pruritus, and coagulation abnormalities, as we discussed previously. So, what are the synthetic colloids? Synthetic colloids are the dextrans, that is, which have a weight of 40 to 70 kilodalton. They cause 100 to 200% volume expansion, and however, there is a risk of anaphylaxis and coagulopathy we have discussed. The hydroxyethyl starch, it is associated with nephrotoxicity and bleeding. So the usage is also restricted, and gelatins, lower molecular weight with risks of allergic reactions. Now coming on to the individual colloids, dextrans. What are dextrans? They are highly branched polysaccharide molecules. They are synthesized by bacterial enzyme dextran sucrase from leuconostoc mesenteroids. The common solutions are 6% dextrans and 10% dextran. They are primarily excreted by the kidney. They improves microcirculation flow in microsurgical reimplantation. They are used during extracorporeal circulation in cardiopulmonary bypass. The side effects, as we have discussed with all the colloids, include anaphylactic reactions, coagulation abnormalities, interference with cross-matching, and there is a potential acute renal failure it can lead to. Now, the gelatins, they are large molecular weight proteins derived from collagen hydrolysis. They are produced by thermal degradation of cattle bone gelatin. They cause 70 to 80% expansion in blood volume, used to rapidly expand intravascular volume and correct hypotension. The advantages are it is cost effective, no impact on renal function, and it does not affect coagulation. However, there is a risk of hypersensitivity and potential for anaphylactic reactions. Hydroxyethyl starch, they are derivatives of a myelopectin, a highly branched starch compound. 6% HES solutions are isooncotic. They have the same osmotic pressure as the blood. 10% HES solution are hyperoncotic. They provide a volume expansion effect about 145% of the infused volume. The volume expansion of HES, it typically lasts for 8 to 12 hours. So they are cost effective, cheaper with similar volume expansion as compared to albumin. However, the disadvantages, the can lead to coagulation abnormalities, accumulation in the body, anaphylactic reaction, renal impairment, increase amylase levels. So this is again a repetition. What are the colloid hazards and controversies? These synthetic colloids, they increase the risk of renal failure and bleeding complications. So now the albumin allergy is rare, but the cost is high. The cost and risk profile restrict widespread colloid use. Now, a few of the perioperative fluid therapy strategies we'll discuss. So, actually, minimal fluid replacement is needed preoperatively, except in children or elderly. However, we should avoid overhydration and monitor losses accurately. Intraoperative fluid needs increase due to evaporative and third space losses. So, that should also be calculated by giving the fluids. While giving fluid replacement, we should monitor the vital signs, including blood pressure, heart rate, evaluate the urine output, skin turgor, and mental status. The laboratory studies should also be considered renal function, electrolytes, and acid base status. And in some cases, advanced monitoring like CVP, SVV in high-risk surgical patients is also required. Now coming on to the special scenarios. In cirrhosis, the albumin is preferred after paracentesis to prevent renal failure. In Burns patient, we need very high fluid and albumin. In diabetic ketoacidosis or hyperosmolar states, isotonic crystalloid should be given first. Slow correction of glucose or electrolyte imbalance should be done. And cardiac or renal dysfunction, we should be cautious with fluids, avoid overload and monitor closely. While giving fluid therapy, we should also consider GI insensible losses, which occurs from the saliva, gastric fluid, the bile or the pancreas and intestine, and also by sweating. So what are the balanced fluids? That is a modern approach. The balanced solutions, they mimic plasma composition. We have already discussed. There is a less risk of hyperchloremic acidosis than with saline. And evidence is that the balance preferred for maintenance or replacement fluids when available. So a few of the key guidelines. In the perioperative period, prefer balanced crystalloids for maintenance or resuscitation. While doing resuscitation, start with isotonic crystalloids. Use blood products if there is hemorrhage. Colloids are only used for specific indications like paracentesis, hypoalbuminemia, and spontaneous bacterial peritonitis. Avoid synthetic colloids in septic shock, renal impairment, or in ICU patients. So, summary of the crystalloids versus colloids. So the intravascular retention of crystalloids is about 25% and colloids is more than 70%. The duration of effect is short, while for colloids it is around 12 to 24 hours or even more. Now, the side effects of crystalloids include edema and metabolic shifts, while colloids can cause allergy, renal dysfunction, and bleeding due to coagulation abnormalities. The crystalloids have a low cost and colloids have a higher cost. And routinely, the crystalloids are routinely used, while the colloids have no specific indications. So, advanced physiology, that is the capillary dynamics, this should also be known to you. What are Stalling forces? The Stalling forces are required for the hydrostatic pressure, which pushes fluid out and oncotic draws in. The capillary leak in the sepsis or trauma, loss of oncotic control and interstitial edema, and glycocalyx that damages glycocalyx damage alters fluid handling in critical illness. A few of the clinical decision modifiers. This is just a repetition we have already done. In renal disorders, avoid synthetic colloids in acute and chronic kidney disease. If there is liver dysfunction, use caution with lactate-containing fluids. Hypoalbuminemia also affects colloid distribution. In cardiac abnormalities, avoid volume overload and be careful with while giving fluids and with the regular monitoring. In acid-base abnormalities, balanced crystalloids are preferred in acidotic patients. For sodium abnormalities, use hypertonic saline. In sodium hyponatremia, use hypertonic saline with slow correction as indicated. So the recent trials, the SPLIT trial, the SALT-MED trial, the SMART trial, they suggest that balanced solution crystalloids may reduce renal events. Albumin benefit in sepsis remains debated, however. Synthetic colloids largely abandoned in the ICU now. Ongoing research into microcirculation and glycocalyx will play a role. So a few examples of fluid therapy. So if we have a patient of sepsis and AKI, what do? We start with balanced crystalloids and consider albumin when volumes are large. In cirrhosis and paracentesis, albumin to prevent renal dysfunction. In severe hyponatremia, hypertonic saline with slow and monitored correction. So summary and a few takeaway points. Crystalloids are the first line fluids. The balanced salt solutions are preferred. Colloids provide potent plasma expansion but limited to specific indications. Individualized fluid therapy as per patient's clinical condition should be done. Monitor fluid status, lab values, and clinical response carefully. Follow updated guidelines and evidence-based protocols. A few more take-home messages. Never use pure water intravenously due to hemolysis risk. Avoid mixing lactated ringer solution with blood products in the same line. Correct serum sodium cautiously to prevent osmotic demyelination. Reserve albumin for specific cases. Avoid synthetic colloids in kidney impairment. And always watch for iatrogenic overhydration and electrolyte imbalances. These are the references. So thank you all for your patient hearing.
Thank you, Dr. Jyoti, for a very comprehensive coverage in a very simple language. I hope the students will definitely comprehend it and benefit from this. Do we have any questions?
No, sir, there's no question as such in the chat box right now.
Okay. So what I gained from the session is that for the students, the key to understand is that IV fluids are used for everyday use. They may be used for resuscitation or for maintenance. The key to understand is the fluid kinetics across the vasculature and in the interstitium. The students need to understand the composition of the fluid and its effect on the volume expansion, electrolytes, and the pH effect, and with the coagulation system. The coagulopathy might arise. And as Dr. Jyoti rightly understood it, we have to understand for whether we are giving it for resuscitation or for maintenance. And we have to understand based on the composition and the need, the type of the fluid, the volume, how much do we need to administer, and the rate actually is to be taken into the account for providing the maximum benefit to the patients. I hope the students will definitely benefit from this. Thank you, Dr. Jyoti.
Thank you, sir. Thank you so much.
So can we have the next speaker, please?
Can we have the CV of Dr. Sonal? Please show the CV of Dr. Sonal.
Do we have Vinod Bala madam with us?
Sir, no, due to some unavoidable circumstances and personal reasons, ma'am was not able to join as a moderator.
Okay, so. Okay, so the next speaker for the session is Dr. Sonal Yadav, and she will be speaking on rapid sequence induction. So can we start the presentation, please? You are muted, Dr. Nidhi.
Dr. RM. We have a recorded session. She's
Okay, we have the slide for Dr. Sonal Yadav. Dr. Sonal Yadav is an assistant professor. Oh, it's gone. So can we start with the presentation, please?
Okay. Good afternoon, everyone. I'm Dr. Sonal. I'm giving a presentation on rapid sequence induction. Before going into the introduction, I would like to tell you what all questions you would get from RSI. You would either get a short note or you might get a short note on cricoid pressure, but it is more of practical purposes and Viva purposes. Now, what is rapid sequence induction? It is basically to control the airway rapidly, minimize risk of regurgitation and aspiration of the gastric content. A little bit of history. It was introduced in 1970 by Stepp and Suffer, and they gave an algorithm of 15 steps. And Selleck's maneuver which is also known as cricoid pressure, given in 1961. And Scoline was introduced in 1951. This is only for history purpose. Now coming to indication, what are the indications needed for RSI? It is basically done in those patients who have a high risk of reflux and aspiration of gastric content during emergency surgeries. Now, as you can see, the table I have divided into two: increased risk of regurgitation and increased risk of aspiration. People who are opposed to increased risk of regurgitation are obesity people, and people who have incompetent lower esophageal sphincter, which is seen in hiatus hernia, pregnancy, full stomach, that is inadequate fasting and delayed gastric emptying time, which is mostly seen during stress, or patients with gastroparesis, seen in diabetes mellitus, patients with gastric outlet obstruction or bowel obstruction, and patients on opioids. Also, now coming to increased risk of aspiration, that would be seen in positioning, if the patient is in lithotomy or Trendelenburg position, and impaired laryngeal reflexes, which is seen in patients who are unconscious in coma and anesthesia, and patients with neuromuscular blockage, which is seen during inadequate reversal and bulbar palsy. Now coming to the steps of RSI, here we have divided the steps into 7 Ps. That includes preparation, pre-oxygenation, physiological optimization, paralysis with induction, positioning, placement with proof, and post-intubation management. Induction of anesthesia with predetermined doses of barbiturates at the thiopentone or rapid-acting muscle relaxants are mostly used. And then we apply cricoid pressure at loss of consciousness. We avoid ventilation by bag and mask, and laryngoscopy and intubation of the trachea with cuff tube has to be done immediately or as soon as possible following fasciculations. Now coming to preparations, I have divided preparations into 4 subheadings: gastric emptying, increased gastric motility, reduction of gastric acid content, and equipments and positioning. Now coming to preparation, as we all know, we have non-invasive tool to determine gastric acid content and volume with the help of USG. And mostly we have to do the gastric emptying with the help of nasogastric tube, which we have now 2 schools of thought: people who leave the NG tube inside and people who remove. So if you are removing the NG gas tube after thorough suctioning, you can also leave it inside, but when you're leaving it inside after thorough suctioning, you have to leave the open end of the nasogastric tube. So if there is an increase in intragastric pressure, the content will be released out from the NG tube. Now coming to gastroesophageal motility, we promote gastric emptying while simultaneously enhancing LES barrier pressure. What all drugs we use? We use to 20 minutes. Other drug which can also be used is erythromycin, which is a macrolide antibiotic, which works on motilin receptors, but disadvantages: it causes nausea and may also cause stomach cramping. Now coming to reduction of gastric acid content, we have to reduce the pH of the gastric acid either by neutralizing the HCl or decreasing the gastric acid secretion itself. So for neutralization, we use 0.3 molar solution management. In reduce the pH of the gastric acid either by neutralizing the HCl or decreasing the gastric acid secretion itself. So for neutralization, we use 0.3 molar solution of sodium citrate or citric acid, but disadvantage is it increases the gastric fluid volume. Although it increases the pH, and hence injury by decreased pH is also reduced. Drugs which reduces both basal acid secretion as well as acid secretion stimulated by presence of gastrin or foods are H2 blockers and proton pump inhibitors. H2 blockers which are available are ranitidine, which we give 15 mg IV or 150 milligram orally, and it elevates the pH in 30 to 60 minutes. And it can be given by IM and per oral also, which should be given at least 60 to 90 minutes before. And proton pump inhibitors, which is used, is pantoprazole 40 milligram IV, and it starts working within 1 hour of dosing, and the effect stays up till 12 hours. Now coming to pre-oxygenation, the next P. The most important goal here in pre-oxygenation is to increase the apnea time, but to have maximum apnea time available to us during intubation. So for that, we have the goal to keep the FeTO2, that is fractional end tidal oxygen concentration, more than 0.9%, which will be seen on oxygraphy, and to have highest PO2 or to wash off nitrogen oxide, which is also known as denitrogenation. Now in this slide, you can see I've shown the techniques and the methods for pre-oxygenation. And basically, you have to do adequate pre-oxygenation to optimize O2 reservoir before induction of anesthesia, and prolonged duration of apnea after induction of anesthesia with administration of muscle relaxant. There are 4 ways which are mentioned here. Either we go with the traditional way, that is tidal volume breathing, which is done for 3 to 5 minutes with 100% of oxygen, or deep breathing, which can be done in you give 8 inspiratory capacity breaths in 60 seconds or 4 inspiratory capacity breaths over 30 seconds. Other ways are by using CPAP, that is continuous positive airway pressure, or by oxygen insufflation, or by using BiPAP. And the newer version is using Thrive. I will discuss Thrive later. Now, techniques of prolonged apnea time. Most commonly, which we use in our setup, is doing no DSAT, where you put a nasal cannula under the face mask and you increase the flow rate to 15 liters per minute, and which nearly gives 100% FiO2, facilitating our apnea oxygenation. The rationale behind this is that difference between alveolar rates of oxygen removal from lungs and carbon dioxide excretion into lungs generates a negative pressure gradient up to 20 centimeter of water that drives oxygen into lungs from nasopharyngeal to oropharyngeal reservoir. Now, the advantage of this is it is easy and very helpful technique, and it helps in removing the events like desaturation and bradycardia. Now coming to Thrive, it was introduced in 2015 by Patel and Nori, where they administered high flow humidified oxygen at 30 to 70 liters per minute with the help of HFNO. Now, Thrive can give for 3 minutes is almost equivalent to 3 minutes of face mask through tidal breaths with 10 liters of oxygen per minute. The advantage of this is Thrive extends apnea time beyond traditional apneic oxygenation techniques and improve clearance of carbon dioxide. Now coming to the another part of preparation that I mentioned, that is positioning. You have 2 ways. Either you have a head up position or a head down position. The head down tilt and full cervical spine extension is done. The advantage of cervical spine extension is that when you give Salix maneuver, it will not cause flexion. Other positioning is back up and head elevated, which is also known as Buhe position. Advantage of this is it gives us better exposure to laryngoscopy and increases the efficacy of pre-oxygenation and prolongs apnea time. I've mentioned 2 mnemonic here, SLEPT and Safari, which includes the preparations. In short, S is suction, laryngoscope, ET tube, pharmacology, and tape. For Safari, it is suctioning, airway equipments, fluid and IV access, assistant for cricoid pressure, RSI drugs, and intubation plan with a backup plan. Now coming to the induction part. In classical RSI, thiopentone used to be the induction of choice with 5 to 7 milligram per kg. But now in modified RSI, we have introduced other drugs also, that is ketamine, etomirate, propofol, and midazolam. And now the drugs, instead of giving per kg, it is given in titrated dose so that the patient is unconscious with minimum required dosing of induction agents. The advantage of that is the patient would be hemodynamically unstable, but it could also lead to underdosing, which will lead to awareness. Hence, the choice of induction depends upon patient's clinical condition. If the patient is hemodynamically unstable, we can use ketamine and etomirate. And hypertensive response can be reduced by using short-acting opioids like fentanyl. Coming to neuromuscular blockage, in traditional RSI, we used to use only scoline, and which had an advantage of spontaneous recovery, but we had chances of anaphylaxis and increased muscle tone, leading to malignant hypothermia, also causing hyperkalemia, vagal arrest, and myalgia. But now in modified, we can use rocuronium also instead of scoline. And rocuronium is given at 0.6 milligram per kg to 1.2 milligram per kg, which is the intubating dose. But only disadvantage is it does not give us spontaneous recovery if you land up in CVCI situation. So make sure you have Sugamadex in your institute before using rocuronium. And the dose for Sugamadex is 16 milligram per kg, and it reverses the effect of rocuronium within 15 to 60 seconds. Coming to cricoid pressure, short write-up on cricoid pressure. Now, cricoid pressure is the application of force to cricoid cartilage of the patient so that you can occlude the esophagus between the trachea and the cervical vertebrae. Advantage, as we know, it causes, it helps us preventing reflux of passive reflux of gastric content and aspiration. In traditional teaching, we used to give 4.4 kgs, that is 44 newtons of force, but now it is the CP can be applied lightly initially with 10 newtons and firmly at 30 newtons as soon as the patient is unconscious. As you can see it in the figure, we use thumb and index finger with the help of an assistant to give the cricoid pressure. And pressure is maintained until ET tube is placed and it has been confirmed either by endotracheal carbon dioxide availability or bilateral auscultation of the chest. As you can see here, we have two ways of giving cricoid pressure, either single hand or bimanually. Bimanually is much better because you get a better laryngoscopic view, and also the patient can, the anesthesiologist can intubate much better. At the single hand manipulation of cricoid causes flexion of neck, which impedes the laryngoscopic view. Now, this slide shows you the difference between classical RSI and modified RSI. As I mentioned before, thiopentone was used as an IV agent, but now you can use other agents also. One more important thing is positive pressure ventilation can be used in modified RSI with less than 20 centimeter water if it can be allowed. And CP is variable in modified, and you can use succinylcholine choline along with rocuronium, and opiates are also preferred as medication. A little bit of trauma RSI. Since we know in trauma, patient might have cervical spine injury, so we do manual inline stabilization before doing laryngoscopy, and high angulated laryngoscope can be used. Last but not the least, pediatric RSI. The disadvantage we have in pediatric airway is that patients, they desaturate very fast, and also they have a very high response to laryngoscopy, vagal response to laryngoscopy. So you have to be present with atropine as an adjunct at 20 microgram per kg to reduce bradycardia. And plus the dose which are required, they have to be calculated thoroughly because they require more doses compared to adult patients. These are all the presentation slides which I have. Thank you.
Thank you, Dr. Sodan, for a very comprehensive coverage. Do we have any questions?
No, sir, there are no questions in the chat box at present.
Okay. Okay, so thank you, Dr. Soda. And one thing that I would like to add is that students should, as you rightly said the short note on required pressure. The controversy is related to the required pressure. If the students add in their note whether it really compresses the esophagus or not, or if not, the esophagus directly compresses, what part that's the hypopharynx is compressed. If they add to the note, that will be beneficial for them. And overall, a very nice presentation should be beneficial to the students. Thank you so much.
Thank you, sir, for chairing the sessions and giving your insightful inputs into the presentations. We're really glad to have you with us.
Thank you so much, madam.
Can I have the CV slide of the next presentation? Dr. Shubis? Now we have with us Dr. Shubhi Singhal, who is assistant professor at ABVIMS and Dr. RML Hospital. Her achievements are she is AHA and IRC certified ACLS and BLS instructor. She has multiple book chapters, national and international publications to her credit, and she is 2003 award winner in cultural arts and literary competition. Welcome, Dr. Shubhi.
Thank you, ma'am. Thank you so much.
Can we have the presentation of Dr. Shubhi?
Good evening, everyone. I am Dr. Shubhi Singhal. Today we will discuss IV induction agents and benzodiazepines. These are not only the most commonly used anesthetic drugs in our day-to-day practice, but also very important for table viva. I have with me Dr. Rohit Dedha and Dr. Sonu Bora, both of whom are third-year postgraduate students at ABVIMS and Dr. RML Hospital. Now let's begin with Dr. Rohit. So Dr. Rohit, can you please identify and describe the drug in front of you?
Yes, ma'am. Ma'am, this is a 10 ml vial of 1% propofol. It belongs to alkyl phenol group. Chemically, it is 2,6-diisopropyl phenol, and it is milky white lipid emulsion.
Okay. What are the constituents of the commercial preparation of propofol?
Yes, ma'am. It contains, ma'am, 1% propofol, 10% soybean oil, 2.25% glycerol, 1.2% aglycetine, and preservatives. For preservatives, there are two preparations. One is diprivin and generic propofol. In diprivin, we have disodium acetate, and in generic propofol, we have sodium metabisulfite.
Okay. What is the role of these constituents which you have mentioned?
Yes, ma'am. Ma'am, for soybean oil, it acts as a lipid vehicle to carry the propofol. Glycerol, ma'am, to maintain the solution to the isotonic blood, and aglycetine, it stabilizes the propofol, soybean oil lipid droplets in the aqueous dispersion, and the preservatives to retard the microbial growth.
Yes, and actually the lipid in propofol, it serves as an excellent substrate for bacterial growth, especially E. coli and Pseudomonas aeruginosa. So that is why preservative is added. Also, while drawing propofol from the vial, we must use all aseptic measures, and the used syringes of propofol and the vials containing propofol must be discarded after 6 hours of use. Okay. Okay, coming on to the next question. What is the mechanism of action of propofol, Rohit?
Ma'am, propofol activates the GABA A receptor complex, which then increases the transmembrane chloride conductance, which then then causes the hyperpolarization of post-synaptic cell membrane and its functional inhibition of the postsynaptic neuron.
Okay. What is the induction dose of propofol?
Ma'am, for adults, induction dose is 1.5 to 2.5 mg per kg. And for children, the dose is usually higher just because it has the greater metabolism and larger volume of distribution.
Yes, and that's why the induction dose in children is around 3.5 to 4.5 milligrams per kilogram. Okay. Okay, what is the endpoint of propofol induction?
Ma'am, endpoint of propofol induction is the loss of verbal response by the patient.
Yes. So we always say that while giving propofol, always check for verbal response. Okay. This is because loss of the verbal response is a higher mental function. It is governed by the cortex, brain cortex. So when the person has loss of verbal response, it indicates that propofol has reached the cerebral cortex. And propofol being highly titrable, it is allowed to reach the cortex before we stop the drug. Okay. Next question. Why is propofol a preferred IV induction agent?
Yes, ma'am. Ma'am, propofol is preferred because it has rapid onset of action. It has rapid recovery. It has lesser CNS residual effects, and which gives the clear head recovery.
Very true. And that is why it is very much preferred for daycare anesthesia. Okay. What are the various uses of propofol with its doses?
Yes, ma'am. Ma'am, for induction of anesthesia, then for sedation. For sedation, the dose is 25 to 100 mics per kg per minute. For TIVA, the dose is 1 mg per kg bolus, then 10 mg per kg per minute for next 10 minutes, then 8 mg per kg per minute for next 10 minutes, and then 6 mg per kg per minute thereafter. It is also used as antiemetic in the dose of 10 to 15 mg bolus, and antipyretic 10 to 20 mg bolus, and also as anticonvulsant in the dose of 1 mg per kg.
Yes, and also for maintenance of anesthesia in the dose of 300 mics per kg per minute. Okay.
Yes, ma'am.
Okay. And what are the side effects of propofol?
Side effects, first of all, it causes pain on injection.
Yes.
Then it causes propofol infusion syndrome. It causes it has allergic reaction. It has abuse potential. It also have it can cause microbial growth also. That's why we use within the 6 hours of its opening the vial.
And any other very important side effect?
Ma'am, sorry, ma'am, it is cardiodepressant. That's why we have a decrease in heart rate, decrease in BP.
Okay.
And
So as you mentioned, it causes pain on injection. So what are the measures which we can use to decrease the pain on injection?
yes, ma'am. Ma'am, we can prior administration of lignocaine. We can use opioids, and we can use magnesium sulfate. We can use dexmedetomidine.
Okay. And Rohit, what is propofol infusion syndrome?
Propofol infusion syndrome, it is a cascade of clinical signs and symptoms. It happens when we use for dose of more than 4 mg per kg per minute for more than 24 hours. The symptoms are, is metabolic acidosis, the triad of hyperkalemia, hypertriglyceridemia, hepatomegaly, cardiac failure, rhabdomyolysis, and the renal failure.
So as you just described, propofol infusion syndrome is a very dreaded complication. So how can we prevent it?
Ma'am, first of all, we have to we do not have to use it for longer duration and in the larger doses. We have to we do not give propofol in the patient with the underlying mitochondrial diseases. We don't use propofol with lipids, and ma'am, we use cautiously in children and elderly, and we can concomitant use of carbohydrates as well. And we do not give propofol in the patient with the underlying sepsis.
Very good. Okay, Rohit. So I think we have covered main points regarding propofol. Now we can go on to our next IV induction agent. So Rohit, can you please identify and describe the drug in front of you?
Yes, ma'am. This is a 10 ml vial of 0.1%, 0.2% etomidate. Ma'am, it belongs to carboxylated imidazole group. Ma'am, it has 35% propylene glycol.
Okay. So is there any specific indication for using etomidate?
Yes, ma'am. Ma'am, it is used in patient with the cardiovascular diseases and refractory Cushing disease.
Very good. Why is it preferred in such patients?
Because this drug is very cardiostable.
Yes, and it has minimal effect on the sympathetic nervous system and on the baroreceptors. So that is why it is very cardiostable. And as for refractory Cushing's, because it causes adrenocortical suppression, as we'll be seeing in further questions. Okay. What is the induction dose of etomidate?
Induction dose of etomidate is 0.2 to 0.4 mg per kg.
What are the side effects of etomidate?
Side effects of etomidate are pain on injection, postoperative nausea, vomiting, myoclonus, and adrenocortical suppression.
Okay. So how does etomidate cause adrenocortical suppression?
It acts by inhibiting the enzyme 11 beta hydroxylase and 17 alpha hydroxylase, and decreases the production of cortisol and aldosterone.
Yes, so it causes dose-dependent inhibition of conversion of cholesterol to cortisol. So there is adrenocortical suppression, and this lasts for only a few hours, and it is reversible. It can be reversed by use of vitamin C. Okay, and you mentioned that it causes myoclonus, right? So how can you decrease the incidence of myoclonus with a etomidate injection?
We can give by prior administration of benzodiazepine and opioids.
Okay, so basically this myoclonus with etomidate, it is a very specific side effect of etomidate, and how it happens is that's basically the subcortical structures of the brain. They normally cause suppression of extrapyramidal activity. What etomidate does is that it disinhibits these subcortical structures. So there is imbalance between excitatory and inhibitory impulses, which results in these myoclonus. Okay. Okay, so Dr. Rohit, I think you have precisely answered all the questions very aptly. And now we can move on to our next group of drugs. So Dr. Sonu, can you please identify and describe the drug in front of you?
This is the vial of thiopentone containing 1 gram of thiopentone sodium. It is an ultra short acting barbiturate. It comes as a yellow hygroscopic powdered formulation.
So as you just mentioned, it comes in a yellow preparation. Why is this thiopentone sodium yellow in color?
Thiopentone sodium is yellow in color due to presence of sulfur molecule.
Okay. And how is this thiopentone dispensed in vials? Can you please tell me?
It is dispensed in the different percentages, that is 2.5%. We make it 2.5%. It can be available as 5% and 10% as well. Mainly we have 1 gram of, we have a preparation of 1 gram or 500 mg.
Yeah, how is it dispensed in vials? Under how it is packed, the powder in vials?
It is dispensed under the atmosphere of nitrogen, because in normal atmosphere it forms a precipitate, salt-like precipitate with carbon dioxide. Hence, it is unstable in atmosphere.
Yes, it forms acidic insoluble compound after reaction with atmospheric carbon dioxide. Okay. What is the induction dose of thiopentone, Sonu?
Induction dose of thiopentone in adults is 3 to 5 mg per kg, and in children it is 5 to 7 mg per kg.
And what is the endpoint of thiopentone induction?
Endpoint of thiopentone induction is loss of eyelash reflex.
So this loss of this eyelash reflex is a brainstem reflex, and thiopentone being a poorly titrable drug, we have to stop its induction as soon as thiopentone reaches the brainstem. That is why we check eyelash reflex in case of thiopentone. Okay. Now the next question. What is the effect of thiopentone on central nervous system?
It is a cerebroprotective drug. It causes a decrease in the cerebral blood metabolic rate of O2. O2 consumption. It decreases the cerebral metabolic rate. It decreases cerebral blood flow, hence decreasing the ICP.
Very good. And there is something which is known as reverse Steele or Robin Hood phenomena, which is seen with thiopentone. as a part of CNS effect. Can you just describe it?
Yes, ma'am. Ma'am, Robin Hood or reverse steel phenomena is a protective phenomena, which is there's redistribution of blood flow from a highly perfused areas, well perfused areas or non-ischemic areas to ischemic areas where autoregulation is impaired.
So it is a protective reflex, right?
Protective, yes, ma'am.
Yeah. What are the clinical uses of thiopentone?
It can be used as an induction agent. It decreases, it is cerebroprotective. It decreases ICP. It is given in the treatment of status epilepticus, refractory status epilepticus. It can be given in the treatment of hyperbilirubinemia and kernicterus. And it is used to verify wet epidural tap, or as well as used in narcoanalysis.
Yes. So in case of hyperbilirubinemia and kernicterus, basically thiopentone has a very good protein binding affinity to protein. So it will displace the bilirubin from the protein binding sites, albumin binding sites, and that free bilirubin will be able to excrete from the kidneys. So that mechanism is helpful in kernicterus. And as far as identifying the wet tap, so thiopentone is highly alkaline in pH. So what happens is we can identify whether the wet tap is because of CSF or local anesthetic. If it is a local anesthetic being highly acidic, it will form clumps on coming in contact with thiopentone sodium, whereas CSF is neutral at physiological pH, so it will not form any clumps. So we will be able to know that whether the tap fluid is CSF or local anesthetic. That is how it is used, okay? What are the contraindications of thiopentone?
Contraindications are ma'am, if there is a sulfur allergy in a patient, we have to avoid it. It is avoided in status asthmaticus. It is avoided in acute intermittent porphyria. It is avoided in any decompensated heart disease or myocardial depression is there, and it is avoided in shock patient.
Yes, an acute intermittent porphyria. What happens when we accidentally inject thiopentone in an artery?
When we accidentally inject thiopentone, it causes pain on injection. There is blanching of the vessels, and there is a vasoconstriction and spasm of tunica media because of the crystallization that has occurred due to differences in the pH of the blood and thiopentone. And then because of the crystallization, there is blockage of arteries, and there is a cyanosis and gangrene formation.
Yes, very good. And how will you manage this accidental intraarterial injection of thiopentone?
We will leave the needle or the catheter in situ. We will immediately flush it with 10 to 20 ml of 0.5% prilocaine. It will cause dilution and vasodilatation as well. We will give injection heparin, and we will give injection papaverine for 40 to 80 mg. And then we can consider giving a brachial plexus block or stellate ganglion block as well.
Very good, Sonu. So you have very wonderfully answered all the questions regarding thiopentone. So now we can move on to our next drug. Sonu, can you identify and describe the next drug which is in front of you?
This is the 10 ml vial of ketamine containing 500 mg of ketamine hydrochloride. This is phencyclin derivative. It comes as a clear liquid.
And what is the preservative which is used in ketamine?
The preservative used in ketamine is benzethonium chloride. It is neurotoxic. Hence, we should use a preservative-free ketamine intrathecally or when given as spinal additives.
Caudal, yes. Okay. What is the mechanism of action of ketamine?
Ma'am, it acts on the NMDA. It acts by inhibition of NMDA channels by glutamate. It decreases the presynaptic concentration of glutamate, hence causing inhibitory action.
Okay. And what is the effect of ketamine on cardiovascular system?
Ma'am, it increases the sympathetic stimulation, increasing heart rate and cardiac output in normal patients, and in catecholamine deficit patients, it causes myocardial depression and hence causing hypotension, hypovolemia.
Okay. What is the effect of ketamine on central nervous system?
On central nervous system, it increases the cerebral consumption of O2. It increases the cerebral metabolic rate. It increases the cerebral blood flow, hence increasing the ICP. Hence, it has not to be given in raise ICP patient.
And what is the dissociative anesthesia which is seen with ketamine? Can you explain it?
Dissociative anesthesia is a cataleptic state where there is profound analgesia and amnesia. The patient appears conscious and awake, but there is a continuous gaze with slow nystagmus and non-specific gaze with slow nystagmus, and the patient has open his eyes, and there is all the reflexes are intact. All the respiratory reflexes are intact.
So it is because of thalamocortical dissociation.
Dissociation.
Right? Okay. So now can you please tell me what is the effect of ketamine on respiratory system?
It has a very minimal effect on respiratory centers because all the ventilatory drives and reflexes are preserved. It can cause bronchodilation and hence increasing the lung compliance, as well as it increases secretion. So there is a risk of bronchospasm as well. So prior treatment with injection glyco is given.
What are the various routes in which ketamine is administered with its doses?
Ketamine can be given via various routes, that is intravenous, intramuscular, rectal, oral, intranasally, or we can give it at intrathecal as well. The induction doses of the IV induction doses are for 1 to 2 mg per kg. IM induction doses are 4 to 6 mg per kg. We can give it per oral by 3 to 6 mg per kg. Per rectally, it is 5 to 10 mg per kg. And intrathecally, it is 0.2 to 0.5 mg per kg with to a maximum dose of 5 to 25 mg.
So for induction, we mainly use the IV route.
IV doses.
The other routes, oral and IM, can be a part of pre-medication for which ketamine is also used. Okay. And what is emergence reaction with ketamine?
Emergence reaction with ketamine is associated with visual, auditory, and proprioceptive illusions, which may lead to delirium. And the patient has a feeling of vivid, colorful dreams and free floating outside the body.
Okay. So I'm sure this is not a very pleasant feeling. So how can we prevent it?
Ma'am, we can prevent it by pre-medication with benzodiazepines or co-administration of injection thiopenton, propofol, or our inhalational agents as well. Or we can pre-counsel the patient before administering it.
Very true. Very good, Sonu. So I think we have almost covered ketamine. And now we move on to our last class of drug, that is benzodiazepines. So Dr. Sonu, can you please classify benzodiazepines?
Benzodiazepines are classified as short-acting, intermediate-acting, and long-acting. Short-acting includes midazolam, and intermediate-acting include alprazolam and lorazepam. And in long-acting, there are diazepam and clonazepam.
Okay, and of these, which is the most commonly used benzodiazepine?
Most commonly used benzodiazepines is midazolam.
So what is so special about the physiochemical characteristics of midazolam?
It has pH dependent solubility. Hence, when we give it, when there is acidic medium, it is water soluble, and when at the physiological pH, it becomes lipids. Hence, penetration in the CNS and has rapid onset of action.
Very true. Very good. What are the different uses of midazolam?
Different uses of midazolam are it can be used in pre-medication, induction. There we can give it as conscious sedation. It is given in treatment of seizures as well, and we can give it. It can be avoided by for avoidance of post-operative nausea and vomiting.
What are the routes in which midazolam is administered along with their doses?
It can be administered same as IV intravenous, intramuscular, peroral, intranasally, and intrathecally as well.
Rectal.
Rectal as well.
Yeah. What is remimazole?
Ma'am, remimazolam is a newly introduced ultra short acting benzodiazepine. It has rapid onset of action and rapid excretion as well, because it is non-organ dependent metabolism. It is breaking down with plasma esterases. Hence, there is no side effects as such in any disease.
Yes, so for short-acting procedures where we require shorter sedation and any patient who has different organ failure or any effect on other organ systems which are dependent for excretion, so this drug can be used. Okay, so very aptly answered, Dr. Sonu. Very good. This concludes our table viva session on induction agents and benzodiazepines. I wish all the exam going postgraduate students best of luck for their upcoming examinations.
Thank you.
Thank you, ma'am.
Thank you. Hello, everyone. With this, we come to an end of day one of Appec 2025. I hope all the delegates had an enriching experience. On behalf of Team Appec, I would like to apologize for all the technical glitches that happened today and assure you that our team is working to fix it and will ensure a smoother run tomorrow onwards. The quiz question will now be displayed on your screen and WhatsApp group, which will be activated in 2 minutes. The first and second prize winners will get full fee refund. So I hope you all are excited to take the quiz. But you will have to wait till tomorrow morning because the results will be announced tomorrow morning. Also, I would like to request you to kindly fill the feedback form, which will also be displayed in your WhatsApp group. Thank you so much, everyone. We will meet tomorrow, same time in the morning. Have a pleasant evening. Thank you.